good morning to all of you and welcome to this awesome session which we always call as awesome Tapicon. What Dr. Rajesh Chokhani modestly did not mention is that the awesome acronym was coined by him. He was one of the pioneers in that. So thank you very much for that. It has really sort of inspired all of us to have this kind of conferences where we do not depend upon any other pharma company and we do it on our own, which I think should be the trend and it should be there more and more. So this particular session is on what has changed or what have been the changing trends in infections, especially post-COVID. So these are, I think, some of the things which we have noticed, all of us have noticed over the last couple of years. There have been, especially among the very small children, 4 or 5 years of age, hardly any children going out here, staying at home. All the vaccinations were delayed because they were just not great to the centers. And therefore we saw a resurgence of certain vaccine-preventable diseases. No school interaction, of course, areas to severe other problems like autism and other things, we saw an increased incidence. School reopening coincided with, of course, the lifting of the curbs, and sadly, because of cross-infection and other things maybe, we saw a severe and rampant flu epidemic. And of course, the HFMD and variants will be talked about soon. And obviously, because of less compliance, less going to the centers, we saw again lots of tuberculosis. So with this, do any of the experts want to add anything else? Any other reasons for this? Now, this is a question which I thought, just to start off, we've been hearing this immunity debt. Would you like to sort of give us an idea of what among these could be the definition and or what is it due to? Reduced cross-infection during COVID lockdowns, lifting of curbs imposed, both and none. You have your time starts now. You can see the timer on the top right. So in 15 seconds, we see the graph of the people who have voted. Alright. We see A and C. Alright. Tamu, could you give us some idea? So
actually, I think both the things are responsible, and in my opinion, like some of the increase was real because you definitely saw more infections because children didn't get their regular infections and therefore they had less immune education to say, and also then suddenly everything opened up. But I think some of the increase was also relative because normally parents are used to their children falling sick, and then in 2 years the children never fell sick. So also I think, and doctors also didn't see so many sick children. So I think some of the increase was also relative because you were not used to seeing it and suddenly you were seeing it. So I think there was both an absolute and a relative increase.
So actually, both the above would have been, I think, perfect because that's your WHO definition, both these come in because the curbs being lifted also. And it was also sort of...
Also,
yeah.
there was disruption in the regular immunization that occurred during these 2 years.
So that is another reason, yeah. So but immunity depth, the term I think includes A and B, so that is just for another keypad question. This is just in a lighter way, don't take it seriously. Every case of fever or potentially COVID, when we saw, during the infection, we are asking for more inflammatory marker tests. ICU admissions have gone up, and the D, ID specialists and rheumatologists were more in demand. So what would you put out here? All right. Anyway, the keypad tell us what's happening. that. Danya, would you like to add anything on this? They mentioned.
I'm surprised a good proportion has answered D. If that was true, I would have come in Rolls Royce, I think.
Awesome, man.
That option should have been reverted. Everyone now thinks of himself and herself as IT specialist.
In the pandemic, of course, in the case of potentially COVID,
Yeah.
during the pandemic, but that has changed now.
Thank you. Next. As soon as the question is put up, please go on to the keypad and use it. It's noticed that some people are not using the keypad. So please go ahead and use that. That will give us a better idea of what's happening, and it will also let us know that nobody is sleeping out here in the audience. Thank you.
So I just wanted to add inflammatory markers. We were never doing it.
Correct.
And now we were doing so many markers without knowing what they contain.
Absolutely.
We were trying to do things to prove whether they were right or wrong. So we were all lost. It was just the apprehension.
True. That's what probably I put that option because inflammatory markers is something which none of us do. He's very right about that. Thank you, Sridhar. So we did see some serious and complicated infections. Now I'll take a series of quick three cases which will tell us about this, and then we'll take the opinion of the experts on these cases. So the first one, this is an 11-year-old boy, and before I start, I must thank Prakash for these cases because where is he? Prakash was there? Yeah. So disclaimer is that these are his cases. So we will any difficulties anywhere, I'll point out. 11-year-old boy, fever, vomiting, cough, cold, altered sensorium since one day. The chest X-ray showed haziness on the right side. The child was intubated in the emergency room, shifted to PICU, lumbar puncture done, CSF was normal. Started on IV antibiotics after sending cultures, antivirals and symptomatic treatment. Labs initially, except for a CRP of 15.8, nothing much, the COVID was negative. So what next? What would the audience do? Continue the same management, investigate further, MP, dengue, NS1, send CSF for meningitis panel, and do a nasopharyngeal multiplex for multiplex PCR. So what would be the choice of the audience? See, none of them are having a real right or wrong answer. We just take an audience poll to see what would be the closest to what we'd like to do. Yes, I think, the experts, what would you like to mention on this? Most people have said investigate further for MP, dengue, NS1. That is the first step. Anyone?
So as a generalist, what we would do is whatever is best for the patient, whatever resources that I have, and based on that I would do it. But yes, definitely I would agree that this child requires a little bit more investigation that I would definitely do. The multiplex PSR and B, it's a question mark because you could have many things sitting in your nasopharynx and oropharynx may not be contributory, but some, yes. So quantitative, qualitative, a lot of ifs and buts on it. That sudden haziness right on day one.
So, I mean, if you look at the case now, it seems that primarily it's a central nervous system problem. And I think the intubation was not done so much for the respiratory distress, but for airway protection, if I understand that. And maybe what you're seeing on the right lung would be aspiration, because it's a child in altered sensorium. So I would think of it as a differential diagnosis for an acute febrile encephalopathy. So, in terms of malaria and dengue, we must check. The fact that his counts were normal doesn't exclude these because this is on day one. I think the child was sick for just one day. So you can have normal counts, etc. on day one. So we cannot say because there is no leukopenia, thrombocytopenia, we don't need to investigate. CSF for meningitis panel is unlikely to be very useful because there is no gliocytosis. The protein sugars are normal. So therefore, it would be, and it's an expensive test. So that's why we also tell people that you look at your CSF first. And then if your CSF is normal, then don't send this because it's unlikely to pick up things. So, I mean, at this point in time, I think ceftriaxone and acyclovir is what everybody would have started. So, maybe wait for evolution of the illness and see. And there's nothing really pointing out to a respiratory viral infection so far because we're seeing, one-sided disease. So, difficult to say at this point.
So you all agree that B is the right answer right now. So these are some of the reports. MP is clear antigen negative, dengue NS1 negative, CSF panel negative, and an nasopharyngeal multiplex PCR was done. We detected influenza A, the H3 variety. So now your comments on what you.
So I was trying to say the best of what you can or the best of what you have.
Correct.
Fine. And you should know the limitations of each test, like she was saying.
And I think a lot will also depend on what you're
Am I
seeing.
audible everywhere or there is?
Yes.
No, it will also depend on what is the epidemiology at that time. So if you are seeing a lot of cases of flu and you have this kind of normal CBC or malaria, dengue, everything is negative, would want to look for.
That makes sense. Yeah.
With such a report, with the flu report coming and with the laziness, I mean, I would also consider thinking about whether to knock off one of those medicines, acyclovir going on. So I would consider with this kind of report. So this, and of course, adding a certain amount. So it does help in some extent.
Yeah, so this is in fact just extension of what we saw right now. So how does it help? Yes, labeling the child as influenza A. Are we seeing a surge of cases, especially more severe ones, requiring ICU admissions? And what about increase? Obviously, it goes hand in hand, increase in mortality. So what is your opinion on this?
So you're controlling spread, you're containing.
Good morning, everybody. So we straight away move to the case of a 7-year-old male child presenting with high-grade fever since 2 days, occasional chills, 2 to 3 spikes per day, poorly controlled with paracetamol, complaints of throat irritation, no history of COVID contact, no family member currently febrile or recovering from febrile illness and attending school. Conscious oriented heart rate is 120 per minute, blood pressure 110 by 80. Peripheral pulses normal, CRT normal, only finding of a palatal congestion in form of erythema, no vesicles, bullae or exudates, otoscopy is normal, no skin rash, chest is clear and no meningeal signs. Now with this high-grade fever scenario, will the awesome Tapicon participants like to go in for tests? First choice A, no test, keep the patient in follow-up. B, send the basic test, a panel like we like to send in on OPD basis. Your keypad questions start. Use the keypad and wake up the person next to you if not using. Oh, the answer is So I would like to ask the experts that what is your take on high-grade fever in the first 2 days? Would you be trigger happy to send the test or would you like to keep the patient in observation? Very quick.
For a throat congestion, I would just follow up the patient.
Fine. Dr. Sridhar, we see more of these OPD things and what would you like to do?
So when you have a prodrome which is like a viral, you just keep them under observation.
Fine.
Because we do know that if you have a strep throat, it usually comes out in a big way and there is no prodromal symptoms like a running nose, a running eye. It's just a high-grade fever with painful jugular-digastric glands and endodynophagia. So I would just keep this patient under observation.
Actually, it also depends on what is happening around you. Because this throat irritation is a very non-specific symptom. So, there's no real runny nose, blocked nose, cough. There's no pharyngeal erythema. So, throat irritation is not telling you exactly that I have a respiratory localization. So, if you are seeing an outbreak of dengue around, you're seeing lots of cases of dengue because normally for pediatricians there's one infection which is going around. So based on that also you might make a decision about whether you want to test the child or wait. So it also depends on that. It also depends then whether the child is getting better by day 3 or is worsening. That may also help you make your decision.
Next. So these are the questions which have been answered by the experts. Are tests necessary? The answer is equivocal. It depends on the circumstances. And does seasonality play a part? Like Dr. Tanu has said, look around you what is happening. Definitely in monsoon time, we might be a little bit more inclined to rule out malaria, dengue and other tropical or monsoon related maladies. So what is the yield of positivity in these early tests? Do you get any? What is the your experience? Do these tests really yield anything in the early phase, first 2 days of fever, or would you like to wait more for the signs to develop and then send the test?
So I think the changes of weight in the first 1 or 2 days. That will come up by day 3.
Use the mic.
Yeah.
Next.
Madam, maybe you can repeat in the meanwhile.
In the meanwhile,
What
the
I'm
audience,
saying
if they
is
want to
that
add anything.
if we took the 4 tests, CBC, malaria, dengue, urine routine, CRP, then dengue, NS1 antigen and malarial parasite is what you are likely to get positive even on the second day. But your changes in the CBC take time to develop. Similarly, your CRP takes time to rise. So, those 2 tests help. But you never do a NS1 or a MP alone. You would always do a CBC along with it.
When you have frank respiratory symptoms in a patient, would you be keen to send the panel like for the malaria or dengue, or would you allow the respiratory to develop?
No, then definitely not. You would not do these tests because this child just had some throat irritation. There was nothing else on examination. So I said, this is an equivocal case. But if you have proper runny nose and blocked nose, you have to practice diagnostic stewardship also, not just antibiotic stewardship. You should not be sending tests if you have a clear physical diagnosis.
So this child continues to have fever on day 3. Again, continue with paracetamol, palatal erythema is persistent, no postnasal discharge, no respiratory findings, in fact no significant findings at all. No change suggestive of some BCG scar, inflammation, no lymphadenopathy, no mucosal involvement. So, keypad question to the audience is, in view of the above history and findings, there is a strong possibility of dengue, malaria, influenza-like illness or some other illness. Fever and palatal erythema, that's the only positive findings. Again, the audience is split between dengue and influenza-like illness. They have gone in for the seasonal predictability. So, what I would like to ask the experts is that whether we would think at this stage of any other illness with a continuing fever and no signs at all, apart from dengue and malaria.
So you would also think of enteric because there is just palatal erythema, which is a little non-specific thing. You would also think of other things like if there is some history of exposure to water, you would start thinking of lepto. Of course, a respiratory viral infection would be first on the cards. So you would also want to think of the other tropical infections as well.
So Dr. Dhanya, now day 3 the test would really
so
be in place.
somebody said there is no rhinitis, but you can have a respiratory viral infection without rhinitis, and in fact there was one molecular study done in South India where they took acute undifferentiated fever and they subjected that patient to molecular tests including respiratory, and they found influenza was the commonest cause of acute undifferentiated fever. So you can have influenza still coming in with high fever for 2 to 3 days without localization.
Dr. Dhanya, Dr. Sridhar, you would like to add anything?
So, the fever is ongoing, this is
This is day 3. Day 3 of it.
day 3. Day 3, again it will all depend on if the intensity is coming down, the fever or going up. If it is worsening, definitely I would be worried about some underlying focus which is not detected. So then you think of all those tests that you thought of. But otherwise, I would still continue to observe.
Dr. Sridhar, OPD dilemma, day 3 fever.
So the problem is OPD is always a problem because they want a diagnosis. And on day 1, you don't have anything. And See, that's why if you look at the throat and you find a red throat, it's either irritation, itch, that's an allergy, or it's an infection, or the big thing is IDK, I don't know. But since you're kept hinting at the red palate and fever, I don't know what's there in store for us. Let's wait and watch.
So vitals are stable, fever continues, palatal erythema is numerous now, and now the perioral rashes are seen. So day 4 shock, like happens in many of these viral prodromes with rashes coming up. No vesicles or pullae in the throat, and this is how the picture is right now. So erythematous patches on the palate, perioral lesions, high fever, early lip fissuring, tongue is normal. Conjunctiva is normal. So keypad question to the audience is, considering the new findings, do you consider there is a possibility of a hand-foot-mouth disease, Kawasaki disease, herpes simplex, or some other possibility? 7 years. Hand, foot, mouth disease. Good. So I have to say the most common culprit is the one which is most popular. But yes, I have to say this illness is revealing us to us in stages. Now we have got a facial manifestation coming.
I think your audience is.
What is your?
No, this is a typical what Kanu said, epidemiology. You don't know what's happening around you.
So definitely something is evolving. Dr. Sridhar, like with these findings in the OPD, would you be tempted to use what is evolving basically?
So I go with the audience. So I'm not going to break my head on a 2VX or anything of this.
This is definitely not Kawasaki disease. Age of the child is against it, and you don't see these kind of rashes. There's no fissuring. Their tongue is okay. So this is not. So we should not even think of doing a 2D echo.
Child is quite healthy, following up on OPD list, but this is what is now developing on day 5. These are the type of lesions which have suddenly developed overnight. You can see the lesions, and then I will ask you questions about it. So an extensive rash covering almost all parts of the body, not including the palms and soles. So the keypad question to the audience is, what type of lesions are these? Macules and papules, nodules, vesicles or bullae, all of them. When I have touched the lesions, some of the lesions have nodules also. They are hard lesions. All of them are. So this is not much of a. Since we had to have keypad questions, easier.
Maybe don't answer.
So D, all of them. Go ahead now. So are these type of lesions target lesions, and do target lesions have any significance? Dr. Dhanya?
Don't look, just one lesion has some necrotic area, but I don't think this overall like target lesions. Target lesions have a dusky center with a peripheral halo, but
Like the erythema, so it's almost like a bullseye.
Now the most important question, the child's fever has reduced, and now only the last problem, that is the rash, is remaining. Now the parents have a question, will the recovering lesions leave behind the scar? Okay, so you can see many of the lesions which are in the recovering phase, but the skin is denuded. So the keypad question to the audience is, when does the skin lesion not leave behind the scar? A is epidermis damage, B is dermis damage, C is subdermal damage.
Answer was A. I think all of you had mentioned A, that is epidermis. So in the epidermis, obviously, did not give us that.
I just wanted to make a comment here about hand-foot-mouth disease. In this season, we have seen children getting recurrent hand-foot-mouth. We have seen atypical presentations of hand-foot-mouth where the lesions are extending to trunk, axilla. Just for information, in Navi Mumbai, we conducted an outbreak investigation with the help of ICMR and NID, and we found that the strains responsible for this outbreak were Coxsackie A6 and A16. Now, there were children getting repeated attacks. Probably there was very little cross immunity against the second infecting virus. That is why the explanation of the repeated hand-foot-mouth in the same season. And why the atypical presentation, Coxsackie A6 is known to cause in areas other than the peripheral hands and feet. So, in fact, the ICMR is conducting a national-wide survey after the tomato fever, panic. So, what they found is that it was in Mumbai and Navi Mumbai area that they see more of these Coxsackie A6 etiology compared to other states. That is why it was perplexing during this season why in hand-foot-mouth we are having extensions to trunk.
So on a general note, enteroviral infections are increasing. And in fact, the worry is that hand-foot-mouth caused by enterovirus 71 is a very dangerous illness in Southeast Asia where it can cause encephalitis and all. And because you're eradicating polioviruses, these enteroviruses are taking the niche. So the epidemic of hand-foot-mouth that we saw was not just related to children not going to school for 2 days, 2 years, or not getting infections. It was because there was a new strain circulating. And we have to watch very carefully whether we are going to see more and more virulent forms of HFMD in the following years.
Is any topical treatment indicated in this type of denuded lesions?
We were just giving them lactocalamine.
Question to the audience is that did the delegates find any increase in the rash-related illnesses in start of schools? Increase to some extent, increase to a great extent, epidemic proportion, or no change? Increase to a great extent. Yes, sir, you can re-poll if you want. Increase to a great extent and almost an epidemic proportion in people who have got very heavy OPDs. So this question again, the answer would be, when does the skin lesion not leave behind the scar? The answer would be, okay. The secondary complications expected in such type of rashes are any of these possible? Fever and bacteremia, necrotizing fasciitis, toxic shock syndrome, because you can see a clustering of lesions coming together and forming necrotic patches. Is any of these possible?
None of them.
Any of the above is possible is the most is the highest rated answer, and fever and bacteremia. I would like to ask the experts if any of these is really possible or commonly seen.
It is theoretically possible, but we didn't see in practical experience, because in chickenpox you do see secondary bacterial infections, you see necrotizing fasciitis, but at least in this epidemic of hand-foot-mouth, maybe apart from 1 or 2 cases, we didn't see a secondary bacterial infection happening. And also there is no role of giving acyclovir for these patients because it was commonly prescribed. Acyclovir works for DNA viruses, this was an RNA virus. And there was a question about whether this is, when initially the patient came, whether this was herpes simplex. Because in herpes simplex also you have throat lesions and lip lesions, but one must remember that if it is primary herpetic gingivostomatitis, you only have lesions in the throat. Whereas herpes, recurrent herpes comes with perilabial lesions. So, therefore, if both of them are present simultaneously, HSV is less likely. So,
and one classical thing is mucocutaneous junction gets involved in herpes.
Dr. Dhanya, is overgrowth with the staphylococcus or streptococcus possible in such large scale lesions in the lymph phase?
In those 74 children we studied, 2 children had secondary infections but they were impetigo. We have not seen severe bacteremia secondary bacteria. But theoretically, as Madam said, if the child is immune compromised, things can change. But fortunately, not much of secondary infection with happening.
Dr. Sridhar, many of the parents
So the atopic ones get extensive lesions. And there you could have a predilection to staph because there is an association with staph. But all this is theory. At least in my practice, whatever, we never had any such complications.
and
What she was stressing upon, Tanu, is there was a lot of articles on ibuprofen, chickenpox, and necrotizing fasciitis and bad skin lesions.
last question is to you, Dr. Sridhar. The parents' query now would be: would these scars and pigmentation be long lasting, or what do you expect out of the outcome?
You could have hyperpigmentation or hypopigmentation because that is melanin deposition.
Do you take
Or
any
no.
therapeutic measures for it, or you just leave it alone?
Just leave it alone. Okay.
Dr. Praveen, 10 minutes left for your.
I have already completed before time. I take those 10 for the next case.
Actually, I expected some monkeypox question would come with these.
Yeah, you can.
Please let us know. But they would be associated with
So monkeypox fortunately has died out. There was a lot of talk when we were seeing HFMD and chickenpox, but these are the two important differentials of monkeypox: the chickenpox and HFMD. But in monkeypox, generally lymphadenopathy is a very important manifestation. So you have fever, and then you have lymphadenopathy, which is absent in both chickenpox and in HFMD. Then the lesions, they usually take a long time to progress, over 2 to 3 weeks, and then there is scarring which is left at the end. With chickenpox, how do you differentiate? Because chickenpox is more truncal, whereas monkeypox is more peripheral. And in chickenpox, you see multiple lesions of the same morphology at one time, whereas in monkeypox, you usually have papules which then go to nodules, vesicles, and then nodules, etc. So, but I mean, yes, when that epidemic was going on, there were a couple of cases of chickenpox which were referred to us as whether they have monkeypox. But yes. So painful, yeah, and they take a long time to progress, and adenopathy is an important point.
Chickenpox is always with an age. What is significant?
One last time. The full term 46 AGA born to a mother by non-consanguineous marriage, brought by relative on day of life with high grade fever, not accepting pills, irritability, and yellowish discoloration of skin. Antenatal history: she is a 32-year G2 fever L1 antenatal register. History of PIH or UHG scan analysis was normal. Mother had a fever 5 days prior to delivery, and her COVID RT-PCR was negative. No history of any PV leaking or any signs of urinary tract infection. At delivery, LSCS was done in view of PIH. Abgar birth weight was 3 kgs and discharged on exclusive breastfeeds. On admission in NICU, baby had fever, extreme irritability, excessive cry touching the baby. The baby was not letting us handle the baby. Mottling was present, tachycardia was there, peripheral pulses were feeble, BP was 35 mmHg, weight was 2.6 kgs with 13.3% weight loss, and front end was bulging. So the key part question is: inconsolable crying in a 5-day-old newborn could be mostly due to meningeal irritation, birth injuries, faulty feeding practices, or we'll have to investigate. For the audience,
Obviously.
in this patient. In this patient. Experts or from audience. The baby had come with fever and irritability and bulging eggs. So cause of meningitis also. early onset secondary meningitis.
Obviously, you would think of neonatal sepsis with meningitis as the first differential, and birth injury or surgical wouldn't explain the fever in this patient. Faulty feeding practice can explain the weight loss, maybe a little bit of the fever. You can have dehydration fever, but you can't have a bulging fountain. So, neonatal sepsis and meningitis.
First is early onset sepsis. On admission,
So that paradoxical crying, that is usually, it's soothing when you pick up a crying baby. But when you have paradoxical crying, in the neonatal period, one condition, not this age group at least, but the staphylococcal skin scarlet syndrome, the beginning. It's an extremely tender skin, just like in Kawasaki. When you have vasculitis, the skin is very tender, and you have paradoxical. I just wanted to add that.
as I said, the baby was not letting us handle. It was totally inconsolable, right? On admission, the investigation significant platelet was 1 lakh, CRP was 11.6, sodium was 150, oxygen was started, IV fluids, inotropic support, and piperacillin tazobactam was started.
Let us know the differential, the TLC. What's the differential?
So counts was 10,000 with no band cells or nothing. 7,500.
Just go to the previous slide.
And it was not neutrophilic nor band cells were present, and baby was having a little bit of rash also that time, and mild edema. And other than that, other than the platelet count and high CRP of 11.6 and sodium of 50, nothing was significant. We had some blood cultures.
We have to first decide whether the septic screen is positive or not. So I mean the CRP is more than 10, so one criteria is met. But we have to, there are no band cells, and is the absolute neutrophil count less than 1800 or something. So I mean just a point for the audience that we should not just look at the TLC, we should really look at the DLC in this patient.
In this case, only thrombocytopenia and CRP was positive.
Yeah, just one more point for the audience. Piperacillin tazobactam are not good for a CNS infection. Piperacillin tazobactam, 64 milligrams of sodium per gram. So if you have a sodium of 150, and you're going to cause more of sodium and less of potassium, I don't think it's a problem. Just for the audience.
Baby continued to be irritable and was having hair spikes. Baby developed generalized rash, edema, CSF and neurosoma were present, which was normal. There was nothing abnormal in the CSF, nor in the UAG skull. Platelets after 48 hours, which was repeated, was 81,000. We had continued the same management. We started the baby on RT feeds and we continued antibiotics. The repeat platelet count after 48 hours, as day 9, 10 of life, was 17,000. So key pad question, what should we do in this situation? Step up the antibiotics, IV immunoglobulins, administer platelets, or all of them. And the time starts now. Okay.
We should make a diagnosis because we can't make a diagnosis. We don't know what is happening because obviously this baby is not behaving like a neonatal sepsis, meningitis because your blood cultures I guess must be negative and your CSF is also normal and you have a rash developing and you have a back with thrombocytopenia and you have the mother who had a febrile illness. So at that time when the COVID PCR was done for her, was a CBC or something else done?
Baby was investigated in view of post-COVID, means inflammatory markers,
No. That mother didn't have COVID. We know that because the COVID PCR was negative. But was she evaluated for dengue, chikungunya, anything else?
She was asked retrospectively, I'll come to that. Other than fever, she had not given any history till this diagnosis.
Yeah, so I mean, none of these things are, I will do none of the above. Step up the antibiotics, definitely not because we have not proven an infection. IV immunoglobulin, like why we give immunoglobulin because we don't have a diagnosis. Administer platelets, again the cutoff I think for giving platelets would be 10,000 or something. So that
Fake newborn
20,000.
Newborn 17,000.
Thrombocytopenia and decreasing platelet will not increase antibiotics. Thinking of platelet still get the diagnosis.
But it's not behaving like sepsis meningitis because there's so many points. Your cultures are negative, your septic screen was actually also negative. You can't have a drop in platelets to 17,000 because of newborn sepsis with negative cultures, and you have a rash and edema. You haven't shown a picture of the baby.
Yes.
I agree with ma'am that I would probably rush to the gynec ward to look at the mother's file. What exactly she had.
Mother had a fever 5 days prior to delivery.
Good, you are listening. That's
So regard
when you have such a wonderful expert, talk with none of the above. That is what we understand.
regarding stepping antibiotics will not safe for antibiotics. Immunoglobulins is the criteria for increasing platelet count.
No, but that you would do
So if it is sepsis, what are the criteria for doing immunoglobulins?
So there is definitely IV immunoglobulin has no value in neonatal sepsis. There's a Cochrane review on that as well. And here we are not even bacterial sepsis now. We are not thinking of. We are more thinking of some viral infection. Role of immunoglobulin unless you have shown that there is HLH or something.
And regarding administration of platelets, because a lot of people, babies come, they are already received platelets.
Yeah, so I mean, I would leave that decision to the neonatologist, if they want to give. But my focus would be that to make a diagnosis here.
Can we ask a question from the neonate, what are the actual criteria for transfusing platelets? We can understand the platelet bleeding that she said, but there has to be some sort
Then please ask the neonatologist.
I think less than 10,000 with bleeding, less than 10,000 with bleeding, which what is I follow. But it may be unit specific. Sometimes
In neonate they say less than 50,000 if there is bleeding.
Yeah.
20,000 with bleeding. If the baby is bleeding, you need to give. Otherwise, they
No,
have
let's get 50,000 and bleeding.
bleeding.
If
That's
there's
right.
bleeding less than 50,000, you have
If
to.
it is 10,000 or so and there is no bleeding, I am not giving. And regarding antibiotics.
Yeah, so the point I think is both together. We will look at platelets as well as bleeding. There is only 50,000 or 40,000 platelets and no bleeding. I don't think you will do it.
I think there are some guidelines, but latest I don't know. I think
It is 20,000. It is 20,000.
And giving platelets is not a thing without harm. Like in dengue, there are RCT which has shown that people who are below 20,000 platelets, if you give platelets, you have more side effects than people who are not given platelets in the form of trali and so many other things. So it's not not an intervention without harm.
Madam,
I would also probably maybe look at the immature platelet fraction and other things which would tell me that are the platelet counts going to improve in your future. Maybe that is something which I would look at.
giving immunoglobulins, does it change the course of antibiotics, the days of antibiotics? So there are a lot of studies, if you go immunoglobulins, the amount of antibiotics, days of antibiotics you can come down.
No, there is nothing like that. There's standard guidelines. Culture positive newborn sepsis, 14 days you have to give. I mean, people have looked at giving at 10 days, but that is in no way determined by the immunoglobulin. You are going to give immunoglobulin, if at all, in newborns, in very, very sick newborns with severe overwhelming sepsis. So you will not look at that in terms of reducing your duration. You will not use it for that purpose.
So antibiotics were stepped up and IV immunoglobulins were given in view of sepsis and thrombocytopenia. Platelets after 48 hours was 31,000. On day 12 of life, baby started developing hyperpigmented rashes over the face. This is the baby. So hyperpigmentation over face and all over body in newborn. It will be sepsis, congenital lupus, drug rash or other infections. And the time starts now. Alright, knowledge about anything about congenital lupus? presence of rash and other things will. I have not seen much cases of congenital lupus. Presentation of rash.
Fever, and it is a very acute presentation with high fever. So that's odd. And the mother, I mean, the fact that the mother was conceived and all is also something that she must not have had lupus or something. So I mean, I would think of an infection. First cause of fever in any child is actually an infection, and we should think of non-infectious etiologies later, especially when and everything is pointing towards viral infection in this child. That is why I felt that we should have looked at the CBC carefully the first time. And we always ignore it, but look at the lymphocyte percentage, which anyway will be high in a newborn. Look at monocyte percentage. Ask your hematologist to look at the peripheral smear to see if they are reactive or atypical lymphocytes. And those will give you a clue that you're dealing with a viral, not a bacterial infection.
Any drugs causing rashes, which we commonly use. Because this type of rashes is commonly seen imipenem and meropenem. That's what I went to the literature.
So, but I mean, you know,
Just for discussion, this
yeah.
case will be.
So, I mean, here we have not been able to make a diagnosis. So, I would think that the rash and the fever are related and both are due to, I mean, they are due to some common cause rather than thinking that the fever is something else and the rash has come because of the drug.
Drug rash are usually morbidly formed. They are not like this. This is hyperpigmented. Even lupus. Lupus doesn't come like this. It's almost like
Lupus are in the both
big glasses.
eyes and mostly present at birth only.
So this, which is centrofacial, usually
Perioral and
chick side. And this is not only seen in chikungunya, you can get it with COVID also. It's called the COVID nose, the dengue nose, the chikungunya nose, the chick nose.
If the dengue you get like this, right?
Brownie nose.
Brownie.
So COVID, dengue, chikungunya, they all can come like this. And it's basically because you have a melanocyte which is linked to about 10 keratinocytes. That's the unit. There is a transfer of melanin and suddenly there is a stop in that transfer. So that is why there is accumulation, very follicular. But here it is extensive.
Dengue will get like this type of rash.
No, it's all in the nose. It's all in the nose. Here it's centrofacial.
You can get a bullous disease also in chikungunya. You can have chikungunya rash which can present as a generalized bullous. I remember Dr. Prakash Vaidya had presented one case of neonatal chikungunya which had bullous rash.
I think Bhavesh had presented one wherein you literally have after ulceration.
So, in view of maternal fever and rash, thrombocytopenia, striking hyperpigmentation, particularly on the face, fever in newborn, mother was investigated for chikungunya and her RT blood PCR came positive.
Yeah, but again the point here, I mean it's difficult to believe that now the mother's chikungunya PCR is positive because she had it 5 days before delivery and this baby is already 12 days old now. So 17 days have passed. So I would have actually done the PCR in the baby.
No, we didn't do the PCR because the mother retrospectively told that she had fever with joining pains, which she never revealed because she was worried that all will start blaming her. That's a common thing. And IgM. The PCR I think comes positive the first 5 days and IgM after 5 days to 7 days. After that I think IgG is to be seen. Maybe clinically improved, starting improving, fever subsided, platelet counts increased 1.2 lakhs, baby's culture showed no growth, baby clinically improved, started feeding side, fever discharged. For experts, how common is vertical transmission of chikungunya, the complications and any long-term neurological effects, and how do we follow these babies?
Vertical transmission is known. I wouldn't say it is very rare, but it is not very common, but it is known. Complications, neurological complications are very well known in neonatal chikungunya, and unfortunately a large percentage, even up to 50%, can have some form of neurological, neurocognitive, developmental issues. The other complications that you can have in chikungunya are even neuropathies. I don't know for such a young infant how that. Basically, these things should be kept in mind. And sometimes they have even tenosynovitis. They can even come with a fixed contraction. So these babies really need follow-up.
Mostly, I think what I read, most commonly is congenital transfer. Acquired is very less. to 80% is lining during true placenta, transplacenta.
Around delivery.
Around delivery. So take home message: history taking of mother and clinical examination important. Culture negative sepsis, always think of other diagnosis. Congenital chikungunya, fever, thrombocytopenia in 90% of the cases. Is hyperglycia, hyperalgesia syndrome when the baby is inconsolable, trying to touch, not allowing us to examine. Irritability or lethargy and typical hyperpigmented rash which starts on the face and moves in patchy way all over the body.
I think this point about hyperalgesia is very important. Normally, as you see mentioned, if a child should be consolated. The child is not being consolated, and is actually crying more when you handle the child. I think that's a very important point here. Because all the other things will come up later on. Rash will come up later on.
20 minutes left for the first session.
Thanks, Bhavta. Thanks, Anand. That was really wonderful. So we are all living through COVID times, and 20 years down the line, there might be a film. Once upon a time, there was COVID, and all these cases have come through in these difficult times which we faced, and made them all the more interesting. But at that time, sometimes the patients also suffered a lot because of certain factors. So here, in case of a 9-year-old female child weighing 30 kilos comes with chest pain, deteriorating general health, weakness, increasing breathlessness since 2 weeks, fever on and off since 3 months, dry cough since many weeks. She was extremely weak, unable to get up even from the sleeping position, appeared to be in intense pain, tachypnea, had fever, heart rate was 120 per minute, respiratory rate was 36 per minute, blood pressure was on the lower side, JVP was raised, facial and pedal edema, pitting on pressure, weak, thready pulse, pulsations were feeble, first and second heart sounds were distantly heard, and abdominal distension was present. Abdomen was doughy with a 3 centimeter little tender hepatomegaly. Past history: the child experienced fever in the month of April 22, 2 to 3 spikes with breathlessness, was sick for a few days, investigated, and various investigations were done, including X-ray, CT scan. X-ray revealed pleural effusions bilaterally, CT scan revealed moderate pericardial effusion with enlarged mediastinal and peritoneal lymph nodes. This was done 6 months back. Pleural effusion, which was bilateral, right greater than left. Pleural effusion was tapped at that time, and child was started on first line ED. We had sketchy report of the pleural tapping, and whatever details we had, I have put up. AFB was not detected, and total count was 1440 with lymphocytic predominance, and child was started on first line AKT as told before. Further progress on AKT did wait for a few days. Medical compliance was poor, and in between, after symptomatic relief, AKT was discontinued by parents. Then continued for a few days again. Then the parents got opinions from family and friends to discontinue AKT because those times the general people were telling us, doctors, how to treat COVID. That was a different time altogether. So they also got the opinion that this is nothing but COVID and you are being taken for a ride. I'm really telling you the facts. And continuing intermittent fever. So the keypad question to the audience based on the previous history is that the diagnosis of tuberculosis in the previous investigations is confirmed, not confirmed but likely, and another differential is possible. The time starts now. Choice of B, not confirmed but likely. Yes, we face this situation very commonly where we don't have a complete diagnosis in hand, but we strongly feel that that is the diagnosis.
Dr. Praveen, the 11% who have confirmed the diagnosis of TB, we really need to know how.
I think I put the
Please correlate clinically.
So what question you asked, keypad question, next keypad question is a corollary to that. Is it justified to start AKT with CT scan findings at total fluid report? Your time starts now.
अभी चेंज हो जाएगा.
11 लोग भी नहीं बन
There is a big change. Okay, so what happens nowadays? We can change sides. More powerful. So history after stopping AKT. So this story continued and view of the increasing symptoms child deteriorated again. Yeah.
As the experts, what they would have done
Yeah.
in this situation, they start taking Acha, you want
Actually,
to
go ask me the question. The common theory here many times,
We had two polls which showed almost like similar questions, but two times the people answered differently. So it's not a very easy call to take. With view of only the CT findings and the pleural tap report, which doesn't reveal us any particular diagnosis as such, we know it can be tuberculosis. Would you be keen to start a AKT in such situation?
So there are two differentials. One is tuberculosis and the other is lupus. Because this is a 9-year-old kid coming with a female girl, bilateral pleural pericardial effusions. So that should also be considered, but that is a much lesser likelihood. The more likely diagnosis is TB. And although they did not do a expert in the pleural fluid, but many times the expert, even if you do, it comes negative because the pickup is only 10 to 20%. So what I would have done in this patient is that I would have one, looked at the white cell count, platelets, ESR and all C3 carefully to just make sure that I'm not missing the diagnosis of lupus. Second, I would have definitely sent the pleural fluid for gene expert and TB culture. And then, if I have lupus ruled out and my expert is negative, and it's not possible to do a biopsy, either a pleural biopsy or a mediastinal node biopsy, I would have started anti-TB drugs. But the important point here is that if the patient has pericardial effusion, then you are also have to start steroids because you want to prevent pericardial constriction. That is a little bit dicey because if you don't have a confirmed diagnosis and you start AKT and steroids, how will you know whether the patient is really improving and whether that improvement is because of the steroids or AKT is difficult. That is the downside for empiric AKT in this setting because even if it is drug resistant TB and you start steroids, you miss the diagnosis. So when you have to start steroids, then you have to be more, you have to make more efforts to try and make a diagnosis. So definitely we should have done a gastric lavage because your pickup in the gastric lavage is higher than the pleural fluid.
No, one more thing is that the previous CT scan, the first, showed adenopathy, significant adenopathy with pleural effusion, which is odd finding. And in such a child, we would have done a kind of trying to get a biopsy.
Other thing is whether you could be dealing with a lymphoma because you're starting steroids. So again, the pleural fluid cytology is important, and of course, you would have checked whether that CT is showing contrast or not. Whether there is contrast enhancement, whether there is necrosis, and you would have carefully looked for supraclavicular nodes, which if you find them, then it would have been easy to biopsy. So I'm saying in this patient, you would have made more than normal efforts to try and reach a microbiologic diagnosis.
So, how often one would see a deteriorating health in a multiple polycirrhosis due to TB?
I mean, you can see because this patient may obviously has adenopathy also, and we often find patients who have extrapulmonary TB with deteriorated health without lung involvement. So, I mean, she's been ill for 3 to 4 months. That may be the reason.
But hypersensitivity reaction is not a child who is deteriorating in health.
But earlier they used to believe that pleural effusion is because of a hypersensitivity reaction and therefore you will always get a positive MAN2. But now we know that there are many patients with a pleural effusion who may not have a positive MAN2 also.
That's a different reason. I think there have been some theories about compartmentalization of T lymphocytes, and that's why the Montox is negative. And repeat Monto after 2 to 3 months is often positive, I think.
Yeah, but I mean, I would not exclude the diagnosis of TB. See, another thing which is odd for TB is bilateral pleural effusion, because normally in TB you get unilateral pleural effusion, and if there is bilateral, you would also think of Sogia or lupus and other things. But given the 3 differentials of multiple lymphoma and TB. I mean, to me, I would rank TB as first possibility, but I would try and make more efforts.
Dr. Dhanya, in this case, the pericardial effusion was there for the sick. Initially, this child was managed through by the adult physician, so they had started steroids. That explains the initial improvement that she showed before the treatment became erratic. Would pericardial effusion in the first time itself, at the time the child presented, would have been the proper choice? Because finally it is going to cause trouble.
Proper choice for what?
For the diagnostic part.
Diagnostic part, pericardial effusion, right?
Sorry, not pericardial.
Yeah, we had a similar child with pericardial effusion in failure, a very sick child, for which we went aggressively to find out the microbiological diagnosis. And I would quite agree that in the era of drug resistance, you should try to see as far as possible with the available facilities, go ahead, because in our child, after doing the pericardectomy, the pericardial fluid showed XDR-TB. If we hadn't done that test, it would have been very difficult to manage that child. The child is well now, but if we hadn't done the culture of the pericardial fluid, I don't know how we could have managed the treatment after that. So aggressiveness, yes, to a certain extent, but when you have pleural fluid, again, the confirmatory as per our program is if you have a pleural fluid biopsy which is positive or gene expert positive. But gene expert sensitivity is very low. Now pleural biopsy, I don't know, even at Apollo, we don't have the expertise. I don't know where it is that we do it.
Just to say that even if you have pericard, like whether sampling, I think your question was that whether we should have sampled the pericardium instead of the pleura. So the pickup is the same. So the expert positivity in the pleural fluid and the pericardial fluid is the same. And pleural fluid is more easy to sample. So if my pleural fluid is not giving me a diagnosis, then I would go to the nodes. I would not, unless of course the pericardial effusion needs tapping because the patient is in pericardial tamponade, I would probably sample the nodes because the pickup would be higher from there.
Can I make a comment?
Dr. Sridhar.
Can I make a comment?
Please.
So I would completely agree with the panelists that we should have gone all out to come to a microbiological diagnosis, which always is the case, but more so in this post-COVID era. We are seeing TB now in a different kind of presentation. So in the last couple of months, we're seeing TB without fever and just only lymphadenopathy. We are seeing resistant TB, and the amount of TB that we are seeing has generally gone up a lot with very abnormal presentations. So the book picture, 2 weeks of fever with cough, with weight loss, sometimes is not seen, and I would definitely, and pleural biopsy is a very easy thing to do. So I think we all should go ahead to develop that expertise. It really doesn't take much to do a pleural biopsy. So I would 100% agree with what they are saying. I would think of TB in all unusual presentations like this in today's scenario.
My question to Dr. Sridhar is that therapeutic and the prognostic wise, this pericardial effusion is going to lead to some consequences. Whether you start on whether it is a tuberculosis or autoimmune illness, whether this fluid could have been left alone at this point of time or required a drainage.
You have to go in because he was already compromised. You can't allow it to go into constrictive pericarditis later on. So you have to do a tap. And I think there are centers where they even take a pericardial biopsy. Tissue diagnosis is a must. Like she said, tissue diagnosis along with a culture so that you know where you stand and you don't waste time.
She was in shock, right, Praveen? He was in shock. He was
Yes. Weak, ready pulse, but pulsations were well fed. They were fed. Ready pulse.
This is, I think the first time when she presented with a pleural pericardial effusion, she was not having constriction. The first time when they did a pleural tap.
She was having moderate pericardial effusion.
Even that.
Moderate. So when she's now, the child is referred
Now
to.
you will have to do it because she's in tempo now with her.
So some changes in the second CT scan also have revealed a hilar and supraclavicular lymph nodes are present and referred to our center for further management. Now we are in the hot seat and the plan of action for this patient from our side would be the keypad. The audience can help me with this. Start
4-drug EKT and watch the response. Second choice would be pericardial and pleural tapping and analysis. C is try to achieve tissue diagnosis with biopsy. Yes, the audience really wants to go the whole hog and try for the tissue diagnosis, but I have got a better sampling here, pericardial and pleural, which would be much easier than going inside the chest with some type of exotic procedure. So they were not really valuable. So that's how they were there, but
Scan guided biopsy.
correct. So the correct choice would have been to go for both. Here we were constrained a little bit with the cost factor and all that, so we decided to go with first the pleural effusion and simultaneously the same day we did the pericardial tapping and we that focus on the. But so X-ray findings were of a large pleural effusion on right side, lesser pleural effusion left side with infiltrates corresponding to the CT picture. 2D echo report showed a large pericardial effusion now. Shaggy exudates with strands. It was very evident on the echo. They predicted it would be a very difficult thing to handle, and signs of developing constriction. So what we did was that we went in for the pleural tapping as well as the pericardial tapping. I'd like to see whether I can show you this video where you can see we are entering with a pigtail catheter because we know that this can be loculated and very thick to drain. And it was almost thought that we should go in for a streptokinase to release if the thick fluid doesn't drain out. So this was the strategy thought out, but luckily we were able to drain out the fluid. So this is not the pericardial, this is the pleural tapping which we did first to symptomatically relieve the child. And typical straw colored fluid with a protein of 2.5, cell count of 1150 with a lymphocytic predominance with an ADA of 9.9.
Last 5 minutes.
Pericardial fluid appearance was that of a thick apple jelly appearance, turbid, and we sent the gene expert for this patient. And the report was that in the pericardial fluid, we could see that the target was detected and the inflammation resistance was detected in the target, and the routine could not be performed. It was quite a fluid, thick fluid which was seen. So now we have at least one type of body tissue telling us that it is detected and it is showing resistance. So now the question arises how to treat this child. Of course, steroids will be started again with the AKT, but help me out with the choice which we would make in this patient. Start first line AKT, awaiting the AFP culture and sensitivity. Add the second line drugs and stop the first line AKT. Continue the first line AKT and add the second line drugs. And for the additional tissue biopsy will be required before starting second line drugs. The audience is divided and the experts can see the answers of the audience, and I asked Dr. Tadu to start with her opinion on this.
This is confirmed MDR TB. So you have to add second line drugs and stop first line inhibitors. There's no other thing because the problem would have come if your rifampicin resistance was indeterminate. Fortunately, it is not. So if you have in Mumbai, if you have even the first PCR which shows that you have drug resistance and you have a prior history of incompliance, then you have to take it like that and you have to start second line drugs.
Dr. Kalya, what would you like to start in terms of treatment?
The MDR regimen that we have now, it's no longer under the private sector, it's with the program, the drugs that are available. So now we just refer to the program. I think you have the center in your hospital, yes?
But now what you do is put on a
and bedaquiline and delamine both are not available for us for management. So we send the patient to the national program.
So the first line gets stopped as soon as you get the RIF resistance detected. That's the point we wanted to know very clearly today. And Dr. Sridhar, what happens when such a patient is there with you? Do you continue treatment with you, or do you refer generally to a government center so the better drugs can be had?
It's totally with the government center, because they provide the drugs, they do the follow-up, and they do a good job. There is total screening, everything is done very well. The only thing is you need to understand that drug interactions are plenty. So anybody on a AKT, be it first line, second line, you should know all the interactions. Rifampicin is an inducer, Axonex is an inhibitor, Bedaquiline of the heart. You need to know all the signs.
Dr. Thane, quickly the exact second line drugs which you would like to use in these patients.
So as I said, now it's a standard regime, at least in Mumbai, where they give levoflox, bedaquiline, clofazimine, cycloserine, linezolid and pyridoxine.
So that's quite a big list to remember.
Yeah, because now we have moved away from injectables, and it's an all-oral regime. And now in JJ Hospital, Dr. Sushant Mane, he is treating a lot of these small kids also who are below the age of 1 year also with bedaquiline and delominate. So now you can use it across all ages.
Last is a keypad question. With the advent of new generation tests, the basic tests like which we used to do previously for tuberculosis have become obsolete. A is true, B is false. False. So I feel the basic, we should start always with the basics and then end up where the technology allows us to. Dr. Thane?
No, but I would say in this list now it's only the test X-ray which is really important. CBC, ESR is of no value. You can have TB with a normal ESR and you can have a high ESR without TB, so that goes out. It's not a screening test, it's not a follow-up test. MAN2 is only for latent infection, it is not for diagnosis of disease. The ZN stain is a stain you perform sometimes in an adolescent with the adult form of TB, the sputum ZN stain can be positive. So I would say that, yeah, these are what to start with, but you have to interpret the results carefully. Many people say the ESR is normal, how can it be TB? 1/3 of patients with culture-proven TB have normal ESR, so we have to know the interpretation properly. MAN2 is negative, it can't be TB. We know that 20% of patients with TB will have a negative MAN2. People have started doing IGRA now, and they do it as a rule-out test that if IGRA is negative means you shouldn't think of TB, which is not correct. So we should know the limitations of these tests.
Yeah, and X-ray, apart from X-ray chest, ZN staining has its importance because if the smear is positive, then you can further go for light probe assay and other tests.
Dr. Sridhar, to what extent are we going nowadays to determine tissue or histopath diagnosis? The first three will be the common fluids that we are routinely encountering and we can easily do this. So sometimes there is always issue whether
A little bit of difference of opinion on the previous slide, because when you are in a resource limited setup, you do what you can best, what you have or what you can. So if I'm in a tertiary center with everything, I will do everything. Because it's criminal if I don't do it. But if I have nothing, in the olden days what we used to do is we used to follow the high ESR. And as the ESR used to come down, we knew the child was improving. Or the platelets which were high used to come down, we knew those inflammatory markers were coming down. ZN stain we used to, if you had a positive patient and it becomes negative, you know the patient is doing well. Or a negative patient becoming positive again, you know what's happening there. But very much operator dependent. But with all the newer diagnostics coming into play, which are becoming very accessible and cheap and being taken care of the government, I think so we should be moving out to a better diagnostics.
Dr. Thane and Sonia, a quick word on the newer diagnostic techniques that are available with us and to what extent we should be using them. So please
So there are two things. One is sampling technique and then what to do with the sample. Sampling technique, these are all there. I mean, what you're mentioning that you try and make a definitive diagnosis and you do all these tests. And on the tissue, apart from doing the gene expert and widget culture, which is now available as expert XDR, where you can check for iron-edge, quinolone, aminoglycoside sensitivity also, like you do LPAs in a smear negative specimen. You also have pyrosequencing where you can pick up TB which is done in Hinduja, where your expert may be negative, you have expert ultra, and nowadays some people are also doing whole genome sequencing. So those are the other things, but they're all in the research arena.
Prakash, you wanted to say?
Coming back to simpler things, just for the record, new ICMR guidelines unequivocally state that do not do MANTU, do not do ADA. It's absolutely unequivocal.
I wanted to reinforce what Tanu said, so that question has to be worded properly. So when you are screening for tuberculosis, I don't think we should from now on depend on CBC, ESR and MANTU. So we should stop doing CBC, ESR, MANTU. If I am trying to answer a question, am I suspecting TB or not? We can't depend on that. So to that extent, Tanu's statement, let us take it correctly that stop using these three to suspect. Once you are strongly suspecting, yes, you go for jail, for AFP, whatever else you want to.
And please look at the standard treatment guidelines for pediatrics, which are now available from the ICMR, which talk about the approach to not only pulmonary TB but lymph node, abdominal, osteoarticular and TB meningitis, where you have very good algorithms which tell you exactly how to proceed, and these are available on the internet. So they are very good in your diagnostic approach, the STG guidelines by the ICMR.
When you have only a single...
Dr. Praveen, I'm really sorry to interrupt. We are shooting too much above the time. I'm really sorry. Please.
Thank you very much, all of you. This is a wonderful panel, and we've seen how different serious, complicated infections and resistant bugs have come up during this entire period. We got wonderful guidance from the panel. Thank you so much.
Thank you so much for that interesting discussion. For our next session, to give us an insight into the current approach in the management of recurrent vomiting, recurrent urticaria and recurrent headache, may I call on stage our esteemed faculty members, Dr. Vijay Emle sir, Dr. Pramod Jog sir, and Dr. Rehan Hawai sir. Dr. Vijay Emle sir, Head of the Institute of Child Health at Apollo Hospitals, and Dr. Emle, Multi-Speciality Hospital. Dr. Pramod Jog sir, Professor of Pediatrics in D.Y. Patil Medical College at Pune. Dr. Rehan Hawai sir, practicing pediatrician in Bhiwandi for last 30 years. I welcome you, sir. I call our senior pediatricians from Thane, Dr. Archana Kavalkar madam, our president, Dr. Sneha Kokate madam, and Dr. Daina Ravish to moderate the sessions. Thank you.
Thank you, Dr. Vaishnavi. Can I move forward? Yeah. So I hope we get those extra 5 minutes.
Yes. Anything for you, Archana.
Thank you. I have one more thing. Like, we were the ones who were like desperately trying to answer. Please try and answer questions. It's anonymous, so just press that. I think one trick we found is elevate that slightly and push the button. Then it will be good. So, without wasting any more time, I welcome you to session 2, and I call upon my colleagues to come. They've already been introduced, so we will not say anything further. And about the experts, I have this much to say, that Dr. Pramod Zog is somebody who has taught us how education can be entertaining with all his lectures. And he comes from my city, Pune. Thane is also my city, but Pune is where I am from. Then we have on stage academician par excellence, our previous past president, Dr. Yevle, who is from our friendly neighborhood branch, that is the Navi Mumbai branch, and our very own Dr. Rehan Hawai, who has always shared his brilliance in all the scientific committees that we have had here in the Tapicons. So, what we plan to do today is to
discuss some recurrent and chronic conditions which are present and which bother us as pediatricians in the regular OPD. And we have some very simple cases, no exotics like the previous bunch of cases. And we are using them just as a tool to make the discussion, okay? I request you to please keep your hands on those pads and keep answering the questions. We want to discuss the approach to these cases. We'll give you a rough roadmap with the help of our experts. We'll try to put forth some guidelines and we'll try to briefly touch upon the treatment. So time is of essence here. So in other words, we'll try to help you bridge the gap. So these are the troublesome 3 symptoms that we have chosen. Urticaria, headache and vomiting. And this is just a graph in my very basic childlike way. I have tried to show this graph. Acute is where the symptom comes, bothers the patient and goes away. Recurrent, by recurrent we mean symptoms which appear. I think this keypad doesn't work. Anyway, yeah. Which occur, gives a respite of a few weeks or months to the patient, and the patient is well in between and they recur again. And then chronic we mean just symptoms going on above the baseline. Okay, so this is where our focus is going to be on the chronic and recurrent. And this is our first system problem, that is recurrent and chronic urticaria, for which I'll call Dr. Sneha to take on the reins. Thank you.
Thank you, Archana. So this is audience poll number 1. Urticaria is classified as chronic when symptoms persist more than A. 2 weeks, B. 6 weeks, C. 3 months and D. 6 months. Okay, so most of the audience, they have answered B, that is 6 weeks. That's a correct answer. So, going for case 1, this is 5-year-old female girl child, Annie, weighing 18 kgs. She has just a fever, cough and cold since 2 days. Rashes are since the 2nd day, and there's a facial swelling which is noticed on 1 day. The fever is fever is high grade up to 104 degrees. There are no other significant symptoms. The fever cycles are almost 4 to 6 hourly without any shivering. Rashes are present all over the body. They are elevated in nature. Waxing and waning rashes, mostly itchy. Also, there is a facial redness and swelling of the cheeks. And the parents are already given paracetamol and methylenic acid for fever. So this is the picture of Annie. You can appreciate the facial swelling, the slight redness, and also the rashes which are present on the thighs. So audience poll 2. This rash can be best described as A. Macular, B. Nodular, C. Papular, and D. Urticaria.
Hello. Please try and answer everybody back there. I think just put your hands on that keypad and just keep pressing.
Okay, so maximum people has answered B, that is urticaria, and that is the right answer. So my question to Dr. Yevle sir is, can you tell us, throw light on different types of chronic urticaria?
Okay, first to begin with the first question that we talked about, acute and chronic. Chronic urticaria by definition is more than 6 weeks. However, there has to be a continuity. You have children coming with recurrent urticaria with a well period in between of more than say 3 months or so. Nowadays they also use a term called acute
intermittent urticaria. So that's not a form of chronic urticaria. Chronic urticaria is typically symptoms lasting for more than 6 weeks with no period of weeping in between or a very short interval of no rash in between. Chronic urticaria, by and large, you can divide them into 2 categories. One is inducible urticaria, where triggers are known and it can be reproduced when you examine the child. And the second would be chronic spontaneous urticaria, which again can be subdivided into 2 broad groups. One is the autoimmune urticaria, which is not so common as your idiopathic urticaria. Most of the time in practice, what we see is chronic idiopathic urticaria. And then arterial vasculitis is a different entity altogether. Now, in the inducible urticaria, also known as physical urticaria, you have this dermographism or delayed pressure urticaria, allergic urticaria, the solar urticaria, so on and so forth. What you have projected here on this slide, most of the inducible urticaria, they are short lasting, disappear in an hour or 2. Except the delayed pressure. Delayed pressure urticaria is something which comes after an interval, after applying pressure. Typically seen in school age children carrying bags with the straps where you have little swelling which can come up a little later with the interval in between. And usually it lasts for about a day or so, 24 hours or so. Contact urticaria is again a short lasting urticaria. And as it is that, vasculitis urticaria typically be long lasting. Typical feature is you have burning and itching and lesions which last about 40 hours. That's the urticaria.
Thank you, sir. Audience poll number 3. Angioedema differs from urticaria. A. Essentially presence of respiratory symptoms. B. Size of the veins. C. Involvement of the deeper layers of the skin and subcutaneous tissue. And D. It's a non-Ig mediated rash. Okay, most of the audience have answered it right. It's C, involvement of the deeper layers of the skin and subcutaneous. So this is just a pictorial presentation of V and angioedema. Going with the past history of Amy, which was not significant, the birth history and later on. The first episode of urticaria, it started at 9 months of age. And thereafter she had several episodes, almost 3 episodes of urticaria per year. The episodes, the rashes were waxing and waning, they were itchy in nature and they were always associated with fever. And the rashes were particularly flaring at the night time. But the child remained active, there were no oral lesions or there were no breathlessness or there were no recurrent sneezing. But the episodes they have increased for the past 1 year. Like she's having almost 3 episodes in the 6 months. Rest of the negative history doesn't contribute, like there's no history of drug rashes or no history of taking any specific medicine or food. The only prominent history was like she had history of lactose intolerance during infancy. Family history, like a paternal aunt was allergic to mushroom and seafood, and the father is allergic to crabs. But most of them, they had only gastrointestinal symptoms, no skin manifestations. So again, this is a question for the audience. Most likely cause of rash on the history. A. Food allergy in view of the family history and milk allergy. B. Acute spontaneous urticaria. C. Drug allergy because NSAIDs were used. D. Urticaria triggered by viral infections. The audience are divided. Many think it is because of food allergy, and few think that it is because infection induced. So my question to Dr. Zog sir is, Is there any relation between infections and urticaria?
Yes, definitely there is a relation between infections and urticaria. Remember one important thing that chronic urticaria are rare in children as a basic. Chronic urticaria basically is a domain of adult dermatology. And some of these infections like mycoplasma, hepatitis A and B, even HIV, they are associated with urticaria of chronic nature. So many times we see in our OPDs, a child comes with fever and mother says whenever he gets fever he has rash or urticarial rash. It is quite common in our practice, day-to-day practice. So there is definite relation. There is some next slide which you can show it, where we have written that there is some evidence that Helicobacter pylori infection is associated with chronic urticaria, and one should attempt to look for and eradicate these infections in severe chronic urticaria. But by and large, I want the audience to know that infections and autoimmunity, these two are the important reasons for chronic urticaria. Food as a cause of chronic urticaria is only in 10%. Okay, acute urticaria is fine. We will discuss it in the some of the next slide. But then infections and autoimmunity, just remember these two as the important causes of chronic urticaria in children. Chronic urticaria in general less common, and food as a cause is only 10%. So that further discussion will be easier.
So in this child
Can I add a
particularly,
point? I agree with Pramod that infections, especially viral infections, are the commonest cause of urticarial rashes in children. However, very often other triggers are falsely implicated. Like you have a child having fever, mother says I will paracetamol, and the child has developed asthma. So it is not the paracetamol but the viral infection which triggers the allergy. Similarly, the parents are advised not to use hair, not to give banana, not to give birds, and that is not the case in urticaria.
Moving with the examination of yes, ma'am. Yeah.
I completely agree with what Vijay says, and it's a misconcept that we think that food is commonly blamed, which is not. But ibuprofen as a drug is very, very common with PC urticaria, and that is one thing. Sometimes it confuses you whether it was the viral infection which caused the urticaria or the ibuprofen. So maybe if it has happened recurrently with ibuprofen, then I would think ibuprofen. And if I were to see the show of hands in this room, there will be so many people who would be allergic to ibuprofen. So that's one thing we should keep in mind.
And one important point is that all those NSAIDs which are COX-1 inhibitors, okay, they are the ones associated with urticaria. So in them you are supposed to use COX-2 inhibitors. That is something one should remember. And I usually write it at the top of the letter. Patient allergic to so and so. Okay, of course, beyond above that I write I treat, he cures. That is okay. Below that I write allergic to something.
Right, further examination of Abby, she was well known for her age. This urticarial rashes, they had a well-defined margin. They were oval and circular, 15 to 20 in number, almost 2 to 4 centimeters in size. And you have seen the picture, there was angioedema on the legs and the cheeks. Otherwise, the rest of the general examination and systemic examination was normal. So this is another poll to the audience. In urticaria, one should be alert if A, there is concurrent angioedema, B, if the rash lasts longer than 24 hours, and C, if the rashes they coalesce and fuse with each other, or D, if there is no clear trigger. Okay, the audience has answered A. If there is concurrent edema, angioedema, we'll see if the answer is right in the further slides. Now, in the view of the history and clinical findings, how would you proceed? A. Investigate for the cause of fever only. B. Investigate for allergic etiology, that is do an IgE and skin allergy test. C. Would you get a dermatologist opinion and get a skin biopsy done? And D. Work for autoimmune causes like do an ANA, C3 and thyroid antibodies.
Okay, so we have a mixed response. Few people think that it is investigated only for the cause of fever, and few think it has an allergic etiology. So let us see what we did. We did these investigations. The CBC you can see slightly on the lower side. Dengue was done, which was equivocal. ESR, CRP were normal. IgE was also within normal limits. Urine was normal. A skin allergy test was performed after a month, and it showed that she was sensitized to cheese and curd 3 ml. So my question here to Dr. Rehan sir is, do we do a skin allergy test in chronic urticaria?
At least when we go as a clinician with this patient, this is repeatedly fever and it's more of an infective etiology. So first I would investigate only for the infection. And if we can treat that infection, we can avoid this urticaria. Other than that, now if at all you get this repeated urticaria, then you want to really go ahead. The second thing I would go for is an IgE test only, which will give me only few things. One, if it is very high, I know that I'm dealing with a severe infection, severe urticaria. Second, chronicity. If the chronicity is there, then I'll be getting a high IgE, so that will help me. Third is with my treatment part. But skin allergen testing, as a clinician, most of us have really we don't go directly for that. But if it is a chronic urticaria, yes, I would go for it. And then skin allergic test, we have a typical pattern how it is done. And the system is that there are about 45 antigens. And these antigens, and there is all antigens are marked on the hand in the forearm. And there is a control. Control is a saline, and there is a histamine control. And it is seen that this, if there is a allergy, and what you do is you use a what you call with a prick, you put this drops inside the skin, lancet, what we call. And when you get an allergic response, if it is more than 3 millimeters, yes, it is sensitized. So basically, it is sensitive. So if you get a list of things where you have a sensitivity pattern for certain things, then yes, it helps us in telling us that this is the cause, and we should avoid this type of allergies. Now, if you are thinking of an immune urticaria, if you are really thinking, and immune also, I would not go for the investigation directly. First, I would like to look into whether I am dealing with an immune or not clinically. So clinically, first I would look into if the child has a rash, fever, has joint pains. So I am suspecting that there is some immune involvement in this child. Then also I will not go directly for I will do a CBC count, serial CBCs. I would see weekly a rise in the WBC count, a rise in the platelets and a fall in the hemoglobin. Then I would think that I am dealing with an immune mediated effect. Then I would go for autologous serum test. And autologous serum test, how it is done, it is the blood is taken from the patient and serum is separated. 0.05 ml of serum is injected at one in the forearm, and there is a control. Control is a saline control, and that is a negative control, and a histamine control, which is a positive control. And if you have a positive control, 1.5 times more than the saline control, it is positive. Then you can think of an immune-mediated type of So this is what we are going to, so that we can find out about it.
Sir, in this case,
Can I make a comment here? While it is good to know about the allergy testing, I think allergy testing and IG estimation, these are grossly abused tests in our field. Very often, there is no underlying allergy. Unlike your respiratory manifestation, your allergy is not because of urticaria.
And that's why I was very specific and I have only 3 things. If you want to do an IgE, only 3 things. Whether it is chronicity, it tells me the severity, and it helps me in my treatment. And if at all biologicals are used, if you have a high IgE, the omalizumab works very better.
Unless you have a specific trigger and known substance, you don't ask for IG.
So we have to make a distinction between sensitization and the allergic manifestation. That's what you were saying, right, sir?
So 2 things about it. I think we used to do skin prick testing, and experts say that for urticaria kind of situation, skin prick testing is not advocated. The better tests are to do RAS test if at all you want. The another point that I wanted to make is this child is getting, suppose we call it as febrile urticaria, fever-induced, infection-induced urticaria. That means one infection
Is it coming repeatedly? I think that usually doesn't happen, and therefore it can be either febrile urticaria, means fever itself is precipitated in urticaria, or it can be because of, as you were saying, that some antipyretics which are given or something associated. That's the way I think.
It may not be the same infection. Repeated viral infections also can come with acute urticarial response.
I mean, what can be pathophysiology for that? So usually it's a molecular mimicry IgE. So there has to be a single kind of infection. So if, say for example, dengue 4 times it can come, 1, 2, 3, 4 species, it cannot come 5th time.
So in this child, seeing the age group, 4 to 5 viral infections generally we expect in these children. And this particular child, let us put it this way, that the rash was always associated with the virus. The rash never came on its own. So there were some febrile illnesses which probably came without a rash, but when there was a rash, there was generally an associated viral infection with that. That's the.
Let's add something. See, COVID has taught us that it's not about the virus alone, it's about how your body responds.
Yeah,
So it is logical that a particular person may respond to any possible infection by going into an urticarial rash.
That's not
Yeah.
infection-induced urticaria. That's fever which is causing urticaria.
Well, whether it's fever or it's a
Fever is because of infection.
Some more points. So it can be viral. Fever can be bacterial to like this. Yes, it will be
no, you're saying that if the child has an immunization and develops fever, the child will still get urticaria, then it is fever induced.
Well, this was not
In the
happening
context of an infection.
So we can get vaccine-induced urticaria also.
Yeah, we can.
So I think that's just trying to piece it together. What we were trying to say that viral infections can induce urticaria, fever can also induce urticaria, and it depends on the person's immune response, every individual being different.
And the response will be different each person.
Each person, every individual being different. Yes. Yes.
And so about this, like only one sentence to be remembered. Only specific IgE is available, and the person knows that the urticaria occurs after is okay. Otherwise, E from IgE is for the economic reasons of the allergens.
That's not on the IgE. So I don't think I'm pushing about it. So if at all IgE and cellulose, in respiratory illnesses also it's not, it does not tell us anything. A high Ig or a low Ig does not tell us anything. The only place in respiratory illnesses where it has a role is like when I'm suspecting say Jobs disease, like a hyper Ig. In ABPA, allergic bronchopulmonary aspergillosis, a specific Ig and a total Ig more than 1,000 would be specific. In urticaria, IgE has a role in chronic urticaria. When you have an acute urticaria, it is absolutely relevant. That's what I would like to
Yes, ma'am.
message.
So provisional diagnosis of Annie was recurrent infection-induced urticaria, or recurrent urticaria may be drug-induced because she always used NSAIDs. So now carefully see this picture because there is a question going to come up. This was a 18-year-old female. She had this rashes on her hands and legs, like urticarial rashes. Rashes were itchy and they were burning in nature. She had been treated with class 2 antihistaminics with no improvement. Some rashes have been particularly stubborn and they lasted for more than 24 hours. No history of any fever, drug intake or any food allergy. So the audience poll said in, your approach would be A. Double the dose of the antihistaminics to alleviate the symptoms. B. Add a short course of steroids in addition to antihistaminics. C. Investigate do CBC, CRP, ESR, thyroid antibodies, ANA and C3 levels. Or D. You biopsy the lesions which are more than 24 hours.
See, 18 years referred to adult.
So 18 is still a child. Please everybody try and answer. We want to really know what you have in mind.
Okay. So no one wants to biopsy the lesion. So my question to Dr. Yente sir is, so what would you do if the rashes they appear more than 24 hours?
First, I would go with the answer given by her. I would refer it to an allergist. Honestly speaking, for a common general pediatrician,
which is complicating, lasting more than 20 minutes, is not everybody's cup of tea. Though theoretically we say you biopsy the skin lesions, how, I mean, from the audience response we know that we we hardly biopsy the skin lesion. But yes, rashes lasting for more than 48 hours, you know, to be aware of vasculitis rashes, particularly vasculitis, that may require your skin biopsy. And then treatment-wise, for a common pediatrician, double the dose of antihistamines. And before adding steroid, I think we should do a proper workup, establish a diagnosis. I mean, you showed us the long list of tests. These autoimmune urticaria, chronic urticaria, very often are associated with antithyroid antibodies. Then you have, most of the time, there is no underlying lesion found, despite extensive investigation. We end up with labeling them as chronic idiopathic urticaria. So I would leave it at that. Skin biopsy, if at all I would ask first, I would definitely refer such a patient to a dermatologist or to an allergy specialist to establish a proper diagnosis of small vessel vasculitis. Then your management may change, doubling or increasing the dose of antihistamine. And if there is severe flare, you may add steroids as well, and then you go on to cyclosporine, so on and so forth.
I agree with Vijay, and at least this slide will tell us, because many in the audience may not be knowing that there is an entity called arterial vasculitis, because it is something we should remember, and it is better to refer to the dermatologist. Many of my dermatologist friends, I asked them why you took dermatology as a super specialty. He said patient bara hi hote hain and marate nahi. So he continues to come to us all throughout life. So let them enjoy their practice with chronic urticaria and chronic this and that.
Talking about this autoimmune urticaria, though urticaria can be a part of manifestation, there are several other, pointers towards, underlying cause of autoimmune urticaria. So lupus child would not present only with urticaria.
What was the correct answer?
See, these are the guidelines. Guidelines does mention that any rash lasting more than 24 hours you should biopsy. But these are the latest guidelines. This is what they say.
Madam, these are the guidelines that have been mentioned in dermatology journals, and I mean they have been shared with us by our rheumatology colleagues. So I don't see Vijay should have pounced on me.
And which is true, unless
which is true. These are the guidelines.
not know whether there is vasculitis, leukocytoclastic vasculitis they call it. Unless you do a biopsy, you not know.
Yeah, that is true, but practically the answer would be, if you are giving say fexofenadine, try doubling the dose. That is the better option for us. Okay, so it is not in the guidelines, and these guidelines, as I was talking to Archana, they are adult guidelines. They have been taken from a journal related to adult dermatology. Okay, so we always have a guideline which is for adults, so it is a guideline. So pediatricians can modify.
Not exactly. You once in a way come across a child who have severe vasculitis. You will have to do
There is only particularly one nodule which is stubborn, it is burning in nature, and usually it will leave behind ecchymotic patches. So those are the ones which are worrisome, because urticaria they usually do not leave behind any pigmentation, or they usually do not rash also. They are evanescent rashes, usually disappear within 24 hours, commonly. Okay. So follow up on Emily. Her fever subsided and she responded to antihistaminics in double the doses for 2 weeks. She was diagnosed as recurrent urticaria induced by febrile illness. She was advised to maintain a diary with urticaria score and possible triggers. She was advised to avoid NSAIDs, advised to use fexofenadine for any further such episodes, and to immediately report if she has any weakness, lethargy, breathlessness, or sensorium associated with urticaria. Dr. Zob sir, could you please tell me what is this urticarial score?
Yeah, as you can see on the slide, this is urticaria activity score. We have to take 2 points in consideration. This is mainly to know how this treatment is progressing, how the child is responding. So wheals and itch, these are the 2 things. And you have to see, look at the bottom. I know those who are at the back cannot see, so I will read for them. So if there is no itch, it is 0. If it is mild itch, 1, moderate 2, and severe is 3. So these are the scores which are noted every day. there are wheels. If there are no wheels, the score is 0. If there are 0 to 20 wheels, it is 1, 20 to 52, more than 50, it is 3. This is to be done once daily. Do it for 7 days. After 7 days, you sum it up, okay? And then weekly score is to be taken. So depending on that, you can just decide as to what is the progression and what is the response to therapy. So this is only for the information of the audience that there is something like urticaria activity score which exists. Otherwise, we are remembering so many scores from so many subspecialties.
Just one comment on this. When you really do the scoring, you know whether the patient is responding well, good responder or not. So if you have a score of between 1 to 6, you know, okay, your treatment pattern is going on properly, you continue. If it goes between 7 to 15, that is moderate, and then third is 16 to 28. So accordingly, you can change the pattern of treatment. So the score will help you in managing your patient.
Half an hour done.
Okay. So this was a 8th question for the audience. What is the choice of treatment in chronic urticaria? A. Second generation antihistamines, up to 4 times the usual dose. B. Combination of 2 antihistamines in double the usual dose. C. Addition of immunomodulatory or biological agent to the second generation antihistamines. Or D. Combination of antihistamine and probiotics. I think the audience has answered B. Let me ask Dr. Yele sir how he would approach such a patient.
The guideline recommendation is to go on increasing the dose of the antihistamines. And giving 2 antihistamines is not the recommendation. If your child is not responding, you have some objective intensity of urticaria score and then step up the dose. And if it's not responding, you refer to allergy specialist and go for the cause of urticaria. And even in idiopathic urticaria, by and large, over a period of time the child responds. And what suffices is increasing the dose of antihistamine. These are now, say, the second generation natural antihistamines. If there is no control, after 2 to 4 weeks, you increase the dose, you can go a recommended dose. And then if it doesn't respond, give it to the super specialist to add on medicines like omalizumab or cyclosporine, which are by and large used in autoimmune or urticaria or urticarial vasculitis.
So what is the burden of chronic urticaria? Is it very devastating, and how do we explain the prognosis to the parents?
As I said, the burden is not very huge. As Pramod said, it is more of adolescents and adults who get chronic urticaria. What children have is acute intermittent urticaria. They keep getting repeated episodes of acute urticaria. Once they do have this autoimmune urticaria, there are other manifestations. And these children are either with steroid or immunomodulatory medicines. So they respond.
And you see, one should remember that the urticaria at some stage or the other. Hello? Yeah. Urticaria at some stage or the other resolves, okay? Chronic urticaria at some time or the other, without anybody's knowing, the patient stops coming to the dermatologist or pediatrician. You should understand that either he has left you or he has recovered, okay? Most importantly, this is like our, people who have interest in contesting for executive members post. If they lose often, they stop contesting after some time. Okay? That's fine. So remember that the prognosis of chronic urticaria is not usually bad, and usual course is that they recover. Only is counseling is very important, because the parents are really troubled. रोज पोरग खाजवते 6-6 आठवडे झाले तरी बरा होत नाही, so they are really troubled. So you should counsel them, tell them that continue antihistamines. If required, double the dose. And they will ask long term therapy से काय problem तर नाही ना. So tell them nothing happens. These are not the diseases like diabetes and hypertension where there are problems of the disease and medication. These are plain simple antihistaminics, and the newer antihistaminics are very safe. So induce hope in them, okay, and see that the patient keeps coming to you.
Probiotics.
I have been doing a study on the role of probiotics in chronic urticaria, and I've finished almost 35 patients now. It's under evaluation. Probiotics really have a scientific basis for treatment in urticaria. The lactobacillus fermentus in casein, and when they go into the intestine near the Pierce patches, equine acid is released, which stimulates the Th0 cells and which blocks the Th2, and which are responsible for response of humoral immunity, and therefore they help in allergic response. And what I am doing is I have taken two sets of patients. One group of patients we are using plain only probiotic, one probiotic with an antihistaminic. There are a lot of papers on this. It's under evaluation. It may take about a year or so, but I think it has got hope, and it may be a very safe bet to work.
So continue probiotic till the urticaria is going on.
Yeah.
For how long?
30 days first, 30 days we evaluate, 1 month course of 30 days, every day we give one sachet of that probiotic and we evaluate. What I am seeing is by day 7 or day 8, generally they are responding very well. And then we continue. And when we continue for 30 days, they go into remission, we stop it. So multiple things have to be added to that. Like I want to go in for longer time, whether we should give, and how much they come back again. And then I am doing one more thing along with that, we're giving IgE levels also along with that. Because generally it helps in food allergies more, this type of probiotics. Pardon?
But we said only 10% or less than.
Yeah, I know, but that's what. So basically, IgE levels, whether they are high or low, that also I am evaluating importantly.
So we'll have to move to the next topic. I'm sorry, sir. Thank you very much.
So you can just go through this checklist for urticaria. We try to cover most of the points. Always take a detailed history with relation to food, drugs, and related to that episode. Always ask about any history of triggers, environmental history, whether there are pets at homes, any plants or pests. High alert if the lesion lasting for more than 24 hours. See whether the dosage of antihistamines have been appropriate or not. You can always increase to 4 times the normal dose. And counseling and a close follow-up. And ask the patients to maintain an urticaria activity score. Thank you so much.
And for the, just for you to take it as a last carry on message, remember the word RASH, R-A-S-H. R stands for reassure, A stands for avoidance of allergen, okay? S stands for, I will just tell you, and H stands for histamine avoidance or histamine avoidance, okay? S would be supportive or symptomatic treatment, yeah, that's fine. So RASH, reassure, avoid allergens, symptomatic treatment, and histamine inhibitor. Ever लक्ष्य ठेवलं तरी सगळं that's fine.
Thank you for the technology, sir.
Moving on with our next topic, recurrent headache. Now some emojis. So yeah, hoping by now the audience is all set to answer the questions. Audience poll will start off with the first question.
पीछे वाले लोग, please answer.
Yeah. So the first question to the audience, the typical feature of clustered headache is, does it present with option A, half headache, B, headache around one eye, option C, frontal headache, D, bitemporal headache? Okay, so the audience seems to think it is bitemporal headache. The answer is actually headache around one eye. So a small set of collection of emojis. Dr. Pramod Jog sir, I can see the smile already on your face.
I was just thinking as to how I remember the recurrent headaches and others. So when I get married, it's acute headache. When my mother-in-law keeps coming recurrently, it's a recurrent headache. So now this location of the headache is to be remembered. जास्ती डोक्याला त्रास करून देऊ नका. Just remember that it's a headache of migraine in children. It is not unilateral. In children, it is bilateral. Okay? Remember, as the girl usually it is common in girls. Crosses 18, then it becomes hemi-headed. That is, okay, but initially it is usually bilateral. Remember that? Of course, up to 18, girls get headache. After 18, they start giving headache. Anyway, take some of the comments in the light away.
I think we've given them a lot of headache, the three of us.
When the sinus headache is the one most of us who either macular or frontally develops after 7 years, and as we can always examine the child in the stooping forward position, many times it gets aggravated, but it is usually in the sinus area. Cluster headache is typically periorbital, okay, and the headache of migraine is throbbing headache and on the temporal side, okay, and tension headache, which is not shown here, it is like a band, okay, so band around this forehead, and it is dull type and all. Maybe in some of these slides we may discuss about these conditions more. And remember, the headaches are of two types. Primary headache means migraine or tension headache, and secondary is secondary to some cause, maybe hypertension or some internal infection. So you have the basic structure we will go on.
That was a
comment on the sinus headache. We normally think that it is because of the sinusitis we get headache, but it is very specific for those patients who have a previous history of migraine or they have associated migraines. So that is one point we must remember. All of them who have sinusitis never always have these headaches. There is a association there.
I would say that sinus headaches is a very loosely used term by parents. They will say sinus, sinus tha. And what is more common is tension type headaches and migraines. So there is a phase of denial. They would say like sinus headache. Typical sinus headache which has been shown on the Zimoli is not difficult to miss.
So going on with the case of a 14-year-old Shraddha, she was previously well and she used to have headache on and off since past 2 months. Headache was sudden in onset, would start on awakening and would progress through the day and would relieve only on sleep. It would start initially from one side and become holocranial gradually, and the intensity also over a few days progressed. We'll see it in a graph format. So initially, almost for 2 to 3 weeks, the parents were at home with the child managing the headache with some suboptimal paracetamol doses, with some mild headaches that she used to have on and off. But around 3 weeks, they realized that this headache doesn't seem to be responding to their paracetamol. So they took her to a pediatrician who initially corrected the doses of paracetamol in the right doses because she was on very suboptimal doses, and was asked to maintain a headache diary. We'll come to it gradually. And on follow-up, as the headache persisted and probably increased, certain investigations were done and further help was sought. We'll come to it gradually. So audience poll at this point of time is on history, what would indicate a sinister cause for headache? Option A, anything that awakens the child from sleep. B, sudden change in quality. C, occipital headache. Or D, all of the above are sinister causes for headache. Yeah. So option D, all of the above is rightly chosen. Going on, considering the other past history which was taken by the child, there was no significant past history with respect to any trigger factors or any ongoing medications, any history of COVID infections or any auras associated with the headache. There was no significant family history other than the mother having traveling sickness. Child was growing well. She's always been a little on the overweight side though. The next audience poll question. So after this basic examination findings, what are your differential diagnosis now? Option A, migraine. B, space occupying lesion. C, sinusitis. Or D, is it a tension headache? So we don't have exactly one answer on this. So we request Dr. Rehan sir to touch upon this with explaining the different specific qualities of different.
Dr. Jog has already discussed the things. Only few things we must remember. We have this migraines, tension headaches, cluster and sinusitis. Sinusitis was discussed. So basically, migraine is headache. It is one which is more commonly discussed and it is seen also. And you have a typical, initially you have a prodrome, then you have an aura, and then you have a headache phase and a recovery phase. So this is a classical of a migrainous part. But when you have a prodrome, you will have retention of urine, or you will have constipation and mood changes. And when you have an aura, it will last only for 30 minutes, but you will have flashing lights, blindness seen in front of the eyes, and this time you have tingling feeling in the body. So this is aura, and then it goes into the headache part. When the migraine child goes into the headache part, it could be partial, it could be holochronic, it may spread to the other part of the heart and also. So in this situation, at that particular point of time, he may have nausea and vomiting, which is a very important association of migraine headache. And the other thing is, with activity, the headache changes, it increases with activity. There are two important points we must remember for migraine headache. And then they go into recovery. Tension headache, as is discussed, it's a band which is seen all over. But tension headaches can go on almost for a year. And they are also discussed in two phases, like you can have a chronic tension headache or even have episodic tension headaches. And important, why we want to know really what different types of headache, because treatment pattern will have some bearing on the types of, otherwise. For us, headache is a headache, we want to treat the patients. Now when you have something like a tension headache, I would like to go for biofeedback as a treatment, because that is where
We will be coming to that.
Fine.
So on further examination
Just 1 minute. Just to clarify what Rehan has said, we must be very clear about migrainous headache and tension type headache. Migraine, as I said, in children usually is bilateral and then becomes unilateral after adolescence. It is a throbbing headache, acute onset. Okay, while tension headache is all throughout the year, continuous headache, it goes on for a long time. That is one. Secondly, the location that we told about this tension headache that is there. And migrainous headache typically is relieved by vomiting or sleep. ते झोपलं की बरा होऊन जातं. वाईट टेन्शन हेडेक काय कमी होत नाही, ते टेन्शन राहत असतं. And phonophobia and photophobia. Migraine headache, they are very much annoyed by noise and light. Okay. While tension headache, remember, it is very important and it is increasing in the practice. And I am associated with an institute where they run an adolescent clinic. The parents who are giving tension about the expectations from the child, the adolescent age, class marks मिळाले पाहिजे, medical ला गेलाच पाहिजे. So all that is giving such a great tension that all those adolescents who come to us with tension headache, the number is increasing. Okay, and it is an important part of therapy which we will discuss little later. But I must tell you that these two are important causes of primary headache. And of course, secondary headache is different. I don't think it has been written over here. Sinusitis is only mentioned. But we will discuss about some other aspects during the examination.
One very important thing about headache is, first of all, in children, headache should never be taken lightly. You have to rule out organic causes before causing it a non-organic cause. And in COVID and now, what we are seeing very commonly as sleep deprivation as a very, very common cause of headache in children. And very often in our busy practice, we do not take history of sleep. And most of these children are sleeping very late. And with stress of school, which is school has started them to get up early, they are chronically sleep deprived, and it's an extremely important cause for headache, which I think we must all remember to take history.
Hindu by and large, longer the duration of headache, unlikely that there is an underlying organic cause. So that is
I did take a full class is very, very important. But if there is a chronic deprivation of sleep, especially pre-adolescents and adolescents, these are kids who will always present to you with headache. So that is a very simple thing. Unless you take the history, you will never know. And many of these children, we ask them to just simply maintain a sleep diary. What time they got into bed and what time they got up in the morning, and that will tell you that it is because of sleep deprivation.
Younger the age, more of the chances that it is organic.
Absolutely, I'm going to come to that. Older the child, I think more the chance of being non-organic. Especially the child is adolescent, and we have all these children who are screen addicted, and that is what is causing this sleep deprivation.
We did get a quote from you for the causes of headache and everything.
So moving on with the examination findings in Shraddha, she's always been an overweight child, currently her BMI being 27.
Otherwise, vitally, no specific findings. Blood pressures were 120 by 80 here. No specific anomalies or any specific head-to-toe examinations or nothing significant on systemic examination was noted. So now to the audience again. What would be one vital parameter you would not miss? Option A, heart rate. B, respiratory rate. C, blood pressure. D, oxygen.
Do we need so much time? I think we can move on.
Yeah, so this one is a pretty obvious just to awaken
But I think
everybody.
once the process is going, it will go through.
By the time they put the correct answer,
Yeah,
which is obviously blood pressure. See, examination of this particular child, any child is intended. First, I always say touch the feet, just as we touch the feet of the bot. Child is our bot. So dorsalis pedis, because coarctation of air producing hypertension and headache is common. So touch the dorsalis pedis and then check the blood pressure. Of course, CNS exam probably may not come. So I am just telling you, whenever a child comes to you in the OPD, make him walk in the tandem gait. And ataxia is important. And second is sudden onset of torticollis. So these are two indicators of posterior fossa problem. And chronic progressive headache. The child is having headache which is increasing. That is something which is indicative of intracranial tumor or something. Anyway, we go ahead.
So this was the initial treatment that was started, corrected paracetamol doses, headache, diarrhea, and on follow-up there was noted that there was no significant improvement. So about headache, diarrhea, may I request Dr. Yevli sir to please comment on it.
Headache diary is an extremely important tool to arrive at a diagnosis. As Rehan described different types of headache, knowing the frequency of headache, intensity of headache, if there are any triggers, sleep as Indu said, how sound the sleep has been in that particular child. Is there any associated vomiting? Are there any other neurological symptoms that the child has? Family history you ask for. Are there any aggravating or relieving factors? And these are a few things which, most of them give you some pointers towards the diagnosis. And important thing is stress factors. Age of the child, sex and weight, that is also very important. And some of the headaches are more common in adults age group, more common in girls, in obese children. So these are a few points that you would want. And then relieving factors. Is there any specific food trigger that is headache? Especially migraine, some children have specific identified triggers.
Certainly, this is right. So remember the mnemonic Socrates. That is an official mnemonic for headache. That is site, onset, then character, then radiation, aggravating factors, and time relation, and so on and so forth. So remember that Socrates inquiry is very important for headache. And what is the purpose of maintaining headache diary? Why we write diary? I write diary every day at night before I sleep because it relieves me of my tension. Okay. So similarly, now my wife also writes a diary. She says at least I will really get relieved from the headache of my mother-in-law, so that I can say whatever I want in the diary. So diary also makes you relieve some of your tensions. Okay. So maintain a diary. Apart from all the advantages related to headache, it is important that you maintain a diary so you know the progression also.
Family history is important. And one very common association is history of travel sickness. Most of these migraine children, they also have associated travel.
So we have a PED-MIDA score here, which is a pediatric migraine disability assessment score. I request Dr. Rehan to show us.
It looks a busy slide, but it is very simple. 3 points for school, 1 point for the home, 2 points for extracurricular activities. So total 6. A child can keep that score. Clause 3, how many days he was absent full day over the last 3 months. Second is how many days he was absent for half a day over the last 3 months. That is the second point. The third point is how much he performed to 50% of his capacity, how many days. So these are for the 3 school. One is for the home. Home, whether he was able to do his course or he was not able to at all his homework and everything. That is one. The fifth and the sixth is your extracurricular activities. Whether he was not able to do his extracurricular activities at all, or whether he was working at 50% of his capacity. So it's a very simple score if we break it into this way, and let him maintain the diary this way. And once you have this diary, you know the disability score grade. And with this disability score, you will know how the child is progressing.
I just wanted to ask one question here. Many of these scores are they for clinicians or they for the judging the treatment of an investigation drug? Because as clinicians, are we going to use this? So
No,
what
sir, it
is
is
your
for the patient to maintain and come to you during the follow-up.
I mean, that's what I mean.
He's got a point. What he's saying is that whether we'll be using it in our practice for our treatment part. That's what you tried to say, no, Sunil?
Yeah. I fully agree with Sudhir. There was a study called CHAMP study, CHAMP, Childhood and Adolescent Migraine Prevention Study, which was published in NESA 2017. There, this score was used to evaluate the efficacy of medicines like amitriptyline, topiramate, and placebos. It was proved that placebos and all these three are equal. So, placebo treatment is equal to, say, flunarizine, which is used for prevention of migraine. So, basically, you should know that these scores are for research purposes. That is definite, no doubt. Ultimately, it was found that medicines are no more than placebos in that study. So, we are not going to discuss medicines, but you are right. These scores are used for research purposes and in drug therapy trials.
On this chronic and recurrent conditions, there is some objectivity. You are taking care of migraine. It helps you monitoring and stepping up, stepping down, investigating further.
So although the practicality of the headache diary is a little in question, but I think in practice all of us, even if we ask our patients to just score the headache between 0 to 10 and a few 2-3 points, I think that is to a large extent practical also, and it really helps.
So Archana,
Pain score.
Pediatrics score may be practically good, but headache diary is extremely important in practice.
See, one or two important things, like a child who is avoiding school because of headache versus a child who is avoiding play because of headache. There itself tells you that that could be whether it's organic or sort of non-organic.
With Mamta ma'am in the audience and Archana ma'am behind me, let's run with the next audience. So what would you do next in this child? Option A, step up the oral medicines. Option B, get MRI brain with angio done. Option C, CT brain done. Option D, just counsel and suggest biofeedback techniques in the childhood. So this child, since she had a progressive headache, we actually wanted to investigate this child. So looking at our, if you remember our graph, we had investigated around 35 days. So with the pediatric neurologist baseline investigations were done. Certain investigations for, because she was overweight, they were done, and ANA level was sent, we'll come to it. The radiological investigation was done and CSF opening pressure was suggested. So the next audience question again, indications of neuroimaging in this child would be option A, seizures or very brief aura less than 5 minutes. Option B, children with atypical auras. Option C, headache which progresses through the day. And option D, all of the above. Not in this child, in any child.
Meanwhile, sir, you can tell us about the indications.
The indications for neuroimaging are obvious. That whenever a child has focal problem or either he has, so all of the above are correct. And particularly when the child has associated seizures, vertigo, or atypical aura, then obviously anyone will do the imaging studies. And whether you tell him or no, he is going to go to get CT and MRI. Of course, we send patients for MRI because MRI stands for mutually rewarding investigation. Please don't be rewarding.
Anyway, it's important to remember that we should not miss something important here.
Sir, but one point, basically what we have learned is that, suppose this may not be, but suppose it is an SOL. The headache of an SOL is more early in the morning because when the baby sleeps there is a venous congestion. So the baby gets up with a headache and after the day goes by the headache actually comes down. Initially at least. Later on of course it's a headache going on, then there is vomiting and all. So that is the reason I was not very happy with that all the topic about headache which is progresses through the day.
Yes, in this child it was progressive.
Agreed, but I am generally discussing about that. So that's what I
So on follow-up of Shraddha, we got a off-time review done which showed papilledema. MRI and MRP were normal. Other workup for secondary causes of pseudotumor cerebri was done, which was normal, which was not negative. ANA was done though, which was found to be weakly positive. I would request Dr. Yevle sir to tell us the significance or relevance of this.
To have papilledema on imaging, that it gets elevated in intracranial pressure, which could be either tumor or pseudotumor. So, and this is a
MRI and MRP is normal, sir.
MRV is also normal. So, I mean, MRV is done probably from
Thrombus,
thrombosis, etc. And so there is a cause of intracranial pressure. So that could be the reason for headache.
The ANA is what? What is the relevance and this weekly positive, should we even give any value to it?
So, this being a girl, they must have asked for ANA. Some girls with lupus, many of them have headache. Can have headache or they of migraine, they can have headache because of lupus itself. So lupus disease itself can give rise to migraine, headache, or lupus girls can have migraine, associated migraine also. So only ANA, I would not give much.
Last
You would have other treatments and so
session. Last 15 minutes of the session.
So yeah, let's just rush through now. Yeah.
I think this needs some
Are we vomiting or vomiting?
ICU treatment. So anyway, this child was treated as pseudotumor cerebri. So we have to rush, like we have the vomiting session to do. And she was better after the treatment with Diamox. We will skip this audience question and just a little bit to show you what is the difference between pseudotumor and real tumor. And okay, just with a show of hands, which is the next cause after migraine which can cause headache in children? I think the experts just told us. Okay, tension type headache, correct. No. Oh God. Nothing correct, yeah, we have to anyway rush, we have only 15 minutes. Why is this not coming? I think the treatment also, sir, about Kerala.
One single.
Sir, want to talk about biofeedback, please? Yeah.
Just remember that of all the discussion, we are all very intelligent pediatricians. We are definitely going to rule out intracranial causes and others. But this management about these chronic primary headaches, migraine and tension type headache are extremely important. Again, remember the mnemonic SMART. SMART is an official mnemonic, and that means you have to ensure that the child gets sleep for 7 to 8 hours. M stands for meals, regular meals. A stands for activities, regular exercise. R stands for relaxation, yoga. Okay, and T is avoidance of triggers. So this SMART therapy is extremely important in the management of chronic primary headache and ensure plenty of fluid intake. Okay, so any adolescent girl coming to you for this particular headache, either migraine or tension type headache, primary headaches, please see that you follow SMART therapy so that you need not remember other things. I think that's all.
Yeah. So
one line on biofeedback, because that would be really helpful for especially cluster headaches. Because you have a spasm of the frontalis, you have the spasm of the masseters and the trapezius. So it's like an EMG machine where we connect these things. And these are special technicians who are trained for it. And it really helps in most of these clusters and in most of the tension headaches. So this is going to be the future as the things, because nowadays we have never used it, but this is what is going to be the future for tension headaches and cluster.
Last point is, whenever IT sector parent comes, IT is the intelligent and troublesome. Inquisitive and troublesome parent from IT sector. Don't use the term recurrent headache. Say it is cephalalgia. Okay, cephalalgia is nothing other term for headache. Okay, so use the term your child is suffering from cephalalgia.
So we had the typical Zoxer tablet. So checklist we know. So we are moving to the next symptom. I think just with a show of hands or just say it loudly. Vomiting center, where is it located? Come on guys. Yeah. Omeprazole helps with vomiting, and what is the mechanism of action?
Blocking action, 5-HT.
No, it's ATPase pump. Okay. Anyway, this is a story of 12-year-old Tina, and I'm going to straight away go to this
graph because we don't have much time. So 12-year-old Tina was otherwise a very healthy child, and after she joined school, I think April the school started, her first episode of vomiting started when she went to school and the parents went out to eat. And there were episodes which about, every time there was an exam stress, the episodes used to come. The third but just before the last episode when this child presented, she had this exam stress and this vomiting would continue for 6-7 days, respond to PPIs. In this third episode that I can point out here, she had been treated with H. pylori kit, and this last time that she came, the parents were really exasperated, and then she needed to be investigated. So she had no significant negative, nothing. Negative history was completely clear, and the only thing we found that the mother was suffering from migraine. So here, it's an audience poll, we're not going to waste those 15 seconds, but I'm going to ask you that if you have a 3-month-old in whom you would be suspecting pyloric stenosis, you would expect the vomiting to be what? Effortless, bilious, blood tinged, projectile. Projectile. Everybody agrees, thank you. The next is if they have a recurrent vomiting, and this is an important question, what would you want to do? You want to do dye studies? You want to do blood gas analysis with the metabolic workup? Do you want to take a detailed history and examination? Or you want to do a fundus examination with an MRI? See, everybody agrees. So, a detailed history like Sir, Ambedkar Sir is here, I'm sure. In fact, each of these symptoms, a detailed history and examination is the key more than any investigation, and that's what recurrent means. Recurrent is equal to history. So I would request Dr. Yevle sir quickly to point out what is it that in the vomiting that you need to really keep in mind.
So first of all, age of the child is important. There are some typical causes where, say, a child in early newborn will vomit, like you said, outlet obstruction, pyloric stenosis, or aneurism event. Then you have characteristic of vomiting, whether it's bilious, non-bilious, blood tinged, non-blood tinged, projectile or otherwise. Then you ask for triggers. What time of the day it comes, before food, after food, any specific trigger in form of stress, like if they had income stress, or if there is any food factor which is responsible. Timing of the vomiting is important, whether it occurs immediately after ingestion or on empty stomach, and what is the content that is brought out, whether it is stale food, whether it is alteration in the food, the taste of the material that is ingested, and then associated symptoms. That is very often.
So, according to what Sir said, all the history was taken, it was found clear, and only thing we found that this child was extremely stressed when it came around exams. She used to lose sleep, she used to lose appetite, her performance was always a problem for her, and she was a generally a quiet type of a child. So, with this possibility, with a show of hands, who would vouch for stress-induced gastritis among the audience, intracranial tumor, cyclic vomiting, or torsion pneumothorax? Any, say it loudly. You would think of stress-induced gastritis. Okay. So we have gone through these causes in a young child. Sir has briefly, summarized, and this is something that you can find in any place. What are the common causes in a young child for vomiting? And we thought of acute gastritis in this child, recurrent episodes of acute gastritis, mostly stress-induced. And again for Tina, if Tina were a 12-year-old who had weight loss, who was vomiting when lying down, and she had postprandial abdominal pain, what would you think of? Torsion ovarian cyst, bulimia, superior mesenteric artery syndrome, or CNS tumor? C. So everybody knows about this, sudden weight loss causing the pinching of the duodenum. Okay, fine. We have a wonderful audience here. So, okay.
Comment about superior mesenteric artery syndrome. The sonography findings classical, angle less than 22, distance between the aorta and the superior mesenteric less than 8 to 10 millimeters.
But again, this is something that you would need to alert the sonologist about, because most of them won't see this. Yeah. So in this child, examination was all normal, and there was really a whole deal of anxiety there. So a gastroscopy was done, and I want you to pay attention to this picture. Look closely, please, because it's a poll. Okay? Yeah. So there are 4 options. Is it atrophic mucosa? Is it ulcerative gastritis? Is this normal, or does this look just generally inflamed? Yeah. Yeah.
the options are atrophic mucosa, ulcerative lesions looking like gastritis. Is it normal or is it inflamed one? Okay, so this is why I put it here, because I too thought this is an ulcer, but this is normal. A few erosions are normal in a gastroscopy, and this child's gastroscopy came out completely normal. There was no H. pylori in her biopsy as well. So in this child, what would you do next? Would you do an MRI? Would you try PPIs for 6 weeks, or would you counsel her and send her back with lifestyle modification, or would you repeat the H. pylori treatment? C, yeah, average. Okay, so I think here I would just ask people to say a few words, because I think I have saved enough time.
H. pylori is diagnosis of biopsy. So empirically one would not repeat it. And prolonged PPI would also be recommended if there is a repeated or chronic gastritis kind of a symptom, of course with counseling and behavioral modification. That is what H. pylori, though I think very often talked about, unless you have done histoscopy and biopsy, when you do the PS test or the staining, you will not repeat the H. pylori.
So, since sir is on H. pylori, I would like to ask you the next question, and that is, which of the following statements of H. pylori is true? A, it is uncommon in India. B, it's an adult thing and we don't have to bother with it. H. pylori has been proven not to cause gastritis, and the last one is almost 50% of children are affected by 10 years of age. Just give us the answer. Say it loudly. D. Yes, that's right. And it is true. And here again, sir, if you can just elaborate further on what you were saying about H. pylori.
So H. pylori, there is tissue damage, there is chronic inflammatory changes seen in the gastric mucosa, urinary mucosa. And once you make a diagnosis based on biopsy, you treat with the PPM, then your amoxicillin and clarithromycin. And that kit has to be, and then beyond this 2 weeks therapy, you need to continue the PPM. You suddenly withdraw the PPM, the symptom may return. And unless you have a definitive diagnosis, I mean, it's not worth giving empirically repeated course of PPM. I mean, pylori.
Next is this poll again.
Is it 50% colonization or a cirrhotic disease?
Colonization. Yeah. So to diagnose cyclical vomiting, all criteria must be, listen carefully, must be met with, except A, the child continues to have mild symptoms between the episodes. B, a minimum of 3 episodes over the period of 6 months. C, vomiting at least 4 times an hour and intense in nature. And B, A. Everybody says A, and that is correct. The child does become completely normal between the episodes. And Dr. Rehan, quickly going through very quickly, sir.
Cyclical vomiting patient is around 5 to 7 years of age approximately, that is the age group. And they generally come with severe vomiting episodes more than 4 to 5 times in an hour. And it is a stereotype, like next time a week apart, again the child may get again the similar time and the similar pattern. And that is very diagnostic of a cyclical vomiting. Thirdly, in between the episodes, the child is absolutely fine. So these 4-5 criteria are very important. So in between there will be no problems at all, and then you have a stereotype pattern. In fact, it sticks to the day that when you get the first episode, the second also sticks to that type of pattern. And that is diagnostic of a cyclical vomiting.
And whatever we said about the migraine and tension type headache, it is applicable to cyclical vomiting. I remember similar things. And if cyclical vomiting is not treated, some of them go to migraine. That we discussed earlier. Remember that?
Yeah. Thank you, sir.
So, I have a question regarding cyclical vomiting. So, this is a practical case which I have seen. I wanted your opinion on that.
I will just
one question which is very specific.
Can we take it in the end, please? I have a
catamenial vomiting and role of estrogen patch therapeutic role.
Sir, can you take this answer in the end, please?
Yeah. So, Aunties, I wanted to put forward my question.
Yeah.
Answer that.
I think we can decide.
Yeah. So we have one short, quick case. So I'm really sorry. I have only 5 minutes to
question, and we will discuss it.
Because
should we
Sir, will answer it, sir. Okay, so this is a 3-year-old child. I want you to focus on this picture, and only stale food in vomitus is a key over here. repeated episodes, almost looking like cyclical vomiting with 7 to 10 days gap in between. The main thing is that this child is growing well and with the stale food and vomiting. What are the possibilities on history? Do you think it's GER? Do you think it's IEM? Do you think it's just faulty food practices or it's a surgical abnormality?
Can you just go back?
Yeah. Sorry.
Okay.
9 months.
Next. 5 minutes.
5 minutes, okay.
You're
Yeah,
fast.
I can slow the train.
Yeah.
Yeah, so.
Next one. Next.
Yeah, so this child received PPIs several times in the period of these 3 years, and there was no significant improvement. But since the child was growing well, the pediatricians just were happy to diagnose this as reflux and continue to treat this. So now I think you can answer this question. D. Okay, who else? Okay, I think I have gone beyond this thing. So everybody agrees with the D. Who thinks it's GER? GER?
Was the vomiting bilious?
Non-bilious.
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 Why D? We didn't. Why D?
Yes?
Answer is D.
No, the answer is D. The answer is D.
Surgical
The
abdomen.
reason is it was stale vomiting, and I'll tell you why. Okay, so now I'm really going to slow down because it's too much. So this chronic vomiting, when it comes to chronic vomiting in an infant, Dr. Zob sir, would you like to quickly brief on what are the possible causes, especially in infants?
Yeah, it is very important. Sagrada Padma is right. See, whenever a child is brought to you in the first year of life, always divide the child into different groups. So, in the first few months, between 3 to 4 months, we all know that the GER, okay, that is the child will only effortlessly regurgitate. The milk will be the same, it will not be usually curdled. I call them as Balakrishna Oak. Balakrishna because he is very chubby, and Oak because he vomits, okay? So, he is Balakrishna Oak. Now, there is another one who is GERD, that is a disease where there is a reflux. So, the acid is coming up, so there are signs of esophagitis. So, the child is getting pain. Bolta hai nahi, so he is arching. Okay, so that is GERD. If the child is say little older, 6 months, 8 months, right from beginning, whenever he becomes sick, he becomes worse. He has failure to thrive. These are incompetence of metabolism. Refer to the experts. Okay. If the child has vomiting with bilious vomiting, molar formation, visible peristalsis and all, that is obviously surgical. And congenital hypertrophic pyelonephrosis, again there will be vomiting, but as Vijay was telling you earlier, if there is obstruction at the lower end of the esophagus, as in case of achalasia and others, the child while he is eating, drinking, he will bring it up, and there will be episodes of choking. So roughly remember that there will be problem in the esophagus, problem at the gastric outlet, problem in the duodenum, and if the problem is above that ligament of Treves or the ampulla of Vater, there will be non-bilious vomiting. And if it is below the ampulla, it is bilious. And if it is much beyond, say, duodenum or ileum, or rather jejunum or ileum, it may be feculent in rare cases. So, like that, you can approach.
Thank you, sir. So,
and obviously, if the child is having fever, bulging fontanelle, and others, intracranial infections would be there, and urinary tract infections also can produce vomiting. Right? Is there.
Okay, so this child on examination is quite normal, no deficiencies, nothing. There is mild distension in the upper abdominal region, and the auscultation shows a gurgling sound in the left hypochondrium. The investigations, there is a peripheral smear which shows microcytic hypochromic anemia. Apart from that, everything is normal. Now, in this patient, what investigation would you like to do? Would you further do blood investigations like renal parameters and pancreatic enzymes, or would you investigate for food allergies like we discussed, or you would do or a variant? B. Okay. Thank you. That's the correct answer. And because this is the report we got on the barium, I want you to see this closely. Because the question that follows is this. What is the likely diagnosis in this child? Malrotation, achalasia. I will show you the picture. Duodenal obstruction or Hirschsprung? The header is there to guide you. Anybody thinking anything loudly? Duodenal obstruction. Very correct. This child had dilatation, that's such gross dilatation of the stomach at the first part of duodenal. So much so that this child was okay for 3 years of his life, and because it was a partial obstruction, it's sustained, It was a duodenal web, a gastroscopy was done, and we know that duodenal webs can present in a subacute fashion. This was the endoscopic dilatation that was done in the child, and there was significant improvement in the child after the dilatation. There was weight gain, and the child started taking solids. So these are the red flags. I think we have gone through the red flags. Sir has very nicely summarized everything. Dr. Yevle, would you like to talk about FPI since there is time? And then Dr. Parul's question about the estrogen patch in cyclopedia.
This food protein induced enterocolitis syndrome. Very often, again, many times wrongly implicated, but typically such children would come with sepsis-like picture. They have severe vomiting, dehydration, they get hospitalized, they have to be on parenteral fluids. To discharge them, with the repeat trigger, again they come back with the similar kind of picture. Of course, all other tests for sepsis and other things are negative. So they have to really go into the details of history and find out if there is a particular food allergy.
Do you see it, sir, in practice? So it's a very rare.
Extremely rare.
So then, up to you to answer the question on the estrogen patch with.
Quickly, one last point. We have not said much about GERD. Just remember, it is again G is again GER. We have another reflux rise. E is extraesophageal symptoms. It could be respiratory. R is respiratory, and D is dietary related, means failure to thrive. So GERD basically is not the cause of recurrent vomiting. It presents differently. It has a cause of recurrent vomiting, but not a common cause, because the presentation is a bit different. They come with failure to thrive or infections or so many things. And it's just I thought I would clarify.
Thank you, sir.
Yeah, I think Parul, you had a very good question. You just asked about catamenial vomiting and the estrogen patch. These young females who are menstruating, they also have these episodes of CVS, that is cyclical vomiting, and it is found that estrogen levels go down, and therefore by supplementing with those patches, there are a lot of studies done on that. The results are good and they abort those attacks, but it's not confirmed, but there are a lot of studies on that. So I think as you said, estrogen patch should help in these patients.
Parul, you have time. Come forward, please.
So as general pediatricians, I don't consider myself as just a general pediatrician or an intensive general pediatrician. We should start having the confidence, I think, to start treating such patients with the adolescent medicine. To treat with the estrogen patch, we should know more about it and start learning and practicing. Because one case also is good enough to put us into a
Anybody in the audience that has experience like Dr. Parul has here? Ambedkar sir, would you like to?
How to prove it, but prove the levels or helps clinically.
What?
Clinically, this patient has vomiting, which is classically fitting into your cyclical vomiting. There a female who is just menstruating female, and that point of time, and you have to do the extra levels, you can't confirm without that. Once it is confirmed and you treat them, they do well, that's what the papers say. A lot of studies are there.
This was a critical case, and ultimately we had to call a gynecologist because they have the confidence. So I think we should also, as pediatricians, we should be knowing about it and discuss it and then put it into practices. So I think that's what I suppose we should discuss. Thank you, sir. Thank you.
So again, this checklist, I think I was told 1 minute. I think quickly I'll go through it. Detailed history, like sir said, extremely detailed history is what is going to get you to the diagnosis. Or always ask about the type of vomiters. If it's stale, there is generally an obstructive pathology. And with raised ICT, check BP. This is something which we pediatricians are a little hesitant to do. Growth, always assess growth. Auscultate if there are any adventitious sounds. Vomiting in a fasting child or with specific food. Then you should look into IEMs and even other metabolic causes. And cyclical vomiting is a diagnosis of exclusion. Rule out everything before you label this child as cyclical. Thank you very much, and I want to thank Dr. Dimple, Dr. Goplani, Dr. Omkar, as well as Dr. Who else?
Vijay.
Dr. Vijay. He's not here. Okay, this would have really torn me apart. Thank you so much for your patient listening, and I hope we've ended in time. Thank you. Thank you to the experts. You have been great. They really took the whole thing really smoothly for us. Thank you so much, sir. Thank you.
Thank you very much for the most practical inputs. Thank you, Archana Madam, for finishing in time. A good night's sleep is what we all need, and so do our little angels. I call our expertise on stage to address all the sleeping disorders in case Dr. Indu Khosla Madam. And Dr. Prakash Vande sir. Dr. Indu Khosla Madam, pediatrician, pulmonologist and sleep expert at NH SRCC Hospital for Children and Lilavati Hospital. Dr. Prakash Vande sir. Dr. Prakash Vande sir, senior pediatrician from Fortis Hospital, Mumbai.
Vaishnavi saved the best for the last, right? We welcome you all to this post-lunch session. I hope the sleep disorders have kept you awake and the sumptuous lunch, I hope, doesn't make you sleep. So we go on to a Pandora's box of the OPD case scenarios. I welcome on the dais Thane sir and Chokhani sir. So we start with the first keypad question. Delhi is burning hot right now, you know. So this is the first keypad question for the audience. Can I have your attention, please? If you can sit down with the plates. The delegates, it would be a request from our side if you can occupy the seats so that we have a good flow of the session, please. Thank you for doing this. So, this is the first keypad question to just tease our grey cells in an entertaining way. ट्रैफिक में हॉर्न बजाने से क्या होता है? लाइट जल्दी ग्रीन होती है, सड़क चौड़ी हो जाती है, गाड़ी उड़ने लगती है या कुछ नहीं? Can I have the hands? I think most of us are awake, and so we straight away go to the session. We are missing Balsikar sir here. He had a family emergency, so he couldn't be here for the session. And we are missing his inputs, but I think the justice will be done by both our expert panelists. So we start with our office. Correcting. In our day-to-day practice, we encounter multiple dilemmas, and it sets the ball rolling between the interaction between the patient, the caregivers, parents, and the treating doctor goes on. So we just enlist some of the cases that we're going to present to you. So the first question, just can I have your keypads, just show them please. The first question is a keypad question. A child with constipation can present to our OPD with symptoms of pain in abdomen, encopresses, UTI, or any of the above. Should we? Yeah. It's nice to see you all settled, and with the keypads. I think the audience has been absolutely awake and I think has hit the bullseye. What do you feel, Chokhani sir? Would you like to add on?
Yeah, so obviously all of the above, but the thing is that we must remember that if we look at it the other way, this session is on constipation, but if we look at it with as a child who comes to us with pain in abdomen, constipation is a very important cause, and unless we fish out the history, we won't get. Similarly, a child whom we are suspecting UTI, we must look at constipation in the background. So when you look at those symptoms the other way, you must remember constipation.
Yeah, because whenever there's a visit to a nephrologist with recurrent UTI, even the nephrologist asks that as a first question to the parents that does the child have a history of recurrent UTIs? So yes, that is one of the, any other symptoms that you would associate it with like enuresis or anything else, Sane sir? Coming in with constipation, because we're talking about constipation now.
I think daytime restlessness can sometimes be there, and otherwise obvious features like hard stools and avoidance to pass
Yeah.
motions, and those are the typical
Some of the
stools.
features that we would not ask on a routine basis is like what I'm asking about. That if
Absolutely.
Can I just add something? Yeah, I mean, we've had children presenting with so-called diarrhea, which was actually ancopresis,
Yes.
overflow incontinence, and they were basically having constipation. That's one of the things to be.
Absolutely well pointed out, sir. So we're going to the history. This is a 2-year-old male child who comes with history of constipation since 1 year. It has increased since the last 1 month. He passes hard stool with straining, which is like Bristol stool chart type 3. And occasionally it is even 1. Passes stools in a standing position. This is what we usually ask the parents, you know. Blood in stools was only 1 year ago. After that, there has been no history of any blood in stools. The deworming has been done. The urine, all the history of, related to the urine has been normal. He continues to bottle feed at night with formula feed. So just going back to this, we want to just ask the audience, how many types are there in the Bristol stool chart? Would you just put the time? Okay. You put the time. Okay. So, sorry. Is this, how many of us really hand the Bristol stool chart whenever the child comes, or do we ask for a history of Bristol stool constipation? How many of us, can you raise the hands? I think that's a good number. So I think our answer also. Okay. So the answer is, as most of us have pointed out. So this is the Bristol stool chart, which is very freely available, and this is also important to maintain a diary. We'll come to that later. So the dietary intake, when we go into the detailed history, dietary intake is very important whenever we are dealing with the case of constipation. So the total consumption of water was about just 2 to 3 glasses, like 600 to 700 ml in a day. The diet was low in fiber, less fruits and less of green vegetables. He was eating biscuits daily. When we inquired, he would finish a full packet of Parle-G or maybe half a packet of Marie biscuits at one go. And he still continues to bottle feed, that was mentioned. So, to the audience again, a keypad question. I think we will put the timer on, start the timer. So what is the impression on history? Whether it is a functional constipation, it's a Hirschsprung disease, C is celiac disease, and D is any other cause can you think of at this juncture? I think it is, I'm going to expect a big number of audience to be answering this rightly. I think the battle is already won here. So, yes, as rightly said, functional constipation. Sir, Sani sir, would you, I mean, you definitely would agree to that, but are there any pointers which we would think at this juncture that
I know. I mean, let's think of Hirschsprung's disease. The child would come in a totally different way. Probably presentation right from the beginning. Delayed passage of stools is common, and abdominal distension is a predominant symptom, and not hard stool. Almost never ever bloody stool, and never encorposis or fecal soiling. this is the way I think Hirschsprungs will come. I think functional constipation, celiac is, I think, one way just to extend illness. The functional constipation, although there are certain very good pointers in the history that tell us that it's a functional constipation. And I think it's not enough to diagnose it as functional constipation, but we should know the etiology behind that functional constipation.
So when we talk of any other cause, so I think the good history, as Sudhir said, growth of the child and examination will either make you suspect or rule out any other cause, because 3% or 3 people did vote for any other cause. So to complete that, we need to look at the growth of the child and also a thorough examination. Maybe I would ask the audience to pitch in. How do you fish out a history of constipation? So we discussed that constipation, so somebody comes to you with pain in abdomen. How will you know this pain in abdomen is due to constipation? Can we ask some questions to fish out that history? Here we were lucky to get a history up front. Okay, so time taken, long time taken in bathroom. Is short time taken also constipation? Yes, it can be. So both extremes. So taking half an hour and taking 2 minutes, both can be constipation. What else? Yeah. So the problem that I have is that the parent doesn't know, because the child goes on his own and the child is busy in the washroom with some other thoughts or some other things. So they don't know, or mobiles. So they don't know whether they are straining. So nobody knows whether they are straining. So that's a difficult thing in the history.
Also, there could be an immediate rush post meals. So no regular defecation, but post meals, if there is a rush.
So I thought these 2-3 things are important, that going 3 times a day doesn't mean no constipation, or going for a very short time and coming back doesn't mean no constipation. So these are some things that we must know in the history.
So just one question.
Absolutely, irregular time.
The child may go once in the morning and the next day he may not, and the next evening he would go. So that is also a pointer.
So just one question. This child, the onset was around 1 year of age. Is that concerning, or?
So we'll have to get into the details of the diet history. So what was the diet till 1 year and then what happened. Secondly, I think most mothers nowadays are wishing to enter the Guinness Book of World Records as to how early they toilet trained their child. So if they started toilet training around that time, that could be another reason.
And note that the child had blood in stools at around 1 year of age. So a painful experience while passing motions can trigger phobia and fear. So I think that's one thing that we should be.
On examination, as Chokani sir mentioned, that we should definitely go into the details. The weight was 11 kg, which was in the 25th centile, with a height of 88 centimeters. The vitals were stable and there was no pallor. Per abdomen wise, there was fullness, which was a little gaseous, but it was soft. And we couldn't feel any fecolates. There was no perianal redness, no sacral dimple or any tuft of hair. And on PR examination, there was stool, which was, palpable. So, what are the... This was gone.
What are the important pointers in history and examination? I think sir has covered few of the points. Could you add on some?
So I think standing and passing motions, and if we ask in detail whether the child is doing anything that is called holding maneuvers while passing motions, would be very important. Typically such child goes in a corner, he is very comfortable till he gets that reflex to pass motions. Then he goes in a corner, puts his, kind of both the legs in adducted position, tries to hold back the motions and starts sweating till the reflex passes. And then he might or might not pass a small amount of stools, relieves himself, and then becomes back to normal. That's one important pointer that we should ask for. I think bottle feeding is the second thing. I have my own thoughts about free water and constipation. I have a feeling that excessive free water or dilute milk actually causes lots of urination and decreases the amount of solids that the child takes and leads to constipation. I think Dr. Rajesh can.
No, I agree with what Sudhir says, so that's definitely important. So I think important is that, see, there are Hirschsprung, there are many types. The others will be little more obvious in their presentation. The ultra short segment is the one who may come with isolated constipation and we may get confused. So right from birth, delayed passage of meconium, then constipation starting right soon after birth or like on within the first 2 days. Now here the history of feeding is very important. If the baby is top fed, then we know that formula feeding can also lead to constipation. So we will lose that marker. But a breastfed baby with hard stool is definitely pathological. So that will be our clue. And then of course that Hirschsprungs don't have soiling and Hirschsprungs, those other points. Yeah.
Hirschsprungs when they pass stools, it's almost never hard. It's really, well formed, maybe pasty, but it's not hard.
What is the age that you would really think of Hirschsprung? You know, if you're seeing a child coming with constipation at the same child, but not resolving to maybe, we will come to that. But
Because breastfed babies initially are constipated. So when will you think of Hirschsprungs?
No, so breastfed babies initially constipated is, again, we need to get into what is constipation. So just infrequent passage of stools is not constipation. So I will not call them constipated. When they pass after 3 days, 4 days, 5 days, it's a soft stool. So therefore that is not constipation. So where I get a history of a hard or a scanty stool in infancy and is not top fed, then only I will think of Hirschsprungs. So onset of constipation is when I will first think of Hirschsprungs. Otherwise, once I have treated him for functional and I have failed, at that point I will go through my mind again. Okay, am I missing something and do I need to look at some other causes?
Very rarely, but sometimes there are cues to non-functional constipation. Like a child, as Rajesh said, failure to thrive. If there are recurrent infections of enterocolitis which required resuscitation, if very bulging abdomen, gaseous distension of the abdomen, because remember that in Hirschsprungs, there is difficulty in not only passage in stools, there is greater difficulty in passing flatus, and that's because the myenteric plexus doesn't relax. And such kind of things, and of course difficult to treat, one might think of it, but low on the card.
This is the question for the audience. Are there any red flags in this particular case and will you investigate? Yes or no? The timers can just have an opinion. Okay, so everyone says no. So let's see what the red flag signs are. Sir, can you tell us, Thane sir?
So we have been discussing again and again, I think failure to grow, very acute onset of constipation. Then suppose we think of surgical causes of constipation, then we would think of whether there is any bilious vomiting or vomiting associated with constipation every time. That would be something that would worry me. And I think
developmentally slow child, because that's another thing. And about blood also we have to be careful. So see, repeated passing of blood is a red flag, but a one-time event could be because of one hard stool causing a cut and a fissure type of a situation.
So these are the red flags enumerated, just like both Thane sir said. We'll go ahead. These are the abnormal physical findings which you have to look for, especially to rule out organic cause in a case of constipation: failure to thrive, tuft of hair over the spine or a sacral dimple, sacral agenesis, flat buttocks, tight empty rectum, and absent anal wink and cremasteric reflex. We go ahead.
would you like to highlight any more pointers, sir, on examinations to rule out any? I think we've covered most of the things.
so I think extreme pallor, well, not extreme, but pallor and associated vitamin D deficiency. Okay.
We'll come to that.
And the question is to you only, sir, that how is anemia or vitamin D deficiency relevant in a case? You put anemias first in a case of constipation. Is it a, what do you say, a cause and effect phenomenon,
No.
or it is only the...
It's association. Yes. That possibly constipation, this kind of inpatient, these patients are usually well grown, but they are anemic and they are constipated, usually on excessive milk diet. And that also automatically means that usually they are on bottle fed and taking large amount of feeds at night. So it's nutritional, and possibly so is the vitamin D deficiency.
So would you investigate a a child who's coming with functional constipation, would you, when you're investigating, would you do a CBC on a routine basis? No.
I mean, routine in my outdoor patient I wouldn't do. But because the cause I know that it's possibly iron deficiency anemia, but that can be debatable because now we can do a blood test and do repeat blood count after 3 months, but routinely I wouldn't do.
So would you treat
So,
here?
on one more thing is when I'm treating anemia with iron deficient iron, that also causes constipation. So,
So when we have red flags, as we had mentioned, how would you investigate this suspected case of constipation who comes with some of the red flags, like if there is blood and stools, or if we suspect that there is, even in the slightest of our mind, there is Hirschsprung's, which is weak. So the line of investigations, how would you go about writing on the OPD sheet for?
So first thing is that if I think of Hirschsprung's, and Rajesh will agree or
If there is failure to
can
thrive or
disagree,
any other-
yeah. So I will go back to history again and take a very detailed history that what really happened since birth, because it's not uncommon that the child comes at 4 or 5 years of age and the mother says that, or father says that constipation since birth. Then you have to pause there and ask whether really it was there at birth, and then they would say no after 6 months or so. Then you think what has happened. So I think history important. Then, as you have rightly pointed out, that in certain patients, if you are thinking of Hirschsprung's, then you might do a per-rectal examination. In my last few years of practice, I have hardly done per-rectal examination in a functional constipation if I am not thinking of Hirschsprung's. In small neonates or paraneonates, say 3-4 months with abdominal distension, constipation, and some history, I do that. But otherwise, I don't do. And then subsequently, one would have to go to a surgical opinion, and under surgeon's guidance, at least that's what we do, a barium. Rajesh, any other idea?
yeah, I fully agree. So, the investigations to screen or try to confirm is either a barium or a anal manometry. Both have their pluses and minuses. Both are not foolproof. But I think by then the surgeon is already involved, so then they take a call.
So in this scenario, if we suspect, we would, instead of writing, we would refer to a pediatric surgical person to go ahead.
So anything in an older kid, a 10-year, 11-year with acute constipation?
So here, that's what, this depends on the cause that we are thinking. It's just not that, red flag signs. What are the red flag signs indicating you? Is it indicating you Hirschsprung's? Then you will take that line. Say, for example, if a failure to thrive and constipation, you might ask for polyuria, polydipsia. Is it renal tubular acidosis? It is hypervitaminosis D, depending on. So again, the clues will be history, and I think clue will not be in irrational or multimodal investigations.
So specifically, if it is failure to thrive, it will not be monosymptomatic constipation. When you dig into the history, you will get 4 other things which may point you to a particular direction, and then you investigate accordingly.
Nice point. I agree.
So the question to the audience is, parents were given advice on diet and toilet training, which we would do in any functional constipation, and asked to maintain a diary. What is the next step in management? Would you give stool softeners and follow-up? Give enema and SOS suppository? Give probiotics? Or would you like to investigate further? I think most of even the hints have been given by our panelists that, but still, what would be your opinion to go ahead? Yeah. So, yeah, I think most of us agreed to that.
I would like to ask you, Dr. Chokhani sir, what would be the preferred pharmacological treatment that you would choose? Would it be a lubricating laxative like a mineral oil, or senna, or stool softener such as PEG, or osmotic laxative such as milk of magnesia?
So I think our first choice should be PEG wherever it is possible. So because that is believed to be most physiological, etc. Senna is a stimulant laxative which you should not use as a first line at all. And mineral oil, milk of magnesia may be used, personally, I stick to using PEG most of the times. And in a small baby, when administering PEG is difficult, in an infant around 1 year, etc., then lactulose is an option.
So can we go back one slide? So this child I was alluding to, coming to the real cause of functional constipation. And in this child, if you think that it is because of pain and fear while passing motions and phobia, then we must avoid giving enema and suppository at all costs, as much as possible. Because the child gets severely traumatized even when we try to do that. And the other thing is, unless you are taking that in your next thing, is how long you give treatment is going to be extremely important.
So this is not only if this started with phobia. In general, enema and suppository has to be underemphasized or avoided as far as possible.
Point very well taken, sir. This is a question which Thane sir already mentioned. So question to the audience, when to discontinue treatment with stool softeners? Is it 1 week, 1 month, 3 months or 6 months? We can start the timer, please. And I think this question is extremely important because we are really not aware of the guidelines.
No, and it is also that we, just give the message to the parents properly that it is important to continue the treatment. So
we have mixed answers.
You've got a signal from the audience that they want to be involved in the discussion. So now I think ask everyone to justify ABCD.
So someone said 1 week. Can someone say why it is 1 week that they thought of?
Because it is costly to continue PEG.
Parents discontinue it in 1 week.
So I.
No, that's what the emphasis has to be laid.
So yeah, so how do you avoid that? That how do you avoid them discontinuing in 1 week? Suhas, you are an expert. Sit. Someone. Come on, how do you avoid them discontinuing in 1 week?
Allow Suhas to also speak. Yeah.
Yeah.
Please take the mic.
I think they need to be counseled that the rectum is not like a rubber band that it stretches and comes back to its normal size. With chronic constipation and fecal overloading, it will get progressively dilated. For it to come back to its original tone and size, it needs conditioning, which of course cannot be done in 1 week. Frankly, I said 1 month, I might be wrong, could be 3 months or 6 months, but the physiology is this, that it needs a longer treatment.
So I totally agree with you, Mamta. And I think so counseling, and one thing that we should address directly in such patient is many patients are worried about giving medicines for something as natural as passing motions. So you tell them that, as Rajesh said, that this is one of the physiological laxative you need to give. You need to emphasize not only the anatomical changes that happen in the rectum, but I think phobia. And I personally believe that none of these options are correct. I believe that till the time child starts passing motions on his own while sitting position, which should be natural, we should continue, and that we should tell. And not only that, this functional constipation because of phobia has tendency to recur. So in our OPD, what we do is, even when the patient becomes all right, we give them 6 p.m. rule. And what is that 6 p.m. rule? That every day till 6 o'clock in the evening, if the child has not passed motions, you give to a PEG. And so that next day, child passes softer motions. It doesn't go back into cycle of pain, fear, phobia, holding, again pain, fear, phobia. So you do that 6 p.m. rule.
Exactly.
Any medicine.
Absolutely.
So
most of them are worried की त्या औषधाची सवय होईल का? That's what.
Suhas, mic देना.
We have parents explain them this is not addicting medicine and they will start passing stools on their own even without medicine. But till that time they have to support.
And in fact,
That
if you
is most
give
important.
intermittently, it might be addictive because then you have to keep on depending on the medicines because you are not addressing the basic problem. Like Mamta said that lack of elasticity of the rectum or psychological problem.
Yes.
So here maybe one thing to add is to tell them that this doesn't get absorbed in the system. So that helps them realize that there can't be side effects. So that is one important thing to add. And yeah.
So on our OPD paper, what do we write? Come after 1 week, 1 month, 15 days.
No, so I actually give them a, so see these kind of problems now, one of the most important things after counseling is to give them a line to come back to you. So I gave them a freedom that give me a ring after 4 5 days or 7 days, whether he has passed enough motions, whether he is feeling better, whether it has started softening, all those things. So those kind of communication lines are important so that they feel they can ask their little bit of queries. Then of course the follow-up will depend on the results, because you also need to titrate the dose. So initially you let the pendulum swing on the other side, and you can actually tell them that I don't mind 2 or 3 loose stools, but I want him to pass a soft stool every day. So that is my bottom line. And therefore you need to titrate the dose and then go according.
Actually, sir, that's what I was coming to. You should give them the freedom to titrate the dose on their own. Then give them a range that you can go from here to here till you pass 2 soft stools a day, or slightly on the...
Absolutely. So that would depend on, I think that would depend on their sort of intelligence level to do that. Otherwise, but we need to titrate the dose.
And as Pooja's question, I'll write at least for 6 weeks, but don't stop before consulting with me. Yeah, Geeta.
So, but here we are not addressing the basic cause. So the diet is the main factor which
Coming to that. No. It is just we were discussing this point. She already said when she talked of stool softeners that diet has been advised. So
Changes first, which we have not mentioned on the slide. Stressing on the toilet training part, this slide is quite self-explanatory. We go to the next one. Yeah, we are done. This is the flow chart just to guide us about the duration of treatment and the line of treatment we follow. We can also skip that. So the take here are: use a Bristol stool chart and OPD to diagnose as well as evaluate the effectiveness of treatment. When the patient comes back after the PEC therapy, we can actually ask them to plot the chart again. Identify the red flag signs and investigate accordingly. The dietary history is utmost important. Toilet training plays an important role in constipation management, and we need to spend that extra 5 to 10 minutes with the patient, teaching them what is to be done. Thank you.
Pooja, it's the, here it's the other way around. If it's 2-year-old child, toilet training should not be started at that stage. It's only after 3.5 to 4 years of age that you make,
So when
I
the
had
child
a
is ready.
comment here. Sorry, I'm taking just a minute. So I feel the diet should be changed first, and toilet training is the most difficult thing to do in these kids who are so scared of passing stool. So unless we have changed, and then maybe in the next week when the stool starts becoming a little soft with the medication and the diet, that's the time we should get into toilet training, is my thought. And there is a very nice article I read which talked about the fiber content of food. And I'd like to just quickly share it with the people here. So we typically say, don't give the maida products, right? And we say, okay, increase fiber, eat green leafy vegetables. But this was an article which analyzed the fiber of each foodstuff. And in that, drumsticks was the highest amount of fiber, followed by lady's finger. Of course, spinach, carrots, peas, corn. Corn has a very rich fiber content. To my surprise, they mentioned black chana, because raisins, black raisins, coconut, dates. Dates is again which children eat very easily.
And rava. Rava has very high.
Yeah, black chana and green akha moong. So these are things which we can easily inculcate in children's diet and it will help them a lot.
Sorry.
And
so while I agree with you, Indu, that dieting counseling is must, but if the child has reached this stage that child is standing and avoiding manures, dieting is not going to be helpful here.
Medication.
Only diet, so medications has to be the part. So
after medicines, diet, and last I
both
think
of them
should
together,
be,
maybe.
Medicines and then toilet, because sometimes they are so resistant to sitting on the potty chair.
This was a session of constipation. We thought we'll include the toilet treatment. as part of
So this fiber issue is a little complex. So there is insoluble fiber and soluble fiber. Insoluble helps promote laxation, but soluble produces stasis. So ultimately what will be the end result will depend on a multiple conglomeration of factors. That is one. And my plea to all of us is that at the 9-month vaccination, let us do anticipatory guidance by almost telling them don't get into a competition of toilet training. Wait for the child to mature and then start, because that will avoid so many cases of constipation.
Thank you, sir. Thank you, madam. Point well taken.
So the basic concept is that when the child is generally, we have a subset of children who are too much on milk. So they are on kind of milk addicted, because of which other foods and fiber and all those intake is reduced. And that is why you need to reduce that milk. Now, whether to tell them to stop completely, I tell them, because my belief is that if I tell them thoda dena, then that thoda has no limit. So for once, as I said, the pendulum has to swing on the other side. Once you have controlled everything, then you can again tell them that once a day or twice a day max is allowed.
Yeah, I agree with Rajesh, and I think it's not the milk alone, but it's bottle which was responsible for that excessive milk intake. So you might give them a choice that you can continue milk but stop bottle. And how much milk? It should not be more than 250 ml of milk in a day. So that's not more than 2.5 cups of milk in a day.
We move ahead.
Well taken. We'll move ahead.
Can we take the questions later, sir, please?
Sir, if you don't mind.
Sorry?
We have a second longer and interesting one, a more interesting case. So please wait.
I will just, this was just to keep everybody awake, but I think everybody is very wide awake, so I'll just go to the history. This is a 12-year-old male child brought with history of dizziness associated with a fall. He's come to the OPD while returning back from school. There was loss of consciousness for few seconds. It was a blackout kind of feeling, and he recovered in few seconds. Onlookers mentioned that there was a pale look on the face with no involuntary movements which were questioned to them, and he rose up to a sitting position without any support. There was a history of drama rehearsal going on in the school for a prolonged period. There was no history of any headache, chest pain, palpitations or trauma. No history of any similar episodes in the past. And on questioning, there was a history of migraine in the mother. So the keypad question to the audience, I mean, we can just raise our hands and just answer. What are your thoughts? And I think that is pretty obvious, and I think the experts also.
At this juncture, sir, would you like to add what?
Only one thing that here, yeah, yes.
Yeah, so, yeah, that can be a reason. No, it was mentioned by the onlookers, but he had a little bit of sweating when asked.
So I think, Anita, the most important point here is what was the child doing when the syncope occurred. If we can get history, it's often difficult because there are bystanders, someone. But if you know that he was walking and he fell, I would be extremely uncomfortable to call it a simple syncope. After walking, he stood for some time and then he fell, I would be very happy to call. So that differentiation is absolutely important. And here, while returning from school, it needs to be, this needs to be kind of enlarged.
Yeah. So this is, and about hypoglycemia, my concept is that hypoglycemia is not that sudden, like we are typically used to syncope. So that child will feel a little weak, will feel little hungry, things like that. There'll be a few minutes. And
respiration, I think, would be an earlier sign of hypoglycemia, as you rightly mentioned.
But it can also occur
it happens later. So, what are the pointers? Sir, would you enlighten Thane sir or Chokhani sir? Anybody?
So I think, as Sudhir said, what we must try and do in this situation, this is a sudden collapse clinically. So we must try and as in our childhood days, we used to listen to radio commentary and they used to say ball by ball cricket commentary. So literally you have to get a second by second account of what happened. You try to get that. Now usually you will have to get it from the people who saw it. So if it happened in school, you have to literally tell them, make me talk to the teacher or whoever. So it need not be the parent who has come with the child or friends or whatever. So those immediate preceding events are extremely important. What happened first? So in a seizure, the first event, whatever they will describe, is some abnormal movement, and then those movements will progress, and then the child will lose posture, and then, whereas in a constipation, if the child, or in a syncope, if the child is big enough, you ask the child, what did you feel just before that event? And the child might also give you some symptoms which suggest a prodrome. Finally, of course, eyes open and eyes closed is a very important difference. So in syncope, the child's eyes will be closed. Seizure, often they are open. The time taken to get back to normal, here it is very brief, here it is long. So these are the differences.
And one textbook of neurology, it is very nicely mentioned that in syncope you fall like curtain, and in seizure you fall like a log. So you gently fall. So hardly, of course, there have been incidences when there have been trauma after fall. But if there is trauma, then think of syncope as less commonly. And what you mentioned in the history, change in the color of the face. If anyone has noticed pallor or change in color, that makes seizure extremely unlikely.
So I think we've already spoken about, but could you just highlight, Thane sir, on the key elements that we have done during the...
So what about family history? This child had a history of migraine in the mother.
I will keep it at that. Migraine is not uncommon in the routine population. I wouldn't know the figure. So having history of migraine in the family is like having history of asthma or atopy. You ask for it, you might get it. I'll keep that in the mind. This doesn't seem to be...
Previously only said that the time of the event is very important. We all know that, whether it was exertional, post-exertional, that is an important pointer in history taking.
Yeah, so actually in practice we have to differentiate between the 99 children who will come with a vasovagal syncope and that one child or even less who has a cardiac syncope. So while the child is active or exerting, a syncope is dangerous, and that's a very important red flag. To that extent, family history of sudden young deaths or any heart disease in the child itself, like a operated heart disease or other heart disease in the family, we need to ask. That's important.
On examination, this child was well grown with the weight of 47 and height of 154 centimeters. Heart rate was 85 per minute in the supine position. The blood pressure was 110 by 68 millimeters of mercury in the supine position. Peripheral pulses were well felt, no tongue bites, no signs of external injury, no murmur, heart sounds were normal. So the central nervous system examination was also normal. What did we miss out here? The question to the audience. Anything that we have missed out on examination?
So all the vitals we've recorded, but...
Yes, absolutely. So we missed taking the blood pressure and heart rate in the standing position after 3 minutes of standing. So we need to rule out orthostatic hypotension here and postural orthostatic tachycardia syndrome. In this case, the blood pressure and heart rate did not show any significant fall and rise respectively.
So can I just say one thing? That it's good to see this, but it's a crude method to see whether there is a postural hypotension or not. Because as soon as we start getting up, our posture reflexes, our muscle tone, our vascular tone changes, and it may not reflect that much. And therefore, I think you know that sometimes a different test. So in a tilt table test or even when the
on the OPD basis.
On the OPD basis, then it's difficult. But that's the only thing you can do. But remember that orthostatic hypotension, the way we do in clinical practice, may have very low sensitivity because it may not pick up the thing when it is there.
And Sudhir, I'm asking you, what is the utility?
Absolutely.
in this.
There is not much utility because our diagnosis is clinical, historical evidence is the most important thing. Even if there is orthostatic hypotension here, then we would know that that would be the precipitating cause and our management would remain the same.
Yeah, point well taken, sir. If we measure it immediately after the episode, that is worthwhile. But just to get things across, as it was a presentation, we thought we should be talking about it. So I think the audience can just.
Amdek,
Sir.
I think this is to be reserved for a recurrent syncope of unknown origin. This is to be reserved for recurrent syncope of unknown origin, and more important is such children have many other symptoms like abdominal pain. After all, there is a hypotension, and because of that several organs are getting involved. So when you have a syncope with recurrent and some more other symptoms, I think that is where this picks up. It's extremely.
Thank you, sir. That was.
Thank you so much, sir. So the audience, this is just to rekindle our, Nelson. Maybe what you define as partial hypotension, A, B, or C. I think you would not go first. I think it's yeah. I think most of us have answered.
This is the correct answer.
So I think we'll just move on. So again, sir, the points in favor, as we have discussed at length, were dizziness, pallor, there were visual changes, there was prolonged standing, and there was lack of oral intake as well. Here is the question to the audience. I will request you to use your keypads, please. Based on the history and examination, would you reassure that it's benign? And keep a close follow-up and avoid any trigger factors and counsel. Sorry. Order an ECG or a 2D echo. I'm reading it for the people at the back because they're unable to see the slides. Order an ECG, 2D echo, and some blood investigations. Go further here and add a Holter, stress test, and complete the cycle by doing some blood tests.
We don't have the timer, some technical error. So can we just have the answers from the audience?
I think we all are in unison agreeing to the same thing.
So wouldn't we do an ECG?
Sir, what are your thoughts?
So if I have even a slightest doubt that I'm looking at a cardiac syncope, then a good history plus a ECG and a echo virtually rules out. So if all three are normal, then it rules out a cardiac. So I would do it when I'm thinking of a cardiac. Now, in that history that we were talking of, family history, etc., in an older child, we must also ask whether what did you feel? And if they feel any kind of palpitations before that event, that might signal a arrhythmia, and that would strengthen your suspicion of a cardiac syncope. Of course, the other situations we have discussed. Blood investigations, personally, I feel that hypoglycemia would be slightly longer, wouldn't be a sudden like a curtain fall, and therefore blood investigations have a limited role in this.
Any? Yeah, absolutely. So we.
So what I would say is that if I don't have a trigger at all, like in this child, that one odd point was that he had drama practice in school, but he collapsed on the way. That is okay, you can say. But if I have a very typical history that there was a painful stimulus, he suddenly got hurt and then he collapsed, or a flu child on 4th day morning, he went to the washroom and collapsed, or somebody collapsed with a blood test, I don't think we should even need a ECG.
Yeah.
Yes.
Let's go ahead, please.
So I think, yeah.
Yeah, that's why the family history was put.
So the family said that it was not migraine, it was some sudden death
Yes.
So if there is any red flag sign like family history, or not only that, if you are not aware of exact situation in which the syncope occurred, then it's the different thing. But otherwise, we are trying to do it not to elevate parents' anxiety, but elevate our anxiety. So we should see, are we anxious at all in the beginning? So we are not thinking of anything else in this child, then I wouldn't do even an ECG.
So remember Tanu's word in the morning, diagnostic stewardship. So let's all work towards that. We're not debating here, but I'm just saying.
So, but here we did a 12-lead ECG just to be sure of things, because the history what we could elicit was not complete. We couldn't get the history properly from the teachers or anybody else. So the CBC was normal, so was the blood glucose, as Dr. Suhas has pointed. The ECG was normal. In view of the history examination and the reports, the parents and the boy was counseled, because he was a elderly, 14-year-old boy, about the avoidance of the trigger factors like prolonged standing and increasing the fluid intake.
So,
Sir, Sani sir, would you like to highlight that on counseling, do we tell the maneuvers to abort any vasovagal
Yeah,
syncope?
in fact, that's the only thing that I would counsel. So 2-3 things I counsel. That first of all, when the child has fainting episode, like Dr. Rajesh said, on the 4th day of flu or while coming, parents are extremely anxious whether this is the sign of weakness. So I would say this is not a sign of weakness. And I would explain to them that why it happens. It happens because there is venous pooling of blood in the legs, and there is not enough, so it will be more in dehydrated situation. So probably I would not tell him to avoid standing for a long time, but I would tell the patient to have proper liquid intake. And then I would ask the child, is 12, 13, 14-year-old child, that what did he or she feel before the episode. And then we can help you that you can do some maneuvers to increase the muscle tone in the lower legs, like isometric contraction of your calf muscles. And that, if the situation allows squatting or even lying down, but lying down may not be possible in all social circumstances. So this typically happens when the child goes to school and is standing for prayer and the child falls, and sometimes it can be recurrent, and you tell them that in such a situations this would work.
Sir has mentioned about those.
the story now unfolds. 6 months later, the same child comes back with episodes of giddiness for few seconds while getting up from sitting position, 2 episodes of syncope at rest in standing position, associated with frequent headaches now of varying severity disturbing the routine activities. The intercurrent periods were normal. There was an occasional episode of tunnel vision in the form of aura, muffled hearing for few seconds before the episode, associated with neck pains occasionally, joint pains occasionally. So now, sir, Chokhani sir, what are the pointers now we favor or against the previous diagnosis of vasovagal syncope?
So we did say that in the previous story, the first episode when he was walking means we didn't have an obvious trigger. That was the only odd point. But other things, especially the pallor on the face, seemed to fit in. Now here, the headache history sounds like migraine, but I'm not sure whether I'll be able to call these episodes as due to migraine, because my original diagnosis of a vasovagal syncope stands. You've already done a 12-lead ECG and you've ruled out that the ECG is also normal. So I think, I don't know right now. The giddiness, I will have to get into more details of exactly what is the giddiness, how long does it last, does it happen with any other change of position of the child, etc., etc.
Yeah, so something else is definitely happening in this child. Now this child is getting giddy while standing up. So while doing an active maneuver, that means this is not a simple, according to my understanding, simple syncope. He did have fall. He had migraine history and all that. So now we will try to, aura is there. So now we'll try to have the pieces of the puzzle together, but this is, surely, so I think if I have not done before, then I will do ECG and echo now. Because would you do echo now? Because I think you would not stop.
That is the next question, sir. So should we do an aggressive cardiac evaluation of this child now?
Yes.
ECG,
echo and Holter maybe. I think these 3 things, especially if he's an adolescent active child, I would do that.
So we added on the 2D echo, sir, which was normal, and we also did a fundoscopy because he was complaining of very severity of headaches. So the question to the audience here is like, would you order here at this juncture a Holter stress test and a health tilt table test, a neuroimaging, or would you refer to a neurologist and cardiologist, or would you do all of the above? Because this child is coming with frequent episodes and it's disturbing his routine activities, and he's visiting the OPD also pretty frequently. I think all of the above is the.
So what is our diagnosis now? I think that is what we will try to find out. Here, I'm thinking that whether it's a migraine variant, but I'm extremely uncomfortable whether it is related to cardiac problem. And what cardiac problem it can be, like we were talking about prolonged QT, Ramesh just said that, whether it can be that, and then prolonged QT may not always come at one resting ECG, then whether there are some structural abnormalities of heart, like hypertrophic cardiomyopathy or pulmonary stenosis, and then rare rhythm disturbances, arrhythmic stress. So for these three things, I will do all these three things together. So I will do Holter. I wouldn't do neuroimaging in this child. I wouldn't have done even, I mean, it was a good thing that you did fundus, but I wouldn't have done fundus also in this child. Fundus anyway should.
The child used to come with varying degrees of headache and severity. So
The fact that it's varying and not progressive, we had a talk today, then that means SOL seems to be less likely. But I think it should have been one of the bedside clinical examination. We now refer, but I think doing is no great.
Moving ahead, in view of the disturbing routine, we did an MRI brain and MRI angio as suggested by the neurologist, which is normal. The stress test was reviewed by the pediatric cardiologist, which was also normal. The head tilt table test, obviously the parents were very apprehensive, so it was been withheld. And the counseling was done by the treating pediatrician and even the pediatric neurologist and cardiologist, because this was very frequent visits by the parents, because it was disturbing his routine school activities, and he had very, the giddiness and the dizziness episodes kept on increasing. So how would you counsel the parents, Dr. Chokhani sir, at this stage? And would it?
Normal.
Today was normal. All the investigations were.
So, we don't have a diagnosis still. So, therefore, because we don't have a diagnosis and we've ruled out cardiac reasonably well, now we are left with either a frequent vasovagal, or I would even start thinking of a conversion disorder. So, I would explore the possibility of a conversion disorder and get into more details of that. That is one. And pharmacotherapy, personally, we have never used for all these. So we would reinforce the hydration and the small frequent meals and adequate sleep, etc. And wait for any other developments.
So my take on this will be, we again go back to history again and say, are there headaches associated? What kind of headache? So we had some soft clue that there's a family history of migraine. Is it anyway related to migraine? Because this child had visual auras also. So is it anything related to that? And I will discuss with my neurologist that can some kind of migraine present like this? And I think
because
that
there were 2 episodes of syncope also. So that's the reason that we thought that it would be a recurrent vagal versus what you rightly said, sir, that conversion disorder.
So, you're right, Sudhir, about migraine. My only thing is that the neurologist has also passed it off. So, if it was fitting into migraine, the neurologist would have started anti-migraine prophylaxis.
So, as I think we have spoken at length about all these things, that the red flag signs that we need to watch is syncope as it is happening at regular intervals. If there is a lack of prodrome, again palpitations with chest pain, if it's exercise induced, if there's loss of consciousness for a prolonged period, and if there is a family history of sudden cardiac death. The most important pointer out here in syncope, I think they've highlighted it enough that we should rule out 99 against 1, as Dr. Chokhani had pointed out, that one patient who comes, 99 patients who come with vasovagal can escape, but one patient presenting with cardiac syncope definitely should not be lost in us treating as the primary care pediatricians. Sir, would you like to add? Yeah, sorry. So, sir, would you like to add till we move on?
One last point is again, when did it happen? So a syncope or vertigo, feeling of that happening when the child is lying down or sitting is extremely rare, and it's a red flag sign. We should specifically ask for that. No. And I think previously Hinduja Hospital used to do. I think they've stopped.
Yeah,
doing
I
it
think
now.
they've stopped.
So you ask the patient to lie down, and then the head is tilted, and you just record the blood pressure,
Yeah.
pulse rate. But that's no more done also.
It is done. It is done.
So to start with our third case, it's a 2 years, 3 months child. Female child brought to the OPD by the parents with the complaints of cough, cold, fever since 3 days. While examining, he noticed that the child was not communicating. Child was busy playing with her toys. She had occasional eye contact. So the question to the audience is, child is too shy to speak to the stranger. Child is engrossed and playing. Is it a concern needing further evaluation? Your time starts.
Start with the timer.
That's the right answer.
I think till the timer. Don't put the timer.
No, so everyone is saying 3. Couldn't it be that you have a very attractive toy in your room and that's why the child is not, Doctor Baju may let me play with the toy. Couldn't that be a reason? Sorry?
Yes.
Yeah. So if the toy is very attractive for a few seconds, that can happen, but then you have to sift it out further and talk to him and he should start engaging
So
with
on a
you.
lighter vein, what Parul is saying is that our own name is more attractive than anything else, I think. Call by the
On detailed history, birth is uneventful, full-term normal delivery child, well grown. On gross motors and fine motors are normal. Mother gives a history that her daughter is very smart. She opens the mobile on her own, opens YouTube on her phone and surfs through her favorite videos. She follows multiple commands, but points out to the object what she wants. She speaks monosyllable 2 to 3 words at 2 years, 3 months. Working parents, so the child is alone with the grandparents and at home, and hence the most of the time the child is either on the mobile or on the TV. Child was born during the COVID era, as we all know. During that time, there was a lot of restrictions regarding social interaction. Hence, scared to interact with others. Child likes to share things of her interest with parents. She also enjoys pretend play with her parents. Plays with her peers but shies away occasionally. And the mother gives a history that since I started speaking fluently at the age of 4 years, so maybe my daughter is going to do the same. So what shall we do next? Question to the audience. Treat the URTI, take a very detailed history, detailed examination, hand over the MCHAT and counsel the parents. Wait till the age of 4 years. As the mother started speaking at the age of 4 years, she is very confident the child will speak by then. Refer to a developmental pediatrician, refer to a speech therapist and evaluate hearing. So what do we do next?
You want us?
Yes.
Yeah, we
would take a detailed history. Since morning we're emphasizing on a detailed history and examination.
Yeah. Somebody wants.
You don't want to evaluate for hearing? So it can't be only A, it has to be evaluate for hearing as well. So what are the points which are good and which seem to rule out autism in the history? Very good. No, bisyllable at 3 years is like a very poor, yeah. But joint attention is a very important point, which is, good.
So her social milestones are good. use MChat in this? MChat are other follow-up charts. Yes. No, but there are MChat are revised follow-up charts. Yes. So you can. So there are pointers in the MChat itself which tells us.
So
that
I think
the-
Koili and Ashwini are there. We can ask their inputs. And please come in front, Ashwini or Koili. And there are, so autism spectrum disorder is a spectrum which ranges from mild to extremely severe. So it's no point just asking one or two questions and rule that out or rule that in. I think raising developmental concern is okay, but further some things we must learn from developmental pediatricians.
Hello. So using MChat here, the question is
Ashwini.
about MChat. Here, okay.
Come here.
Kohli ma'am also can please come.
Yeah, Koili, please come. Yeah.
We are very
So
long.
using MChat in the flow of this discussion, I would say that MChat has to be used for all children between 16 months to 30 months, and it's not a diagnostic or a screening tool that because we have picked up speech delays or communication delays, which you expressed very well, that's why we use MChat to confirm a diagnosis. That's not the role of MChat, I would say.
So
But
madam,
yeah.
if the child comes at 3 years, can I still use the MChat?
So MChat is from 16 to 30 months and it's for all children. So it's not like a tool which is going to diagnose autism. Definitely not. It's a screening tool for all children.
But Ashwini, would you agree that at least in this child, when there is a concern, you use it? You should use it screening to all the patients. But at least when there is concern, you should use, or you wouldn't agree to that?
I would say that this is still a screening which will be yes and no answer.
No, I think
So
what
in this child-
Ashwini is trying to say is that if I have a child who's obviously not looking at me, no eye contact, and if this child did have joint attention, but if there is no joint attention, means someone who's staring at you as a autism spectrum disorder, then doing MChat is not going to confirm your diagnosis. She's saying it's not a confirmatory tool. So my thought process is that when you are not able to decide, I'm talking of us general pediatricians. So when you have 1 or 2 points for and 1 or 2 points against, ultimately what is MChat using? It is using most of these questions only. Does he look at you when you point? What does he do? Does he show a toy to you? So these are all similar things. So at least when we are not sure, we should use it. Is
what I am saying, but Ashwini is saying do every time, which is ideal.
Ideal, yeah.
Yes, and I would also say that, like actually Amruta did talk about it, the history and the detailed history. So instead of, if we are suspecting something, it is only communication delays maybe, but a detailed history about that communication, expression, as well as understanding of the the words and the gestures and the understanding and also the other domains of development is going to help us. And the M's, because like it's, yeah, I'll come here.
Koili?
Yeah, go ahead. No, I just wanted to say that, like, the speech is not only about speech. So happy that you talked about communication, Amrita, because it's like the presenting concern of so many developmental conditions, factors in which the child is, the caregiving factors. So knowing about the concerns in details, the expressive and receptive, the expression using words and gestures, the understanding,
We're talking about the speech and language.
speech, language and communication, and also the other domains of development and the psychosocial factors.
So since you both are here, we would.
Koili wanted to add something.
Yeah, can I just ask you to shut up when we go too much beyond time? So I think the point that everyone's trying to make, that the MChat is a very powerful screening tool, is very well taken. And when you follow up ideally, if somebody in your front office asks the parents to fill in the MChat, and then you review the answers that the parent has filled in and go over the follow-up interview, because the items that the parent, the child has not passed, those are the items that the follow-up interview helps you to go over. There are responses, you go over it further. I also want to point out a few things. If you could quickly go back to the presentation slide. So the problem is, that well, this is a bumper slide, but when the first slide, when you talk about the presentation, when you see the child in the OPD, yeah, yes, okay, that's it, right? Not communicating, busy playing with the toys, has occasional eye contact. The child may have selective mutism, right? So for which they still need to be followed up. So I think there are pointers here, and also just a little bit of something to confuse you with. When girls come to you with autism, they are way more social than young boys with autism. So they have more eye contact, they look more at people, they do more pretend play than little boys with autism. So children who look at you, children who do some pretend play, does not rule out autism. Trust your clinical judgment when you feel you see hundreds and hundreds of kids with autism in your office. When it strikes you that this child is not really responding back and forth with me, value that really. Follow it up with a question to the parents. Tell me about how your child communicates. I think that will give you much more richer information than just 2 minutes.
Yeah.
Thank you so much.
Yeah, so we talked about that here. Yeah.
Yeah, but I'm just saying that these don't tell you absolutely
Yeah.
that the child does not.
Not have autism. Yeah.
Uh, yeah. We. Sorry. No. So I think the experts have already mentioned that what are the pointers differentiating speech delay from autism. We'll just, as experts, as pediatrician, what would be a suggestion to parents in this case?
I mean, this child has some red flag sign. And I think before that, for Mamta, we need to devise a term called as referral advocacy. So, investigations advocacy, antibiotic advocacy, and referral. We cannot refer all patients to developmental pediatrician. So, here, there are some red flag signs that the child is continuously on the screens. And that is the first thing that we should tell them, that only some kind of, so really zero screen time, only some screen time may be allowed. That can be video chatting with grandparents, maybe when the child is talking inside. That also, because the kids don't learn from machines, they learn from humans. So there should be more human contact, and that's what we should tell them.
Yes, I think we can all read all these things.
Suggestions would be zero to screen time as Sir said. Enroll the child in a play group so she can communicate with other kids. Follow up for further evaluation and monitoring. Parent education and stimulating her by using the flashcards, big color books, and storybooks to read her aloud.
I think we'll just go to the next case because I think we have just 10 to 15 minutes. How much time do you have, Mamta? Okay. So this is a 5-month-old girl who is brought to the OPD with bilateral breast enlargement, which is noticed since last 8 to 9 months by the parents. But because of the COVID era, they couldn't come to the OPD. There was no history of any headache, trauma, or any vision changes when we're talking of the central causes. There was occasionally history of mood swings, and she's been developmentally normal. On examination, the breast tissue, there is, it's almost like Tanner stage 4. There is projection of areola, there is a secondary mount formation, and the pubic is in Tanner stage 2. There are sparse pubic and axillary hair. I think we'll not go to the timer. It's a keypad question. I think it's pretty obvious that what are your thoughts at this juncture? I don't think most of us would agree to. Yeah. Somebody said A. No, I think B. Yeah. So we move ahead. Going to the growth parameters, the weight was 33 kgs and the height was 131 centimeters with a BMI of 19.2. We did a bone age at this juncture, and it was corresponding to 10 years with a chronological age of 7.5 years. So again, this was a question, so that which is not a method of bone age estimation. We used to do, look at the carpal bones. So we do not do it anymore. So I think B is, which is not a question. We have a pediatric endocrinologist sitting with us. To the experts, sir, what do you think would be the cause here? Because we are thinking this is a precocious puberty, and Sani sir, would you like to highlight?
I think this seems to be isosexual and central precocious puberty. And I think one more thing is that we did bone age and everything. Just one or two quick points, and Alok is here. And Alok, please come forward. And yeah, so one or two quick points is, if we have time, this child we may not have time because Tanner stage 4 breast, and if she starts having menarche, then we would lose so much of skeletal height growth period. But if you have time, it would be worth seeing whether the height velocity is appropriate, and with that would differentiate really whether it's a kind of a premature thelarche versus precocious puberty. Please come. Alok is pediatric endocrinologist, you all know, and he would like to kind of.
Alok, can I just flash this question and then we can answer? Based on the above audience, would you follow her up regularly and plot the growth parameters to the biochemical markers like the LH FHS and the LH FHS ratio, estradiol, the thyroid function test, biochemical markers plus a USG pelvis, or refer to an endocrinologist? Yes.
Thank you very much.
Okay, wait. Which of these options is wrong? Which of these options is wrong and you will not do it?
So, Alok, I wanted you to be welcomed with that.
So again, you start from the history. History is indispensable, and so are growth charts. Onset, progression is the most important thing, and growth charts, you definitely see a spike up there in the centiles. That is one sign which you take. Even in history, if you ask, the parents will come up with a seeing that there was a growth spurt. The child suddenly grew up in the last 6 months or so. But largely, you would want to correlate these 4 things. You want to be on the same page with respect to 4 aspects. One is clinical, one is growth chart, biochemical, and radiological. If everything matches, this is central precocious puberty. Central. I'm talking about central here, not going into rarer causes.
So, to the audience, when should a pediatrician refer to an endocrinologist? As he's actually mentioned, there is a sudden growth spurt in height and weight which is crossing the 2 major centile on growth charts. A breast nodule which appears before 8 years, pubic hairs before 8 years, or if there is a isolated menarche before 9.5 years, that's really a cause of concern, or all of the above. So, sir.
So personally, I mean, I would be very comfortable in my OPD treating a child with breast nodule, only breast nodule, before 8 years of age. I would monitor her growth and see whether she is entering into puberty or not, and I would not do anything at that matter. So is also only pubic hair before 8 years of age, because this can be adrenergy. And so some of these patients do have this, but again, this I wouldn't just label it and leave this child alone. This child needs close follow-up. So whether endocrinologist is better or I am better, at this stage I feel I am as a pediatrician better. But yes, one and isolated this thing menarche before 9.5 years, I would definitely send to Rajesh.
Yeah. So sorry, Rihan.
Rather than precocious puberty, I think.
So these are all phytoestrogens.
Yeah, phytoestrogens.
There are a lot of endocrine disrupting chemicals that we are seeing, but we are talking about hypothalamo-pituitary region.
You're saying something.
No. So continuing from what Alok said, so central will go through the regular routine, whereas these are all extraneous sources of estrogen, so they would amount to peripheral precocious puberty, something like that. So yeah. Specifically to this option, what I would say is, say breast nodule before 8 years, you'll have to qualify. So before 8 years means we have those time periods for isolated premature thelarche. So if it fits into that period, I would be very comfortable waiting for that. And just a breast nodule alone will not. So before 8 years means quarter to 8 years, just a breast nodule, still whole puberty to go through, may not really be precocious. So therefore,
Alok would like all the options to be referred to him, but what would be rational really? What would you think here?
Like I said, so I would want to correlate everything clinical, biochemical, radiological, and growth chart, very importantly. You should have all four evidences and then go ahead with treating.
Isolated breast nodule, would you think that
It has to come with an advanced bone age, it has to come with a growth spurt, all of those things should be there. Otherwise, I wouldn't even bother about investigating that case.
So we referred the patient to pediatric endocrinologist. He diagnosed it as idiopathic central precocious puberty because of the elevated LH FSH ratio, and there were significantly enlarged ovaries, but there was no cyst. He also did a MR pituitary, which was normal, and the girl was advised GnRH analog therapy. Parents were apprehensive, and they come back to the pediatrician. Ma'am, what would you want us to do? So I would like to ask the experts, Chokhani sir.
So let's ask the audience, what would you do? Parents said that, okay, abhi nahi karna hai. So what would you do? How would you counsel
What would you
them?
do sitting on the OPD chair? I mean, if the parent comes to you that this has been done. No, they have gone to the endocrinologist. The endocrinologist has suggested that GNR analog therapy.
So what will you counsel them? What will you tell them? That's the whole. So I think Rajesh. So I would deal with this like this, that I will tell them, and see, remember this is 12, how old is the child? 7.5 years old child. Okay. So I'll tell the parents that your child is 132 centimeters. That was the child's height.
Yes.
So I would tell them that there are definitely physical and psychological effects of having early puberty and menarche. And the height growth will stop if we don't intervene immediately. And I would again reiterate that the advice given to them is very logical. And I think my limit of knowledge ends there, and you need to go to an endocrinologist.
That's it.
No, and I would consult the endocrinologist and also give them an idea of, if we were to go further with therapy, what is the height gain that we can possibly achieve. So that is also what I will tell them, computing with the endocrinologist, and
we would plot the height and show them that this is the height that we would expect you to achieve with the therapy, and without the therapy you may land up with some other problems, and it could be a
yeah, there's a lot of psychological issues.
It could be emotional abuse also to the child when the child starts going to school. I mean, already going to school. So I think we've already spoken about it. So when on pharmacotherapy, Alok, would you like us to, as pediatricians, because the child is going to come for a 10-year vaccine booster, would you like us to monitor a few things? Would you like us to highlight?
Growth. Again, plot. As a pediatrician, you should be plotting the growth chart. Breast size may or may not.
This is the protocols which you mentioned.
Breast size may or may not go back to Tanner 1. It depends on your bone age. But as a pediatrician, the most important thing you should be doing is plotting the growth on their growth chart and monitoring growth velocity. If your growth velocity settles down, the therapy is working.
The idea of putting this question is because they have mentioned even you need to monitor the bone age, some of the, But is it worthwhile doing a radiological
Yes,
investigation?
definitely, because there can be other, clinical connotations to it.
What
Because
would you do, sir, as experts?
I thought the age at which we are dealing with the child is important. So about breast size reducing, it's plus minus, and we as pediatricians will not be able to really make it out so much. So the growth is the most important what we can make out. So that speed falling down is something which we can make out. About bone age and all, I think we need to have how much time window we have. So here this child's already 10 years, and once you start treatment, how much time window we have for monitoring that the bone age has remains or has slowed down. That is a question.
I think the take-home messages, I think we've ended on time. Mamta? Yeah. So the take-home messages. Yeah.
Would go for any therapy, I suppose, Parul.
The only worrisome side effect I would be worried about is seizures in a patient who's already an epileptic or has a seizure disorder. So GnRH analogs tends to lower the seizure threshold. That is the only worrisome side effect I'm thinking of. Other than that is sterile abscess formation, which is not very troublesome. I haven't seen too many. And nothing else. The problem is they Google, and Google shows you the first thing is bone health, bone mineral density going down, but those are seen in adults wherein estrogen is the main driving factor for your bone mineral density. Here you want the estrogen to go out, so it is not going to be counterproductive on your bone health. So there is no. I would counsel. See, yeah, if they are okay with the child menstruating at 10, and if the epilepsy is severe enough, I would say it's okay if you don't. Yeah, yeah. There is no point in titrating there. The doses are no longer weight dependent. These are fixed doses. You cannot titrate it. I would explain that there would be. Yeah, yeah. Yes, they would. I would explain at first whether they want to go ahead with this therapy, and these are the problems we would face with it. Yeah. Yeah. Yes.
Yeah, sorry. No, you just asked, Neeta, what can pediatricians also do? And may I just add that I think as pediatricians play a very important role in talking to the child about what's going on and what is this that they're going through? Why are they getting these shots? What does it mean for their growing bodies? What does it mean for when they are going to get puberty, and why are they doing it? Because that's a point that nobody covers, and these young women are dealing with all of this, and as pediatricians who've been in their lives, you can play this very important role.
Point well taken.
Thank you for that, Koili.
very
I was
important.
thinking that we are becoming like dinosaurs in pediatricians. We are getting extinct, and thanks for that.
Yeah, because I know it's a lot of emotional and a psychological burden on the child when even the counseling sessions are going on. Thank you so much. I thank our experts for absolutely wonderful contribution and their insights. I thank my co-moderators and wonderful delegates for making it very interactive. Thank you so much once again.
So let's tune into the child's mind with our first question for the audience. Mental health refers to how we think and feel, how we act and behave, how we cope up and with stress and work productively, all of the above. Learned audience, that's the right option. How common are mental health illnesses in children? 2 to 4%, 6 to 8%, 10 to 12%, or 14 to 20%? Maybe you could give a chorus answer for that as well. D is the right option. It's 14 to 20%.
And in today's world, the mental health illnesses are increasing, as we come to know when we have the session.
Which of these are not important for positive mental health? Healthy habits, relationship, fixed mindset. Okay, very good. That's the right option. So moving on with our case, we have 14-year-old Nia, a single child presented with complaints of not listening to parents, especially the mother, previously good at academics, now refuses to study since a few months, pays less attention in class, irregular menses, earlier was passionate about playing guitar, now not able to focus much, not much in touch with the regular friends for some time. Moving on to the parenting history, mother was a highly demanding one, not really friendly, mostly lacks on communication skills, herself apprehensive by nature, criticizes harshly and tries to prove herself right. Minor conflicts between the parents noted quite often. My question to the experts, what would you like to know more about this scenario?
Yeah, as you can see, a 14 years old teenager who has dramatic and sustained change in behavior. This is a very important red flag, in any change in behavior in a teenager for mental health. So I would like to ask first is what happened before this change of behavior. So any trigger was there, any family issues or some relationship issues or something like that. Apart from that, of course, sleep and eating habits also, where they changed also. And you are not mentioned about father's role here. Mother has been emphasized. So what was father like?
The father was not really, the father was a milder one. Not
Then
much.
prognosis is poor.
Agrees to whatever the mother says most of the times.
Yeah.
So, what would be the most likely parenting style in the above case? This is a question for the audience. Is it authoritative? Is it authoritarian, permissive, neglecting, or unevolved?
You may use your polls if you
For
wish
this,
to.
maybe you could use the poll. Okay, yes. Sir, maybe you could allow. Poll vote. Yes, that's the right answer, and our audience is very much learned. So, my question to you, sir, as per you in the above case, which is the kind of parenting? One, may you please elaborate more about the four parenting styles and what are the features of positive parenting? Question to Sandeep Kedkar, sir.
I think parenting style and parenting practices really make a lot of impact and influence on child's development, behavior, and mental health. So we should be knowing about the styles which are important, which has been clinically research. Parenting research has come out with Dr. Diana Bombrin has come out with these four types. This typology called as Bombrin typology. And in this case, it was authoritarian. Of course, the B answer was right. Because as you can see, x-axis, there is how much control the parent has on the child. Control and demandingness. Whether it is very high control or low control. And on y-axis, it is warmth and responsiveness. And of course, caring attitude. So in this case, it was, of course, high demandingness, that is, on this side, and low warmth. There was no connect of mother with the daughter. And of course, she was highly expecting a lot of things and she was more of an autocratic thing, mother. So it falls into authoritarian. But of course, you can have different types of parenting as you can see in this. It can be authoritative, it can be permissive, or it can be uninvolved. According to how much warmth is there and how much control is there. And if there is a imbalance between that, definitely it will lead to negative influence on the child. Of course, here we don't know about father because sometimes father can neutralize the mother's style. So it's called joint parenting style. If the mother is authoritarian and father is authoritative, because authoritative is supposed to be a better parenting style, is one of the best parenting style you can say, where you have high warmth as well as high control. You are setting limits also. You are expecting standards of behavior very high. And you are very caring and tuning into child's mind. So in that case, authoritative father will neutralize the negative effect of authoritarian mother. So that's very important. So here I think in this case it was authoritarian. Yeah. It's a good question, but most of the times we have one dominant style. Because we also as human beings, as we move into adults, we are hardwired and the patterns are set up, right from the beginning. So we tend to do certain things in a certain way. So as parents also, as adults, we tend to fall into one dominant style. It may be sometimes authoritative, sometimes uninvolved also, but then most of the times it will be one style only. So that's what we want to focus on.
Continuing, sir, what would be our parenting advice to the mother in the above case?
Yeah, of course, parenting advice before that, probably we should know about positive parenting, because you were asking about that also, that a positive parenting is about how the parents create that positive climate in the house. And it depends on how the parent is connected and tuned into child's mind. How the parent is focused on strengths of the child rather than weaknesses, and what is called as strengths-based learning and strengths-based strategies that parents use. And of course, how the parent is praising the child as well as criticizing the child, because sometimes the praise is given in a very global way, like good boy and good girl, and that can be damaging actually to the child. It has to be specific praise of specific behavior, which is very important. And of course, authoritative type of parenting will lead to more of a positive parenting style. So in this case, probably I would like to talk with the parent and especially mother, and both of them actually. If father is not involved, we'll have to get them into, because it's not only mother, because mother must be stressed because she's holding all the battle there. So we have to involve the whole family here and counsel, where we focus on how the mother should be communicating with the daughter. That's very important, because the child-parent relationship depends on communication. How the child and the parent is communicating, how the parent herself is dealing with her own emotions and behaviors. What role model, modeling of behavior is done by the parents in front of the daughter. So we need to counsel the mother, where we talk with the mother about how the mother's, the whole style can be a little bit changed, how she can be more warm, more caring, tuning into child's thoughts and feelings and being supportive rather than, harshly criticizing, being judgmental on emotions, all those things. So I think that is a very important point which we have to convey to the mother.
Thank you, sir. Moving further on examination, the child was underweight due to peer pressures under food fads and was noted to have iron deficiency anemia and vitamin D3 deficiency. So my question to Madam Vaijayanti, correlation between iron deficiency anemia and psychological behavior in children.
Yeah, so as it is these days, we know the children are more interested in eating junk food, and giving healthy food is very, very difficult. That too, this child especially looks to be really in some trouble. She was not really very happy. She was not feeling interested in things. And as of course this question also, the history also says that because of peer pressure also, sometimes they really go into that habit of eating other things. So that's what these days it's said, that even if the children are of well-off parents, they are malnourished. So they're malnourished in this way, and then they get iron deficiency anemias and vitamin D deficiencies. And iron deficiency itself can cause, as in the previous session they were saying, that dopamine pathways get affected because of iron deficiency, and then because of that, of course, you start feeling fatigued, you start feeling tired, and especially so many times the children are brought with this complaint that they are feeling tired and they're not able to concentrate in the studies and they're not interested in anything to do. These are the things, of course, in their general everyday life it starts happening. They're not able to really do things in school also, and they're not able to play, nothing they're able to do as they were doing normally. And the other thing, of course, now these days they are associating, probably there are many studies done, that even these behavioral disorders like ADHD and autism, probably they also get more aggravated because of iron deficiency and vitamin D3 deficiency. So definitely we have to take care.
What would be an approach to this recent onset poor scholastic performance? Madam, maybe you would take.
Yeah, so of course, we have to now find out. Physical health could be the, of course, first thing to be seen, and you have to really find the solutions for that. But then for poor scholastic performance, that too, that is recent onset. So we have to find out that what has really happened, as Dr. Sandeep was saying, that immediately before this, what has really happened and what has gone wrong in child's even other environment. The school environment, the home environment, as well as his peers, is something going wrong there, or something different has happened. So these are the main points. Of course, one has to definitely find out for the poor scholastic performance.
As far as school is concerned, what would we like to get the role of the school in the assessment of this particular child? Would it be important? Maybe Dr. Mamta could take it.
With this, I think you all have been stressing on history. Without a detailed history, I won't bring in the school in right in the first time. I would try to find out what has happened. You have already told, I think in the history, the child was performing really well before this, has a good scholastic performance. So I would not want to involve the school unless it's related to the school. Thankfully, we have a 45 minutes to an hour session with the child. So that will allow me to talk to the child a lot more to see if there's anything else that needs to be looked at.
So moving further, the child was referred for counseling sessions, and to the further surprise of the parents, it was revealed that the child had a recent breakup with a boyfriend whom she was dating for some time in the post-COVID times. So my next question to the audience is, relationship breakups would have the worst impact in which age group? Early adolescence, mid-adolescence, late adolescence, both B and C. Yes, I think the audience. It is the option, right option is D. Madam Vaijanti, maybe you could highlight more on this and the reason for this.
Yeah. So as we all know, adolescence is the period from around WHO definition, it is 9 to 19 years. These days, of course, you say that late adolescence, so that comes to from 16 to 19 years. So 10 to 13, 13 to 16, and 16 to 19. So maybe you say late adolescents and young adults. So they are taken together probably. So relationships start these days at the age of 10, 11 years, definitely. Because the school children come and tell us that pairing to ho gaya school mein, class mein. So that age itself, 11 years, they have started relationships. Only think probably the early adolescence, so up to maybe 12 to 13 years of age, it's the relationship, is the initiation. Probably it's not really fixed. एक दिन एक लड़का अच्छा लगा, दूसरे दिन दूसरा लगा. So it's okay like for them. But then maybe later, slowly, as they go into mid-adolescence and the late adolescence and young adulthood also, then slowly they start fixing, because now the brain also has started developing and they know how to, yes sir. So the brain also has started undergoing changes, as well as the hormonal changes are happening. So they really want to now go together, form the relationship really, fix the relationship, and then slowly start experiencing the intimacy also. So that love, intimacy, so all that starts happening in their lives. So now, so relationships are there for all of them. What happens when the breakups happen? So breakups, of course, for all of them can happen. And especially at any age it can happen. So early, mid, late, any age the breakups happen. All of them, of course, naturally get affected. I remember a child coming and asking me, Auntie, mere na friend ka breakup ho gaya hai. The child was just 11 years old. So you just give me the points, how do I deal with it and how do I help that child? So it does. Probably. So all of them really feel bad, but then of course the worst impact would be on the mid and late adolescents, because as I said, early adolescents, they are just initiating, so they can forget and have another toy, so they can have another friend also.
Yeah, so I just wanted to ask question to the experts that is it ethical to let the parents know that the child had breakup, or are there any nuances there that you need to be careful before telling what you have, because I think these counseling sessions are extremely secret and private. So would the parents have right to know what's happening to the child? Yeah.
The rule that we follow is before 18 years of age, when the child is not officially an adult, anything that's related to harm and self-harm, other harm and self-harm, we tell the parents. We involve the parents. And that is told to the child right in the first session, right in the rapport building. We don't say it later. So, no, this we won't, unless it's leading to self-harm or other harm, we won't. And we also clearly tell this to the parents that I will give you my professional opinion, but I will not divulge the content of the session. Now, this becomes very difficult because parents would want to know. Many a times the confidentiality we call it, that aspect itself helps the child because the child sometimes goes back and says what the child has told to us. Yeah. So if the relationship, what Dr. Sandeep just told you, that in our field there is a concept of identified patient. It's called IP. Generally, the person who comes to the psychologist is the IPs. I'm not talking of developmental disorders. I'm talking of children who are absolutely okay, but come up with issues. We call a concept of identified patient. So what we say is that the most weak link in the system comes to us. Yeah, doesn't mean weak link, doesn't mean no power, okay? But the weakest link comes to our system. But when that person comes to our system, we know that the system has to be looked at also. So we wouldn't look at only what the child is going through, we would also look at other factors. But the confidentiality aspect, we wouldn't talk to the parents unless there is more serious things in it in terms of wanting to run away, wanting to do any other things. Then what we do is we don't tell it. So we don't become a mediator. What we call is, in a family therapy, what we call is triangulation. So we don't triangulate with the child. We get the child to sit in the room and talk to the parent about it. We don't divulge. So we don't become like, you tell me and I'll tell your parent, because that's unhealthy. No, you're not going to be in the picture later. They still have to communicate with each other. So confidentiality doesn't allow us to say unless there's harm and self-harm. But in specific cases and specific situations, we'll get the child and the parent in and they can talk and we can mediate.
And we have to go deeper into why the daughter or the child is not speaking with the parents first and coming out with you as a pediatrician or counselor, because that's a very major thing. So that's why in relationships, if we want to have a better optimal relationship, it's like Mamta said, it has to be between, should be no secrecy between those in that relationship. So the daughter has to talk with the mother in front of you only.
If it is harm and self-harm, it can hold back the child, but we don't take that risk. We do say that because we cannot be there all the time, right, for the child. The parents are the primary caregivers. I think the idea is not to take over care from the parent. The idea is to empower them more, and there is going to be difficulty in that, the whole process. But we say this, and the child will say, oh, I wanted to tell you something, now I'm not going to tell it.
Yes,
and you have to say, that's your choice.
Yes.
The psychologist never works at digging out the truth. The psychologist works with what data is there on the table at that point of time. We are not detectives. We are not going to dig out the truth. We are not going to find out what's good for you. You come, and that onus of responsibility will have to be taken. So when we lay that boundary in the first session, we are telling the child this is how we function.
Okay.
Maybe any more questions we'll take at the end of the session.
This is just one second. This is a very well said point. As a psychologist, what they're trying to, I feel this is a very important take-home message, that it is empowering the parent and the child or the family to handle the situation, and you are just the person who is kind of, trying to give make them choose bridge the gap or try to find out the solutions together. That is a very well point we should.
Madam Vaijayanti must be, as an adolescent expert, you must be coming quite common with these problems. How common is in your day-to-day practice you see such issues?
Yeah. So especially the breakup issue is not really very commonly, they don't commonly come to us, because especially in our Indian families, the children don't come alone to you. They're always brought with the parents. So in front of the parents, and as Dr. Sandeep was saying, somehow the relationships at this age especially, it's not that the mother or father are not having good parenting, they are doing it, but at this age somehow they're not really very free with the parents, or they're scared of them, so they don't come on their own. So probably we don't see so many cases, but then generally slowly when you know that child very well, they have been coming to you, so somehow the child just lingers back and then tells, I want to tell you something, can I come little later? And then so many times they do tell. But when we take our group counseling programs, as I told you, they all of them in unison, suppose there are 25-30 children who have come for group counseling, they all tell us that yes, in our class it does happen, all of us are doing it. But as a case, मेरा breakup हो गया, that way they come very, very infrequently, but I think when that goes to severe state, then of course they do come, and then of course they go to Mamta.
Ma'am Mamta, how would you counsel? What would be your approach to counsel this child?
I think first of all, I think what Dr. Sandeep had put up, I think emotional coaching part will have to be a part of the entire conversation. But I think the first of all, to understand that relationships are not necessarily stable at this age of point, yeah, and with so much of exposure that they have, experimentation is going to happen. So it will be foolish to say that do not have a relationship, but in a relationship, what are the red flags? I think all that education will have to be done for the child, definitely. For the parents, we'll have to sit separately, because I think the way we have grown up, we have not probably had so early exposure to relationship. Therefore, I think experimentation, meaning I'm talking about even physical experimentation, yeah. I don't think I have a lot of children who have not experimented by the age of 15. I'm calling experimentation, it could be intimacy, it could be physical touching, it could be going beyond that also. So for me, this would be quite common. The problem is pretty common because such children are coming to us. In school, also we have school counselors who are dealing with this regularly. The approach would be family and the child, definitely. More sessions for the child, probably together sessions in terms of communication, and how this is going to be an ongoing factor and how they can be looked at, I think.
What would we assess at each follow-up, ma'am?
I think for the child, on whatever the child wants to work at. So first the distress will have to be reduced for the child. What distress is happening, how is it affecting the everyday functioning, that will have to be taken into account. So is that getting better? Because the school is necessary, your grades are necessary, your everyday functioning is necessary. So that for me would be the first thing that I would look at. For the parents, I think any suggestions given in terms of increasing conversation and communication, because also what needs to be psychoeducated is when the child is 14, the child is not going to behave as when the child was 9. Yeah. So power is going to be wrestled. There is going to be more negotiation. There is going to be, I want this. So all of that, the psychoeducation will happen with the parents, because they no longer can hold the power completely. The power will have to be distributed with their teenage daughter.
And of course, parents concerned how to handle this situation. How would you assess that problem?
First of all, trying and finding out how has it been till now. Has there been a change after the child has become a teenager? Like generally after the menses, is there a difference in communication? Because you cannot give instructions and the child will follow it. It will have to change. The kind of communication will have to change. Now, most of us feel that kind of communication has to change means I'll have to say please. It's not that. I think respect for the fact that the child is moved from concrete thinking to abstract thinking. Yeah, and if the child is moved from concrete to abstract, the child is not going to just agree to whatever you say. The child will have views and opinions, the child will have those, and just respecting those and seeing what can be done as a family. It's not a question of, like I think what she mentioned, that all of us are not authoritative all the time. We have all kinds of parenting in us, and I think we move towards authoritative. So if the authoritative is kept as a, let's say, a benchmark, then how will your communication be so that you're authoritative and not authoritarian? I think I would do that, and in every session, whatever activities are given as homework, are they be able to do it, and what problems are coming across?
Can I add 2 points here? I agree with all the things what Mamta has said. I would like to have 2 points here, because there is change of behavior. Suddenly a child or a teenager who is good in academics is now falling in academics. We have to go to deeper into it. we have to find out the coping skills of this teenager, because many a times the stress which is evoked during the breakup, she is not able to tolerate that. Those skills of stress management and all that is lacking in this teenager. So we have to develop that also as a corollary. And secondly, whether there is baseline underlying anxiety, depression creeping in also, because many a times this PTSD also behaves like this as post-traumatic, because breakup is a kind of trauma and stress for them. So that has also to be evaluated and counseled for that.
Thank you, sir. Moving on to our next case, 3-year-old Saminu was taken to the mall, sees a toy.
Ramesh, can we take the questions later? We have 3 more cases to go on. Extremely sorry for that.
3-year-old Samani was taken to the mall, sees a toy. On parents' refusal to buy the toy, he just rolls onto the ground and refuses to come along, not getting diverted by any means. Similar situations happening infrequently over the last few months, and parents concerned how to handle this situation. Now, my question to the audience is, what would be your suggestion as a general pediatrician to parents? Ignore the child and walk away, fulfill the child's demands, reference to a child psychologist, tell the parents that it's developmentally normal to have temper tantrums at this age. Maybe you could just
You
tell me
can
the
just,
word
say loudly. D.
D. Yes, the right option is D. The next question, what would be your opinion regarding the parents' optimal response? Giving punishment, giving attention and focus on stopping the behavior, teaching the child to identify and manage his emotions, giving in to the child's demand. C, right option. When is it developmentally acceptable age for temper tantrums? 5 to 10, 1 to 4, 2 to 7 or 3 to 8? 1 to 4. Extremely learned audience. Which of the following is not a parent-child attachment style? Anxious, ambivalent, avoidant, secure, demanding. Maybe, how would you identify the parent-child attachment style, and maybe you please elaborate on this as well.
Yeah. I think parent-child attachment is the most neglected part of our pediatric practice, and we are not giving enough attention to parent-child attachment, which can be actually measured, as well as you can, through the behavior you can measure it. So parent-child attachment is about how the parent is responding to infant distress. When the child or the infant is distressed with something, maybe different intense emotions are there, how the parent is responsive, whether that response is consistent, sensitive, and the parent is very responsive, which leads to safety, security, and be a feeling of protectedness in the child. So parent-child attachment, the attachment research has been done for almost 3 to 4 decades now, and they have come out with these 4 types. One is there are 3 types which are insecure, and one is secure. And foundational, all the mental health of any child, the foundation of mental health is secure attachment. It is much deeper than bonding. Okay, we say that the parent is really bonded with the child. No, that's not what is secure attachment is. Secure attachment is about how the parent is responding to the child's needs accurately in a sensitive and consistent manner. And how can we measure it? I do it normally in post-immunization, when the child comes for vaccination, the child is really distressed. And when the child goes back to parent, what is the behavior of the parent? You just observe that. If the child gets soothed immediately in few seconds, stops crying, it's more of a secure attachment, with the parent. If the child is avoiding the parent, it's trying to keep hands in between, it's kind of avoidant type. If it is actually sometimes the infants beat the parent themselves, or they are very aggressive. They become really anxious, and the crying increases after going to parent. That's where it is resistant type of parent-child attachment. And when it is totally havoc, means the child is not listening to any very atypical behavior, the child is just roaming around, that's called disorganized kind of parent-child attachment. And I do this, and we can actually measure and actually makes whether the child-parent attachment is secure or not. And why it is important is because we can actually tell parents how to make a secure attachment. And it starts quite early in first 6 months of age, where how the parent is responding to the needs of the child. For example, many a times a infant cries. It's very common that child cries. Most of the times, what the parents do, what the mother does in first 6 months, breastfeeding. Breastfeed the baby, right? But then we have to tell that hunger is one need. There are other needs like insecurity, boredom, and other things also. If the child is feeling insecure, you cannot give milk. That will give rise to different kind of parent-child attachment because you are not accurately responding to the need of the child. So you have to just give security, the child feels well, and child stops crying. So that's how you can actually do a lot of things at pediatrician level to actually assess parent-child attachment and do something about it.
Just a warning here. I think it's beautifully expressed by Dr. Sandeep, but I have to be careful naming it because most of the mothers come for immunization and fathers do not come for immunization. So you will be probably reading into the mother and the child attachment and not anything else. And I have to be careful about that because these are distressing situations, distressing for the parent as well as for the child. So yes, it is a good observation, but I would not want to conclude from that observation.
No, I just inquired this and I found an article in one of the journal which corroborates what I am saying. I will show that article where they found that this reunion of the child post-immunization will actually give idea about how the parent-child attachment is there. And it's called Pediatric Attachment Style Questionnaire, or the style which is PASI it is called, where you are actually know post-immunization behavior. So I am talking with some evidence also.
So our next audience question is, when does a skill of self-soothing, which is an expression of emotion, start emerging as early as 0 to 6 months, 1 to 2 years, 2 to 4 years, 4 to 6 years? Maybe a chorus answer again. Yes, it's 0 to 6 months. So a question to Sir. So what is the science behind temper tantrums?
I would request expert to be a little faster.
I think it will take just 2 minutes to talk about brain science of tantrums. It's very interesting. Dr. Dan Siegel has done a lot of work on parenting science, then child psychology, neuroscience, how the brain works. And according to Dan Siegel, there are 2 types of tantrums: upstairs tantrums and downstairs tantrums. And it's about the brain, how the brain is developing. And he gives a very wonderful hand model of brain. So if you keep the hand like this, all of you, just keep this, put your thumb here and encircle the thumb with your fingers. This is how the brain sits in us. Okay, this is the upstairs part and these are the 2 downstairs part. And as we know, this is the primitive reflective brain, this is the emotional brain, and this is the rational or the neocortex. Okay, now the child, how do you know about whether this upstairs tantrum or downstairs tantrum? If you imagine that if you give in to the demands of the child and the tantrum stops, it is more of upstairs because it is a manipulative tantrum. If the child is not wanting a toy and throws tantrums to get that toy, if you give the toy, the tantrum will stop immediately. That's upstairs because he is intentionally doing it. Okay, and when the child new toy is broken and the child is really upset and throws a tantrum, that's a downstairs, where you need a different strategy, where you're connecting with the child, where this part of the brain gets activated and what is called as limbic system and the primitive parts, and there are actually a lot of emotions which are evoked, and the way the parent responds to downstairs tantrum is different than how we should respond to upstairs tantrum. That's the basic brain science.
Just continuing with the same thing, sir, maybe how do you teach emotional management in this particular 3-year-old child, or maybe from the age group of 1 to 4 years, wherein it is okay to have tantrum?
It's very unrealistic to say that the child should be taught emotion management right at 3 years of age, but the emotion management and self-regulation starts quite early. And as we were doing this sleep session, the self-soothing starts in first 6 months of age, where the child starts, soothing himself. Where if we give opportunity to the child to soothe, of course, if you are giving solution every time rocking, the child will never develop the self-regulation skills. So in this child, there are two ways of teaching emotion management in any child, for that matter. One is implicit. That is how the parent is role modeling in front of the child. If the parent role models his or her own emotions in a better way in front of the child, it's called co-regulation. Okay, so when a child is feeling really intense feeling and the parent is, herself is also, intense feelings, she has to first regulate her feelings in front of the child, which helps in, learning. The child learns from the child, by role modeling from the parent. And of course, emotion coaching type, which is, because of time constraint, we couldn't go to that. Emotion coaching is one of the very interesting parenting style which has been discovered by Dr. John Gottman by intensive study for 2 to 3 decades about how the parent should deal with intense feelings of the child. Where, you actually validate the feelings first, where, actually say that, it seems that you are really angry, and then put limits and then let the child explore the solutions. So that's the emotion coaching. That also will help in child's better management skills later on.
In short, how would the parent handle this particular situation?
Yeah, so in this case, I think it was more of a upstairs parent, upstairs tantrum. So I think active ignorance, till the tantrum stops, will be, effective method in this. And of course, then connecting with the child, upsetting feelings, engage with them, tuning into his mind, validating those feelings that I wish I could have given. Just giving the child in fantasy, but not in reality. That's a very interesting way of, you say that, I wish I could have given, but then, I cannot give it right now. So just the wish is acknowledged, the child's intensity of feelings will go down. Okay, that can be a very good way of doing.
So our audience question, whether child with temper tantrums appropriate for age should be referred for evaluation. Seen occasionally, seen with self-harming behavior, seen frequently, BNC together. Yes, BNC together.
We move on to the next case. We have to little bit rush like the Archana rushed in the morning. So this is an 11-year-old Manasvi who presented with history of vomiting, initially reddish tinge, but later red color noticed, and this episode appeared 2 to 3 episodes happening since last 2 days. It was not related to any food habits, it was not related to any particular time of food, and there was no other positive history in terms of any way, in terms of any forceful bout, no fever, no loose motions, no bowel disturbance, and there was no significant past history. And this was the thing the mother had showed. This is what the color of the vomitus the mother had brought to show the child with. So on examination, this child was a well-grown child, weight and height falling at the 50th percentile. Child was hemodynamically completely stable, the PP was normal. Systemic examination per abdominal was absolutely normal. There was no organomegaly, and the other system examination was absolutely fine. There was nothing which could be pinpointed to say that this is something red color vomitus, if we may call it as hematemesis. That is what the history and the examination of the child was. So we just proceed further. How was it treating pediatrician? Would you like to proceed? Investigate further, observe the child, refer to an gastroenterologist, treat with an PPI. You can just say the... So since this session is tuning into the child's mind, I know the other option will be detailed history. But as probably if this child come on an OPD basis, where this is not the session pertaining only for the emotional thing, what would we be doing into the further? Obviously, one of the things will be going into the detailed history. Or anybody wants to refer to a pediatric gastroenterologist at this point of time? No. No? Okay. I'll take that answer. So I would again re-endorsement on a very learned audience. This child was also assessed for this head screening. So this is again an audience question. This head screening is for psychosocial history, physical examination, neurological history, or general history taking as we take it in adolescence. Your answers? Yes, it's absolutely right. Once we go in this heads assessment, as you all know this head screening, I would just want to know S does not stand for. Out of these four, it does not stand for sexuality, suicide, safety, and sleep. What is the right answer? The correct answer is B. In the heads assessment, it does stand for sexuality, it does stand for suicide or depression, it does stand for safety, but the sleep is not the one which is in this head screening interview for psychosocial factors. If you say only for the sleep session, this is for the psychosocial history. So sleep is.
Ma'am, the head score is coming ahead.
No, just try to understand there are many more factors about the sleep also when you come to take care of an adolescent. Okay? So that is why this has the more importance. So this is what is the heads assessment. If I may request Dr. Vaijayanti, you can just have a brief, short elaboration on all these factors.
One sentence. Yeah. So.
coming with that,
Okay,
sir.
I'll just say it in another one sentence then. So, okay. So, of course, this is for psychosocial screening of the of especially the adolescent child. Home is home environment. So, how the parenting is, how the child has having relationship with his parents, with others in the family. Education, of course. How is child doing in school, how is he in academics, and how is he interested in that. Eating, of course, are there any eating problems, he's not interested in eating, or other eating disorders like he's eating too much going vomiting, so some eating disorders also. Activities, if the child is doing physical activities like exercise, etc., or there are negative things which are happening like too much of screen time, too much of mobile, so all those activities and other entertainment things, and being on internet and playing video games, etc. The drugs, of course, in drugs, then it comes for addiction to anything. Of course, we do know that now especially the late adolescents are coming for the treatments also. In fact, we have been getting children at the age of 15 years also with alcohol addiction and the drug addiction. So they have been taking that, so we have to be very careful about it. Sexuality, again, how they are forming relationship with their own age children, and if they are involving, as she said, they are experimenting, and how much they are experimenting and to what extent they have gone to. Suicide and depression, of course, so it's mainly the depression we have to take care of, because again the children with depression are really coming very often. It's increased now, and they do have suicidal tendencies also, and we really have to catch them very fast, because then it just goes away and then the time is really gone. And safety, of course, especially at this age, because prefrontal cortex is still developing, so they do have all those risk-taking behaviors, rash driving, again drug abuse, so other things which are there. So for safety, and these days some people are adding spirituality also to this, so because that is also very important for your well-being, but that is just unofficially added. Sleep also probably we can add unofficially.
Thank you very much. So we just move on to the case further. This was just to summarize an 11-year-old female who presented with a history of red color vomiters, 2 to 3 episodes since past 2 days, which was investigated. This child was investigated at the second episode because the child was always brought with mother. The father was not there when the complaint were presented, when the child was brought. And the mother kept on saying that the father is very worried and we just don't understand why this child has sudden onset of. For them it was something like a blood, frankly speaking, and for us also, when you say red color, the first thing will be, our antenna will be definitely wanting to know whether it is a blood in the vomiters. A pediatric gastroenterologist opinion was taken here. She did a scopy and the scopy done was completely normal. The father was reassured, especially after the scopy being normal, because he was very worried. Though he never came up in the OPD, I have never met the father, but the mother was always getting the child, but she always kept persisting, the father is very worried, father is very worried. And after reassuring the mother and the father, the child was sent back, and the child come back again after 1 week with a similar repeat episode with again the red color in the vomiting. So what next? So at this point of time, since the scopy was done, everything was fine, a detailed probing again in the history was revealed. Though in the first episode also I tried to ask her any changes in the routines, is there any change in the child's behavior, is there any some trigger factor in the home which has made the child have this complaint. But at this point of time there was no. But when this happened second or third time, the mother revealed that the father was very strict and scolded her badly for watching something, probably a phone on the mobile in the middle of the night, and this complaint started after this. So this, as we know, is a medically unexplained symptom, and I would definitely want to say, see, especially for when we have a fever or when we have anything, we have an objective evidence of fever, we have some parameters or investigations to kind of come to conclusion for the diagnosis. But when they are medically unexplained symptom, they are just symptoms and you don't have anything to kind of have them diagnosis with regards to an objective evidence. So in that matter, I would say a whole psychiatry per se, the criteria when you take it in DSM-5 or so, it is all your history and how the child fits in, and there is nothing in the form of investigations you are going to prove it. So one has to have a very strong suspicion for this medically unexplained symptom, because they will be presenting to pediatrician most of the time, and I'm sure they will not be going to a psychiatrist per se with a vomitus, with a red color vomitus. So that's why as a pediatrician we should have a little insight about what this is and how we are going to deal with this and how we need to probe further in this history. So with this I come to our audience question. How common is a medically unexplained symptoms as a presenting symptom? Are they 30%, 12%, 20%, 25%? What do you feel it is? These are general. The literature says 30% are seen in the OPD basis as medically unexplained symptoms. They are investigated very thoroughly because they don't get relief, because obviously there is nothing as physically causing the issues, and they have a lot of, I would say, cost into it, lot of stress into it. So that is the reason this medically unexplained symptom is one of the entity which we also need to have, maybe more so presenting in the little later age group, not at when the child is very early. So I would just want one of our experts to highlight on medically unexplained symptom, how you see them in the OPD and how do they manifest? I mean, why should they manifest as a physical symptom when you have some stress in the mind? I have a mind stress and I may manifest with some medically unexplained symptom. Yeah.
No, anyway, so this is very, very common. All of us face it. And especially when the parents come with a big, thick bag of files and lots of reports there, then time itself, you really start feeling that what I'm going to see. And suppose the symptoms are like this, or maybe the commonest symptom I think is abdominal pain. So those are the things which are so many times unexplained. So here I think we have to deal with it like, you have to first not say this could be psychological, because the child does not like it if the child is big and the parents don't like it at all. So even if you reassure them by whatever investigations have been done, or if you want to do some more investigations, you feel okay, let me really remove all the doubts, because we definitely should rule out all the organic diseases. So if you do that and find out that no, that nothing is there and this looks to be this, now we call it as medically unexplained symptom, but when I think we were studying, we used to call them as psychosomatic, or now also.
Even,
now
DSM-5 it says psychosomatic symptoms.
now they say somatic. So these are the somatic symptoms. So many times the symptoms are true. The child is really getting that problem, but that problem has happened because of the mind stress. So that is the way I think the mind is really working now, and then the body and mind, they are working together as it has been mentioned in the slide. So here also in our case, of course, as you were asking why this head cells has come in between, because we have been taking history, we have been trying to find out what is the any organic cause for that. So all the investigations were done, gastroenterologist's opinion was taken. So finally, at least we get reassured that yes, there is no problem. The parents may not get reassured. So we have to keep saying that, okay, probably there is some problem, but let us find out if there is something going wrong in the mind also. And then you do that heads assessment and try to find out that how much, what, where, what is happening. So you go into deeper history. And here, finally, when you went into the deeper history and the child went for the counseling, and then maybe, no, not child went for the counseling, the father has found out the child was looking at the phone and watching the pornography. So probably that medically unexplained symptom is at least psychologically explained then.
See, basically, as she rightly said, they are real symptoms. I mean, we may feel that there is nothing wrong. So there are some factitious symptom or something, but what has been explained in literature is they are real symptoms, and the distress is manifested unconsciously through your physical symptoms, and that is the reason we need to handle it, so that the importance is also stressed onto the parents along with the child's distress, which needs to be taken care of, because those symptoms which are disturbing in day-to-day functioning needs to be attended. So I would just want to know what are the important steps for identification of MUS, which we already covered, Dr. Mamta. As we say, probably it is a more detailed probing into the history when you don't have anything to explain the symptoms which are in terms of examination or the investigations. And at an can we do anything, interventions at a pediatrician's level for this MUS? Dr. Mamta or Dr. Sandeep Kelkar?
Generally, when it comes to me, it comes with all the organic tests being done and being cleared that there is nothing physically wrong with this child. That's when it comes to me. So I think the answer would probably be better.
Yeah, I think here again, stress is the main issue, and it is caused by maybe harsh criticism, and she's not able to cope up with that, whatever been told by father, and she's been caught actually, watching it. So how to deal with those intense emotions she doesn't know. So probably I will like to do here emotional intelligence testing. EQ testing is a must in this child, because there is something going on in her life where the skill building is necessary, especially related to emotion management and stress management, because she's experiencing this psychosomatic or what is called as somatic symptom disorder, because of she is not able to deal with that stress effectively. So I would like to go there, and as a pediatrician also I would like to start doing something to build those skills.
So I think we will skip this. This is just to have a, what is the difference between the addiction and the dependence, because this is the most common problem as we see in the adolescents. As we all know, dependence is, I think I will skip this slide because we need to move to the, and this addiction, dependence, both of them can have an effect in physical and psychological mind. That comes to our next question. Which part of the brain is the most active when a teenager has an emotional outburst?
Just tell the
Say
answers.
loudly.
Amygdala.
Amygdala, yes.
Correct.
That's the right answer. And the question to Dr. Sandeep with this regards to this case, so that we can move next to the next case fast. How do you handle intense emotions for this child when she is caught, when the father is caught her watching something? How do you handle intense emotion? How do you approach? Some part of the answers are already given in our previous discussions also.
So I will be very quick on this. First is co-regulation. So when you see a child, when a parent sees a child with intense feelings, first he or she has to regulate her own feelings first before doing anything. It's like they say in the airplane that use oxygen masks for yourself when the oxygen drops before you use it for others, right? So same way in parenting also, you use that EQ mask where you manage your feelings in front of the child, where the child is really having intense feelings. And secondly, name the feeling and validate the feelings of the child. So when a child is really angry, rather than saying why you are angry, what is there in anger, getting angry, instead of that, just say that it seems that you are really angry. Just in a matter of fact tone, if you just validate, give a word to the feeling and name the feeling, the intensity of the feeling goes down, and there is a research behind it. It's called as name it to tame it. Okay, when you name your feeling or others' feeling, you can tame that feeling. Just naming accurately the feeling will bring down the intensity. So just say that you seem to be really angry. And then, go on to next. So I think there are a lot of things we can do on intense, emotion coaching is a...
In short, it is parent has to behave like an emotion coach.
Absolutely.
That is what you mean, right?
Absolutely.
Which we already learned in those 5 steps in the first case. So we move on to the next case. This is a 80-year-old Anna accompanied by mother. Mother complaining of the child is not eating well. He is hardly having any interaction with the family members. He was earlier used to play with his sister. but now he's constantly occupied with the thoughts that I'm going to die, the world is going to end, or I have to leave this world soon. This child was spending most of the time watching TV news, especially because this was a COVID era where he was not allowed to go for the school and not allowed to, have friends or nobody coming in the house. The child was average weight, vital stables, looked sad and tired, and the systemic examination being normal. So as a general pediatrician, what would be the next best action on your part? You can just have quick answers. Okay. So refer to a psychologist or a psychiatrist as the person, if the person feels that he can himself probe into the history and try and do some counseling, then one can take care of that. Otherwise, refer to a psychologist and psychiatrist. This was in the COVID times. The mother was an anesthesiologist, the father being a physician. They both were very busy in the COVID era practicing in their own hospitals. The family was a nuclear family. The children were mostly alone with a caretaker, and there was online schooling. So what would be the most probable cause for this above situation? Is this screen and TV influence, I would say. It is not addiction. This child was busy most of the time watching the news about the COVID. So what is your answer? Yeah, rightly said, all the above. There is not one factor which is playing into this child. So how would we intervene further? As we already said, refer to a psychologist. So here, what would be the intervention? Would it be for only child, only parent, or it is for both A and C? So I would like to ask our experts, what would be your take on this? He's just an 8-year-old child who comes in, the mother comes taking the child in the OPD saying that he's talking that I want to die, or I have to leave this world, or the world is going to end. So what would be your take on this child? Does this child fall in the category of depression? And of course, if he falls into category of depression, what are the criteria for diagnosis of depression? Dr. Mamta?
In young children, we don't get into diagnosis, frankly. Psychologists anyways don't diagnose, psychiatrists would diagnose. But I would say that the child is too young, and if I have, again, going back to what you all have been saying probably from morning, that take it into a detailed history. Just this one incident, I wouldn't get into wanting to think about depression, not that the features are not there. But once a diagnosis, then it becomes very difficult also, because diagnosis also means medication will come in. So I would be very careful. But one thing that is important, I think, is the take-home message for me here is, at least what I would like to tell all of you all, is that all behavior is communication. Yeah, any behavior that the child has is communication. Yeah, the fact that I am coping with the anxiety and stress of the news is through addiction to audio video. Yeah, so for me that is the communication that I would take first into account, and then I would probably get into the other details. I would not think of depression right in the first.
No, in this case, I would like to little bit disagree, because the child has got suicidal ideation. Any kind of suicidal thoughts is a red flag in depression, and it has to be immediately referred to psychiatrist, because it can harm the child also. Because just ideation, we don't know what's going on in his mind, but he is thinking of that, which is very strong red flag. So I would probably, you would agree with that.
Yeah, we will come back to case again, but this is just a criteria for depression, and the two most important criteria for depression would be feeling down or unhappy or sad, which this child was definitely, and a little interest or pleasure in doing things. So this child probably had definitely one of the, yes, 1 minute extra. So we will not go into this you can get on the net anytime. So I would just want, how would you approach this child, the child who has these features of, suggestive of loss of interest in doing things or suicidal ideation? How do you approach it? How would you counsel this child? Dr. Mamta, Dr. Sandeep has emotional management if you want to.
Yeah, I don't think suicidal ideation is not a red flag. I think what is important is how was the child pre this issue. Yeah, so lot of teenagers have suicidal ideation. Does not mean that you don't send them for diagnosis or you don't have the red flag of depression, but because the abstract thinking has come in at around 8th, 9th, 10th, I would say especially 10th and 12th, a lot of children have suicidal ideation. I wouldn't necessarily look at it as depression, though I would not say that is not important. Yeah.
So what would you do for this child?
For this child, I would first find out the history in terms of how was the pre-coping for this child before the COVID times. Yeah.
It was absolutely fine.
Yeah, so that for me is a good sign. That means the coping strength of this child is probably good. So probably I'll have to just see how the child, what kind of information the child is taking in from the audio video, what is it that the child is, what are the conversations at home that is happening, because sometimes, as I said, the anxiety of the family can be taken in by the child also. So getting all of that and trying to cope and get the child back to his pre-coping before the COVID era. Yeah, what were the child's strengths, and telling the child to use that only probably for coping. And if any active intervention is needed, I would probably look at that. The communication between the parents and the child also, because it was COVID times and both of them probably saw a lot of death. Generally, I think what parents do is if they go through difficult experiences, they stop communicating with the child. And that puts the child more in difficulty because the child can see the parent and non-verbal behavior. So all of that is probably what I will look at.
So these are the interventions, as Dr. Mamta has said, just to complete the story of this child. Apparently, the both father and the mother decided that this is something very serious note and we need to give the time to the child. And from their busy practice, both of them have shifted to Shirdi, where they are attached to the hospital there. And as what they made last to me, they said their life has been absolutely wonderful, with a good, communication with the kids, giving good time and enjoyment, and this was absolutely a real. Thank you so much. Before I end, I would definitely like to thank all the experts and all the audience also for their patient hearing. So thank you very much all.
Thank you so much, ma'am. Thank you, sir. Thank you, ma'am, for the wonderful interaction and sensitizing us to such an important topic of emotional development of the child as well. Moving on. After safeguarding the patient safety, the parent safety, now let's move on to our own safety as doctors. So let's look at certain medical legal aspects of our practice. So let me call upon stage the experts for our next session. Dr. Hemant Gangolia, sir. He's currently a senior practicing consultant pediatrician practicing at Nerul since past 31 years. He has many publications, awards, so please come on stage. To his credit, he's got a Lifetime Achievement Arogyam Dhanasampadam Award in 2017. Let me also call upon Dr. Professor Mahesh Baldava sir on stage. Sir is a senior medical legal advisor and senior pediatrician. And Dr. Parmanand sir. I request all the experts to please come on stage. Parmanand sir is the Chief of Pediatric and Neonatal Intensive, the Chief of Pediatric and Neonatal Intensive Care at Jupiter Hospital, Thane, and also Pediatric Intensivist at Wadia Hospital, Parel. To moderate the session, let me call upon Dr. Ram Gopal sir and Dr. Samir sir.
So thanks Diana for this introduction part. We are very thankful to the organizers, including Sneha, Amruta, Grevita, and also to the audience team members, including Kulkarni sir and Kelkar sir. So let's see, for today we are, as discussed and already mentioned by Diana, that something for pediatrics, something for our patients, and something for parents. But what is something for ourselves own? You call yourself as a pediatrician. That is true. But my question comes to you guys that in the era of medical legal cases happening, so just go ahead and skip these all introductions. Bridging the gap. We talk ourselves as a medical profession, which is a very noble, but it has turned out towards like a business now. And we are seeing that it is the only concern where patients die because of your mistakes, and these mistakes cannot be pardonable. So doctor-patient relationship has worsened further more. And that's the result in getting a lot of patient is not coming here. Okay, so it's will skip this part. So let's go directly here. So there are increasing the number of litigations on the doctors. And the common reason what we see now, going to ask next slide, criticism by our own colleagues. अच्छा आपने उसको दिखाया है, उसने तो बराबर किया ही नहीं. That's the worst thing what you are talking to the parents. Death of the patients, then there are deformity, disabilities. All this comes in a medical practice. Now I have to ask you certain things. Specialist, you call yourself as a specialist. I am an intensivist, I am a neonatologist, I am a nephrologist, I am a some other person. So you have a degree of DCH, DNB, MD. Okay. You have no other degree as an official. You have done some fellowship, you work for 6 months somewhere, and now you call yourself as a specialist. So is it legal to say yourself as a specialist? So let's ask the audience first. Dr. Mahesh sir, you are a person like you have done MD in pediatrics, also PhD, LLB, LLM in the law.
So I may do in musicology also, but I have nothing to do with pediatrics. So you can take in Sanskrit as well. Actually, officially, as per the National Medical Commission, these are the only degrees which are recognized as far as getting qualified as a specialist in pediatrics. All other like, fellowships, etc. and super specialty, which are there, which are now getting recognized as hematologist, as pulmonologist, or whatever kind of things which are recognized by the National Medical Commission or your state medical council, which are getting registered. With that registration only you can practice. The important thing is having degree is different, having registration is different, and we usually get confused. A person who is having a degree of MBBS, if he has not registered with the state medical council, he has no business to practice. So that is very simple fact to remember. Rest you can call whatever you want, but then the fact is whatever is registerable with the state medical council or National Medical Commission are only the things which are recognized and with which you can practice.
So as such, at the time when I started my career, it was not there. As a DNB degree in the intensive care. Right now there is a degree in the intensive care. Now degree of DM in neonatology, which was not there. So should I still continue talking as myself as a specialist?
You should not, you should deter, because this is a very common question being asked. As I understand, Dr. Ambedkar sir is also there. Previously there were people who did a MD in medicine and they started practicing pediatrics. Am I right? Yeah. So, and they were examiners in DCH and MD pediatrics. Basically, this is where the law is conflicting with whatever is going on in the society. In society, we have people who are just DCH and they are practicing, say, maybe hematology or maybe pulmonology or whatever, intensive care, etc. on the basis of experience. But as per the law, their experience, and as you are aware about that 8 pages National Medical Commission guideline, they did not give any importance to the experience unless, of course, that is a draft, but that very clearly says whatever degrees you take from a particular university and which are registrable with the state medical council, only those people can call themselves specialists.
There is a very famous case which was in Bombay hospital. Somebody is an MD medicine, but he has the DM students, but he still got in the court, and the court mentions you are not cardiologist because you don't have DM degree, you have only MD degree. So though he has teach the students as a DM, he himself is a MD medicine, but that was long back in 1960s. So this comes, and that's why we actually asked this specific.
But Samir,
so next question is
Samir,
yes sir.
Only thing is, there are two aspects on this. One is the legal aspect and one is the recognized teacher for the teaching. These are two different things. If you want to fill the form for the recognition of the institute, for recognition of DNB or recognition of your DCH, there are two columns. One is what degree you have a DM for neonatology, or is an experience of neonatology for that much from the recognized institute. Means like suppose you have a Vadia, I have worked for 6 months, or if I get the letter from the dean that he is worked in intensive care or in the neonatology for 3 years or experience, I can be a qualified teacher in an MUHS. But what sir is saying, it is an NMC guidelines. If it is changing, then it may be a different thing. But up till now, when the last form was there, it was and you have to have either a degree or an experience-based neonatologist. It was still valid.
May I add to this? Yes, sir. See, there is an hematologist who is at university, who is an examiner for DNB, and he is in Dehradun, and he is attached to the medical college. Everything is fine, and he has been held up by other people who have done DM in hematology in the court of law, and he has been producing all these letters from dean, from the university, etc. But the court is telling that, do you have a degree which is registered with the Uttarakhand Medical Council?
So on paper, the qualification is more important rather than the experience.
Can I?
Sir, there is a privilege in that. See, if it is, he may be a cardiologist, but he has his the expertise limited to non-invasive cardiology. He may not do even invasive cardiology if he's not trained that time.
He's not trained, but as a MBBS person, you may not claim yourself as a specialist. There you might, sir, what sir is correct. But I can practice as cardiologist, I can practice
Sir,
still as
either you don't
neonatologist.
claim yourself as a specialist, or if you claim you have to practice that specialty only.
No.
So if you are claiming that you are a cardiologist, you have to have that qualification to practice as a cardiologist.
We don't claim, but
yeah.
No, it's a big point, because right now all the institute beds, the fellowship, all IAP fellowships, all institute fellowships are not registrable. So they are not qualified. They neither it's an endocrinologist, neither hematologist, not IAP. They are not recognized by any institute. If you have done from MUHS for that fellowship, and you are done from a good institute, IAP fellowship, still the person who has done from MUHS fellowship, which is not good institute, that is still qualified rather than the institute, because it is registrable with MMC. It is not the IAP fellowships are not registered with the fellowships with MMC. So all IAP fellowships are actually, you are just an MD medicine or MD pediatrics, that's it.
Similar question.
On this count is absolutely right.
One line. Legally to speak only, there is a case going between the physician who is done the cardiology. There is a question against him whether he should practice a cardiologist or not. Legally speaking, whatever the degrees are registered under MCI or now NMC is legally valid. No fellowships, nothing will held in the court of law. So the question is whether we should write in our letterhead or the whatever the display board, whether you call as a specialist, that we should not do, but that we should avoid. Practice basically as an MBBS or an MD, you can practice that, but don't put on the board and the legal the things. And secondly, one more thing to that, it depends on the circumstances also, the areas where you practice. The area where the opposite the road, if there is a MD neonatology, DM neonatology existing, and you are doing the neonatology, probably in some cases you have to refer and take the opinion of that. But same thing, if the periphery where there is no DM neonatology, that pediatrician, because of the experience in the pediatric post, can practice as a neonatology. There is a little bit difference in that.
I will add on here the one thing. What he said very correctly, on the basis of your MBBS, if you don't write specialist, that's fine. But you can always fall back on your first, second, third MBBS mark sheet or its syllabus, or say that I have passed and I have been examined on this and I can do this. So that does not mean that by registering DCH or MD, your MBBS degree is relegated to dustbin. That is not the case.
Sir, it is something like a DMLT can do a investigation under the banner of a MBBS doctor who is authorized to practice the pathology also. Am I right, sir?
Absolutely. Absolutely. And there is a High Court decided case in Madhya Pradesh where a cardiologist, he is MD general physician, and so many MD general physicians are writing cardiologist. And he was held up by his another person who went to practice in the place, and he was held up by that
Even
fellow.
pediatricians, every MD pediatricians write pediatricians and neonatologists.
Yeah.
And one more thing, doctor.
Sir,
One more
go to the next
thing.
Yes, Ram Gopal, the only
Here, it's not doing an MD or DCH, even if it's from JJ or Sion. It's government institute or private institute. There are certain university or the degrees which are there in Sion or DCH like that, they are not MCI recognized.
Yes.
So they are not at all qualified for registration in MMC.
Doctor-
So even if you have done a CPS DCH,
should go on the next
CPS
questions.
DCH, you can still be qualified on the MMC.
Dr. Ram Gopal, take home message is only just one thing. Please write the degree which you are recognized by the MCI NMC to put on your letterhead or the note, what is the board of your establishment. That is the only take home message. No, that one should not write. That one should not write because that is not recognized.
Sir, next question is.
Samir said correctly, there is a circumventing way of that. Okay, you are a general pediatrician or a general special interest in hematology, special interest in maybe that way.
Sir, what are the legal status of the standard treatment guideline issued by the apex body?
See, the classic case as Ajay Dev versus the Shanta in the south, it came before the court to give intramuscular injection, which are the sites. So the case was absolutely, it was being given in the gluteal region, and patient developed sciatic nerve palsy. So they came up with not that giving in gluteus muscle in intramuscular injection is wrong, but IAP has come out with the guidelines which says vastus lateralis is the right place to inject. So with these guidelines, the doctor Ajay Dev, he was given.
Sir, but as per my knowledge, the textbooks are preferred over the standard guidelines. So
Absolutely,
I want a
absolutely.
clarification.
There are so many cases decided on guidelines. So guidelines have become loose in the neck of the doctor because the guidelines are being given by the academy or some association or IMA or IAP or whatever. So they may not have any legal holding. You can definitely go in the next court of law and
So that
you
is
can
what was
challenge.
my question is, what is the legal status
There is
of
no
the
legal
guidelines,
standard.
Given by the apex body?
But judges do prefer the guidelines.
The answer to
Simple
that is
he should approach the association to fight for him.
the guidelines are not mandatory. That are only to followed if in particular situation. And there's a guidelines. When it is put in the front of the court, what court sees, what fits into that. If it is satisfied, then only. But to follow guidelines is not mandatory.
Problem is a judiciary always says that now with the Boehm's law, so which is being relegated to dustbin again, that in 1957 it was the minority view of the physicians which was respected. Slowly we have moved to majority view with Montgomery in 2015. So now if majority of practitioners are following a particular practice which is authentic, respectable and reasonable, also logical, then only the court is going to accept it. So there comes the role of the academy or Indian Medical Association, etc. If they have given a guidelines, then the most of the doctors, the judiciary expects that you should follow them.
Even the textbooks, if you see, like when I done, it was like a 14th edition. Now comes 21st edition for the pediatrics. So guidelines get changed. Like let's see, we have example of a decay. So what happens? Like first guideline which is mentioned in the book, give 20 hours of fluid bolus. This guideline says no fluids, just give mannitol. What next guidelines? Keep the sodium in the normal range. Latest guidelines mentions give mannitol. So textbooks are standard, but you have to update your own knowledge also. That is also very important.
Dr. Samir, only one thing to say, because the question of guidelines came. Whenever you anticipate any litigations, please research the literature that time itself. What are the literatures for your side? What are the literature against? And as Samir said, latest editions, standard textbooks, no journals, no guidelines hold true in the court of law. So research that literature. You can ask your dear colleagues and the senior ones to guide that and preserve the literature, because whenever the incidence happens, the period of limitation is 2 years. So that complaint may come up after 2 years. So you don't know what happened that time. So please write a chronology of the case, whenever you anticipate some problem. So that is the importance of the literature of the latest standard textbooks guidelines.
Sir.
In the guideline, there is one more problem, because the judiciary believes in, but most of the time the guidelines are brought in by the patient. So they have guidelines have become patient friendly rather than doctor friendly. That is first issue. As far as the court of law is concerned.
Lawyer argues your case in
Exactly.
front of the
That is
judiciary.
Second thing is, even the books written by me, there was a big issue whether the pediatrician should preserve records for 21 years or not. The guidelines are basically up to 21 years, but that is not mandatory. Mandatory is for 3 years only. So they quoted the books which are written medico-legally in the court of law, and the doctor was told that. And now we have the prerogative that, okay, if this is the way, then we can call that association responsible person in the court of law for cross-examination. So be aware about that also.
Okay, thank you, sir. Next question. As per the Clinical Establishment Act, any patient comes to your OPD, you are supposed to stabilize the patient, whatever may be the specialty. So I just want to know what is this stabilization means.
So basically, the stabilization means stabilization of pulse, respiration.
No, sir, if the patient comes into the second stage of the labor, now in that case the stabilization is that you conduct the delivery. Now you are the pediatrician, can you conduct the delivery? Second question is, when we talk in terms of a golden hour, now we have learned that in that golden hour the patient should be at any institute. So how to go about it?
No, basically now here the thing is that whatever the specialty is there, if it is different specialty, and if you are talking about golden hour, then the legally.
Sir, don't you think so? Both the
Absolutely at loggerhead.
are opposite each other.
Absolutely at diametrically opposite. That is absolutely correct. And in such a situation, the logically whatever appeals to you best for the patient, for the benefit of the patient, you should be doing.
But my question is legally what is correct.
I got their answer, but before I answer that thing, Dr. Ram Gopal sir, I think so. I should mention something which I thought at the start probably you may ask this. I want to just take 2 or 3 minutes.
Yes, sir. Please.
Because that is very important. That is very important, because one most important statement is ignorance of law is not the excuse. So everybody should know. But there are too many laws, everybody cannot know each and every law. That is one thing. The another thing is that if any issue happens, if you research law, you may not find the answer for that. So there are so many gray areas to trouble our gray matter. So there are so many gray areas in these medical legal things. What are the laws? The two things, basic things one should remember. There are the standard laws which are passed in the Parliament or the State Assembly. Example, this Consumer Protection Act or whatever the State Medical Council. So that are the acts which are passed in Parliament. But whenever any issue happens and that issue goes to the court of law, the highest authority which gives the judgment, that is the judgmental law, and that becomes a precedence law. And probably I always say in my most of the talks, 6 words we should remember. Because if we see the questions whatever coming and the answers coming, it will be very problematic. So what are the 6 words when one should remember while practicing? I think so these 6 words are very important. The first is anticipation. second is documentation, third is communication. These three important words are why whatever we are doing practice, because we are not doing enough practice. One is practicing clinic, one is practicing office, one is hospital, one is super special. Everything is different. So one has to anticipate what problems can come when he's practicing in his area. Number one. Number two, his document. That is everybody knows. Communication, everything should be communicated. The three important things which probably will answer this question is that we should know our limitations. So limitations of as per our degree and our infrastructure, that is important. Then introspection, we should always introspect at the end of the day, audit ourselves, what we are doing, and probably putting the near and dear ones in the shoes of the patient, we may realize what we are doing and what we should not do. So we should, and lastly, ethics. Ethics are very important. We may not achieve 100% of the ethics, but try to achieve at least 70, 75%, and probably the 4 rules of the ethics are always respect, no harm, do good, and equality. So going this is a background, and probably this background, going to this background, whenever the emergency patient comes to any institute, so that is because there is a standard case law, Pandit Parmanand Katra versus Indian case law, which states that any emergency coming to any clinic, any establishment, it has to be treated by whatever the limitation, capacity, ability of that physician or of that infrastructure is having. And then when whatever stabilization, so there is no specific definition of stabilization. Stabilization means what? What is the structure available at your hospital? If you are able to stabilize according to your infrastructures, continue treatment. Otherwise, arrange the nicely equipped ambulance, everything, accompany and please make that patient to reach at the safest hospital. Just making the note and referring, that will not work.
So we need to transfer the patient, right?
If your infrastructure is well and good to handle the case, then you need not transfer. You stabilize whatever you can do.
There are 2 cases which I will quote. There is a Savita Guliani, who was a Dr. A.K. Manocha. A.K. Manocha is a pediatrician who is in his clinic attending to some OPD patients. And suddenly, patient was brought in with a stab wound from the DTC bus. And he did not even bother to see.
I was coming to that.
Yeah, he did not even bother to see. He said, you go to opposite Orchid Hospital. And in the Orchid Hospital, he reached, and there he died of hemorrhagic shock. Basically the femoral artery was cut. Orchid Hospital, in the judgment of the court, they were let off. That when the patient actually was seen by the doctors, that he was already dead. So Dr. Manocha was held up, and he was asked to pay 3 lakhs rupees. So this is one case. Another.
In that similar situation, I ask you one more question.
So
when we are accompanying the patient, now definitely we are having an OPD patients which are sitting and waiting for us. Now if you are going with another patient, and at the same time if another patient becomes serious in your absence, you are leaving one patient, you are going for another patient. So what is the legal status?
Legally, you are in a double jeopardy. Basically, I can only wish you good luck. I can only wish you good luck that you should not have such situation.
And sir, one more situation.
Take both the patient with you.
Clinically, the patient was not that bad, so I give a referral note to him, and in between the patient dies. What is my legal?
You are responsible, sir. That is, legally you are responsible. But as I said, it will much depend upon how you present your case in the court of law. If you are presenting the way you are presenting now, you will lose it.
So, Dr. Ramgopal, answer to that is anticipation. When you see that emergency case, if you feel that the people accompanying that patient, something is going to happen, probably leaving the OPD and going with that the patient is advisable, then not that the OPD.
If the patient deteriorates suddenly, then what?
You are not there. Suddenly and unexpected things. Sudden unexpected things when they happen out of the blue, and then it is your misfortune, bad fortune, and you will be landing in the court, and there if you present your things properly, that what was the setting, that you did this, that, and you have an actual documentation of that, you may be saved. But the way if you are telling that I left a note and I did this, then you will definitely lose.
Only you are in clinic or you are in a hospital?
Huh?
You are in a clinic or you are in a hospital?
Anything.
हॉस्पिटल हा तुझ्या तिथे काय लिहिलंय 24 तास इमर्जन्सी सेवा अवेलेबल
That
आहे
is not written.
रिटर्न ना
Not written.
He is aware that 24 into 7 into
Nowadays
360.
nobody writes 24 hours emergency available.
हा रिटर्न देन यू आर गॉन
No, I said it is not written.
Still, when you are not there, if you are accompanying the patient who has come first and critical, the other patient, like
Nahi, patients were sitting before only. These patients come in emergency, and now you are accompanying
So-
that patient when the previous patient.
so
is
you
not
have
back.
you have a trained staff with you who can triage and send the patient to the other hospital or accompany it in your absence.
We go on with that.
So we have a practical question now. OPD patient you have who needs to be transferred. You feel the child is sick. Oh, sorry. So OPD patient required to be urgently transferred. You feel that child is more sick. So ethical versus legal versus both the things combined. So what you do? So we have this question as a part. Write a referral note and send. Call particular hospital and send. Accompany the patient and ensure he went to the proper hospital. Call cardiac ambulance and send this patient, though patient party doesn't ask for that.
Notified.
No write up any note, just say. The question has legal points and then multiple debates questions. You did not get the proper answer. But what you have spoken so far, you have to take your own answers and just let us know what happened. So it may not be correct, actually you are doing, you might be doing something else. So say accompany the patient and ensure.
I think the audience is legally right. Yeah, it is not practical. That is a different issue. Yeah, that is. Yeah, that will not be you yourself or a pediatrician. You yourself, you are the, see, there is a doctor-patient relationship formed between the patient and the person who puts up the board or under the banner under which he is acting. The cardiac ambulance is a standby. That you are delegating yourself. You are now sitting, instead of you doing, you are in the shoes of the cardiac ambulance. You yourself are standing in the shoes. So whatever bad things are.
Sandeep, what you asked now, there are two types of cardiac ambulance. The cardiac ambulance sent by the official institution who's having proper personnel, what is spoke. And the other cardiac ambulance only having the medical officer who is not qualified itself. So then you have to decide if the ambulance with are qualified, you should accompany. If they're coming from the hospital which is having the RMO is qualified, then you can send into the cardiac that way.
See, there are
but be proper transfer.
Again, there
note.
are two things here. Once the patient, suppose you are asked from that the referring hospital to come and receive the child, it's the receiving hospital's responsibility to send a qualified person who can tackle the emergency in that hospital and reverse back. But sir, I want to ask you the question, if the patient dies in between.
Yeah. See, first of all, you should learn the legal concept of vicarious responsibility. Patient intends to come to you. The doctor-patient relationship is formed between that patient and you. So, whatever bad, good happens, that is your response. So, whatever actions you are doing, through your staff, through ambulance, through whatever, it is considered by the law as if you are doing yourself those actions, whether it by ambulance, by assistants, by qualified or unqualified staff, whatever. So if anything good happens, that is for your good fortune. If anything bad happens, that will definitely bring only bad outcome, will definitely, it cannot be rewarded. It will be punished in the court of law. So vicariously, you are responsible. You are respondent superior. You are the captain of the ship. You are the person standing in the shoes of those people.
We go to the next question, that's on the vaccine. Everybody, as a pediatrician, we give vaccine. So how many of you take the consent?
Whether the consent for the vaccine is required or not.
So handwritten consent, verbal consent, implied consent, no consent.
I think Ganguly sir can answer. Now we have only 30 minutes. So many questions, so rapid.
So we will just take rapid answers. See, the questions what you पूरा करो ना, पूरा options दिया है क्या आपने? So how many of you follow that?
नहीं
Never.
नेक्स्ट स्लाइड ही नहीं आ रहा.
Is there implied consent? Is there implied consent that the patient came to us? That means he has come for vaccination. That means he or she understood. So is there implied?
Sir, there are.
Yeah, yes, sir.
Yes. So vaccination is a issue. See now, if you must have heard ACVIP, our this advisory committee of vaccination. They have devised this UMP module, and one of the first slide which mentioned in that module, UMP module, which was made, I think so, Dr. Kasi was there in that. And what the first slide mentioned, key vaccination is an implied consent. So patient coming to you, so it is an implied consent, so no need to take consent. But this is the first thing. And much of you must have done UMP module at your place also. Thane mein hua hai meko lagta hai UMP, I don't know. So that is the first slide. So that is the committee advising. But vaccination is an invasive procedure. Any invasive procedure in practice requires a consent, as court of law says. When it is not non-invasive, it's okay, the implied consent works. So now question is how to resolve this issue. So whenever because it's an invasive procedure, one should take the consent. And in 4 or 5 years back, we used to see the first page of the file everywhere, the 3 lines down. I have taken the consent for the vaccination, the signature of the parents. But that doesn't hold true because that is not a real-time consent. So whenever the time one gives the vaccine, the fresh consent has to be taken, explaining all the things. Need not be in the printed forms. It may be 2 or 3 lines in the paper. One more thing can be added. Whatever we stick the stickers, that should be stuck on that. And what are the literatures that can be attached to the file. So that becomes the one little white consent. Now question is whether everybody should take consent or not. Written consent at every time. It is a definitely practical one, impractical thing. And the secondly, one can also argue then how in the government hospital without consent they are giving the vaccinations. That is one more issue they raise. But government, though legally there is no immunity, but still government escapes from that. But as an individual, suppose something happens at our place, legally we will be responsible. So then again that one word, what I said, anticipation. So one feels legally anything goes in the matter. Oneself has to defend ourselves only. No one will come to your rescue. So to save our skin, best thing is to take the consent. Now how to do it, that individual has to decide. So uniform, one line we cannot put. But legally what is it? Because vaccination is an invasive procedure, it does require consent. Real-time consent that time. Signatures of both parents as well as the doctors and with the consent explaining the pros and cons of the vaccination. Right.
Because why we are taking consent? Because if anaphylaxis happens.
Dr. Samir, what I say, I write on the paper only and I stick that stickers as well as I attach that literature in the file or I give it to them. आणि माझ्याकडे तर बरेच पेशंट आहे ना म्हणजे इंग्लिश वाचणारे नसतात पण मी त्यांना काय म्हणतो हे इंग्लिशमध्ये लिहिलेलं आहे हे कशा म्हणजे सर्व इंजेक्शनची माहिती याच्यावरती त्यात काय माहिती मी थोडक्यात मराठीत सांगतो पण तुमच्याकडे कोणतरी इंग्लिश वाचता असेल तो वाचून घ्या तुम्ही पाहिजे तर सो दॅट इज द थिंग्स दॅट देअर आहे देअरफॉर I appeal to Ms. Elisa for IAP to come out some vaccination information booklet. So whenever patient comes to our vaccination, just it happens the West, one should give the book to read. हे पुरा पडके आहो सर्व वाचा तुम्ही याच्यात ह्या वाचल्यानंतर तुम्हाला वाटत असेल की वॅक्सिनेशन द्यायचं तर तुम्ही आपण कन्सेंट घ्यायचं दॅट इज द बेस्ट वे टू डू बट स्टिल वी आर लॅगिंग दॅट सो दॅट वी शुड डू
Depends on the judge what he wants to decide. There is no clear-cut guidelines whether we should take the consent or not. But again, it's a judiciary.
May I add to it? See how many well-baby clinics do you have Mickey Mouse and all kinds of cartoons displayed on your walls, etc. How many? Most of the. So instead of having those funny cartoons, you can put some information in English, Hindi, Marathi, whichever language, regarding each of the vaccination, that what are their problems and what are their side effects. On the Can I finish this? So
let him finish.
On the wall, second thing, you laminate and ask whichever vaccination they are taking, ask them to take grab a picture on the mobile, ask them to read that this is the information regarding this particular vaccine. Or if you have a stationery and if you don't want to do that, you can distribute stationery that this is the MMR vaccine and these are the pros and cons of that particular vaccine. As Dr. Gangulia sir said very correctly, that invasive procedure, judge is not going to leave you charitably when anaphylaxis occurs. Even if you have treated the patient well, or later on some epileptic fits, etc., or some neurological problems occur. So in these two scenarios, possibly judges will punish the doctors. And most of the cases are decided, I won't go in the details of the cases, but most of the doctors have been awarded some or other kind of compensation to patient. Yes, now you
So my question to again both of you. So you mentioned about putting up the information on the literature or the basic of vaccination in the clinic. Dr. Gangulia sir did mention about putting the literature along with the stickers. Again, when we are giving this information and asking the patients and families to read, this becomes an implied consent. Dr. Gangulia said, in 2 or 3 lines, you need to write. There should be a real-time consent. So I want to ask you, sir, what kind of real-time consent do you seek every time, and how is it?
the concept of the real consent has come because of one Supreme Court judgment by 3 judges that in Samira Kohli versus Prabha Manchanda. Prabha Manchanda happened to be one of the best gynecologists in Delhi. She operated upon a 42-year-old female with a frozen pelvis with endometriosis. Patient's consent was taken for therapeutic and for diagnostic, and she performed hysterectomy with bilateral salpingo-oophorectomy. Only 25,000 were awarded by Supreme Court. Only 25,000. But just to impress upon the doctors that proper real-time consent is required.
So I just want to ask, sorry, what is the definition of invasive procedure? Is examining by stethoscope not invasion of a privacy of a person? So I think we can take that logic to any extreme and harm ourselves.
Judges don't take to that extent.
What about a PR examination?
Judges don't take to that extent. Yeah, the whole concept has come from the battery assault. Actually, in the American concept, that even if you touch or if you see with a different kind of eyes, it is an assault, battery. Okay, so to protect it, actually the concept of consent has come to protect the doctor. The implied consent came, the patient walks in, so he has certainly not come for getting traumatized, a battery or assault, or to protect, they brought in the implied consent. So with the consent, they went to the written consent. From there, they went to the informed consent, and now in India we have real consent. So there are varieties of blanket consent, and you will hear valid, invalid, this, that. So if you read a chapter in my, there are 5 chapters I have written related to information, forewarning, disclosure on consent itself and the cases. And Americans have gone far ahead, that even doctor is suffering from fits and is taking anti-epileptic, is a drug addict, is an alcoholic, is a womanizer, yes, he is HIV positive, HCV positive, HBV positive, he has to disclose. So we are not to that extent.
Best way out is every time, whatever you write a prescription or give a vaccine, just add one note, parents have been counseled. That's it. Now the onus is on the parents. They can't say, we were not informed. Look, I have written, parents have been counseled. You could have asked me, sir, you did not counsel, why did you write this? I think make a habit. Even when you write some prescription, or whenever you write, no medicines required, write, parents have been counseled. Okay, then the onus is on them. Absolutely. I do write every time. My impression is this, parents have been counseled, because my impression may be wrong. But I have counseled them, and I think that is the safest legal way. Yes, so for the vaccine,
One more thing, just add to, parents have been counseled for pros and cons of the vaccine. That's all.
See, when I do my duty and I have said I have counseled, it means I have counseled on all that I have done. I'm sure legally it is valid.
Whatever you write, at least
So,
add 2 more
and-
words. That is nothing.
Supposing
You are writing consent, write pros and cons.
we take a consent and we make kind of a software and मतलब online कुछ ये करके रखा तो is it
Now,
वन मिनिट सर मॅडम तुमच्या क्वेश्चनला आन्सर आहे
Amruta, your answer is coming.
मी माझ्या बाळाला गोवर लस देण्याची परवानगी जे डॉक्टरने मला सर्व समजावून सांगितलेले देत आहे. दॅट इज सफिशियंट टू लाईन बस आणि सिग्नेचर बस.
take the signature of the father?
Every time
One.
when you give a vaccine.
So, and do you write all the vaccines that you have advised?
We should and we should.
In government sector, madam, no doctor is giving those vaccines.
that is a sovereign act. The king cannot do any wrong.
So can we make it in an online form? मतलब वो ते सगळं
Sir,
जमा
Ganguly sir, I
करून
request you that you have a ready-made format consent for the vaccine. Can you just send that to the
I will send it to you. You can just make ready-made, but ready-made that should be ready-made रहेगा. मगर उसके ऊपर आपने हाथ से लिखना है date time. That should be in your handwriting. So that then becomes legally okay.
Sir, next question. When we are attached to a corporate hospital, as a visiting consultant, we write the order for the staff nurse. And if you have written an IM injection, sisters gives IV injection. Second thing, if you have written a chloramphenicol and sisters gives IV chloroquine, whose responsibility it is?
Again, the concept of vicarious.
Wait. There are a lot of issues in that. So, should
Why-
I enumerate the issues? Now, I am a doctor. I have not employed that nurse.
Ram Gopal, your question has been answered by the audience.
No.
So suppose I have my own clinic versus I am working in the corporate. So when I am working in my own shift, I own for all the nurses, junior, everything. When I am working in the corporate hospital, I am not bonding with the nurses. Nurses are taken by the hospital.
They are employed by the hospital. We don't have any quality control on the staff nurse. One thing. Second thing, it is paid by the hospital. So, and being a doctor, we cannot be expected to present every time when the staff gives the injections.
Patient is admitted under whom?
Patient is admitted under you in a corporate hospital.
You are responsible.
No, but are you, the staff is not employed by you?
Whatever error, who has sent that patient to corporate hospital?
That means you are expected to present every time when the staff gives the injection. You have written an order 8 hourly. So 8 hourly you are supposed to.
Ideally, yes.
No,
Are
that
there?
is not practically possible. Baldova sir and Ganguly sir.
The basic thing is that when you are in a corporate hospital, you are taking all the risks of someone else employing
Exactly, sir.
someone else employing a staff member who is not properly qualified, underpaid, just in the name of good 5-star ambience. They are making you a great fool. So that is one thing which is, and always the patients will come initially in the name of the hospital, to corporate hospital's name. They come to Dr. Ram Gopal. Once the mishap happens, the corporate hospital will be the first to run away from there, saying that it is all the responsibility of Dr. Ram Gopal, who is the captain of the ship, respondent superior. And all the staff members are working under the supervision and direction of Dr. Ram Gopal.
The sole responsibility of the operating.
So, नाही डॉक्टर one minute, Dr. Ram Gopal, that is a vicarious liability. And what you have narrated, chloramphenicol, that is a Spring Meadows case law, where hospital also compensation as well as doctor as a staff. So vicarious liability. The ratio is different.
I will tell about the very specific case. one medical college, private medical college, 6 kids, newborns died within the span of 15 minutes. It's a very new case. It's not like a very old case. And that time, of course, lot of media hype, but judge was very clever. He gave sentence only to the nurse and junior doctor at that moment. In his judgment, he very clearly said, head of department and the person on duty who are not at that time available, they were exempted. And that was very clear judgment. If you want, I can give you personal comment on that part. So whatever, like what we speak, it is okay, but what is given judgment, it has also to keep in mind what was there. No, I will tell you later on.
I will tell you another case.
Classical case is that.
No, this is Harjol, everyone must be knowing. Harjol Sil Ahluwalia versus Spring Meadows Hospital. Now in this case, instead of chloramphenicol, IV chloroquine was given 5 ml bolus and respiration and heart stop. They resuscitated. The child is still living with cerebral palsy and mental retardation. And in those days, that is 1996, Supreme Court awarded 3-judge bench 12.5 lakh rupees. So, and that time the pediatrician was awarded less, the hospital was awarded more, and the nurse was unqualified, was left alone in spite of her negligence. You know, she worked under the supervision and direction of the pediatrician, under the supervision and direction as the captain of ship, the vicarious responsibility of the Spring Meadows Hospital.
Next question. When the patient is brought dead to your clinic,
डॉक्टर रामगोपाल जस्ट आय विल से एक आठवड्याच्या आधीचीच गोष्ट आहे. आमच्या रायगड जिल्ह्यामध्ये झालेली आहे. एक ट्रान्सफर करता डेथ झाली आणि द पेशंट्स as we know everybody is having registration number and how we get registration for hospitals everybody is aware of that. Though the papers mention qualified nurses are there but वास्तवमध्ये नसतात unqualified nurses. तर त्या पार्टीने because the hospital is not having qualified nurses आणि त्यासाठी त्यांनी केस फाईल केली आहे. So we should be very aware of that when registration is being taken the qualified nurses should be there. About Mumbai I am not aware, but at least in the district places at least A&M should be there. One A&M in the nursing home should be there. That is the qualification should be there. But still A&M is there, but that whatever she does it is to be under the supervision of the doctor. So now that questions, if you are there 24 hours or not to see the things, but certainly something happens, it should be under observation.
Now, to add to this, the vicarious responsibility, as per the court, there is a case by Alema versus Dr. Alema Varghese versus Dr. Varghese. Now in this is a qualified nurse, BSc nursing qualified nurse. MOP were not counted properly, which is the duty, and in the court of law they said this is the duty of the nurse during the LSCS to count the MOP. And MOP was left, but ultimately finally Dr. Varghese was held responsible along with the hospital for leaving a MOP and glycemic occurring in that lady. So there is hardly any case I am aware of where the nurses have been punished or awarded compensation to be paid to the.
Like the recent case where the gynecologist advised an ultrasound and the child had anomalies which was missed up by the radiologist, and even the gynecologist was held responsible for that.
Yeah. So absolutely, the problem is that the principle of vicarious responsibility is extremely sensitive, and most of the judges, when nothing occurs to their head, they pass on to the qualified doctor. Second is a res ipsa loquitur. The negligence speaks for it. If you don't produce proper explanation, then they just substitute the evidence by saying that since doctor has not explained in the court's judgment, the doctor is responsible. Now, these are the two very funny kind of concepts. Behind the smoke screen of that, most of the judiciary is working.
Okay. So the next question is, when the patient is brought dead in your clinic, what should be your first action? Whether you start a CPR immediately, or you declare the patient dead, or you wait for some time to declare the death? Because sometimes we have seen the child starts moving after some time, or immediately you inform the police. What should be the action in chronological order? Any patient brought dead.
So the patient brought dead.
Patient brought dead.
So we don't know whether it is dead also. One thing is when patient comes, you don't know whether it is gasping, whether brought dead, just dead. As Panan sir has mentioned about one of the cases. So now question comes whether we should try and show that we have done CPR. If you do CPR, that means patient was alive and that's why you tried and patient died. So patient died at your table or your hospital. Second, if you declare dead and patient is actually not dead and he started moving. Okay? So sometimes you wait, you say, no, we should wait. So should we do ECG to confirm that it is straight line? Lot of hospitals they do actually the casualty. Or you just wait and watch. Sometimes you feel that there is a lot of mob is there and that's why you want to wait. So we'll ask the expert first and then we'll ask the question later on.
Thane sir wants to ask first.
We should do what a good Samaritan should do. That if the patient comes, you genuinely assess him and think what you feel. If he is recently
Sir, but
dead.
if the patient is already dead and you start CPR, you are putting your
So
hand in
I think first of all you do with good heart, and then what Dr. Hemant said is correct. You quickly counsel them, you anticipate trouble, you counsel them that probably he is dead, but I will try my best to give CPR to him. You can't take written consent at that time, and I think that would be the best thing. So I think acting with the goodness of the heart would solve most of the legal problems.
Sir,
And
legally what we should do, because mostly what people do, once they feel the patient is dead, they send them back to their general.
Dr. Ram Gopal, sir, before we proceed, I think there is a lot of chill which is coming with the AC. So, yeah.
what did you do to that patient?
We will just move very fast because we are at less time.
5 minutes, sir. So,
So,
rapid questions.
patient brought that first issue, dead patient cannot be transferred. That is the first attitude of ours. Always we try to shift that responsibility to others. When we realize कि बाबा it is dead ना, तो अपन लगेच पाठवून देतो. सरकारी दवाखान्यात जा नाही ते जा. Dead patient cannot be referred because in future any litigation occurs, the inquiry starts from there, and the first person for the inquiry will be yourself. So first dead patient cannot be referred. Now, whenever the relatives bring the dead patient, you assess the mob or the number of people coming, whether they are counselable or not counselable. They are in what mood? We are having pediatric patient. So first, ask them to keep the child on the examination couch. While pretending to examine, at the back of my ear, आपला माहित पडून जातं की बाबा गेलेला आहे. पण तरी let us examine the patient, and while examining, please try to collect some details. Why? I will tell you. कुठल्या गावाचं आहे आणि बाळ कसं होतं जेव्हा तुम्ही आणलं आणि काय होतं असं थोडंसं शॉर्टकट हिस्ट्री एक्झामिन करता करता हे करायला पाहिजे. कारण जर तुम्ही ठरवलं नाव बघून की बाबा नाव आय विल डिक्लेअर डेड, क्लिनिकली वी फील दॅट इज डेड, probably most of the time they pick up the child and go away and you don't have any details. Why we want details? Suppose they run away with the child. When you say ki it is dead, आता आपलं काय करता येत नाही, they don't believe because they're in the denying mode. So one should have the information that we can inform the police ki माझ्याकडे this one patient was brought from here and there and according to it was dead, but they have taken away the. So that make us the legally safe. And at the same time, we should inform the police. That is the one thing. Then, now assessing the mob is very difficult question. So just see how it is to be done. If we feel, now the question is whether it is clinically dead or not. So of course you can see whatever the clinical signs are there.
The child is clinically dead, that is what, but still do we give it?
Now you will ask me ECG. ECG is not available at every clinic. In every office we don't have ECG. So to document whether it is a ECG straight line. So practically that is not possible. Whether ECG should not be done or not done, I will ask that Dr. Baldava afterwards when I finish. Because in one of the medical talks in Bengal, one of the intensivist, I don't know what Parman has the idea, the intensivist says even the child is dead, we will do CPR for 30 minutes. I do not know what was the reason. One of the intensivists at Calcutta. I don't know what are the guidelines in the intensives. So they say we will do the CPR for next 20 to 30 minutes and then we will declare the dead. So that time I said ki I feel that is not right, but ठीक है, that is the guidelines. What is it? So as for what practically, if you feel clinically dead, pupils dilated, no risk, no signs of life seen, probably you can clinically declare dead. No problem in that. Now declare dead, and whether to give DC or not. So if it is a regular patient, as seen in the past 14 days, and if you know the disease, then you can give the disease. Otherwise, preferably when you don't know the cause of death, because you are examining the dead child, you don't know what happened. So probably cause of death cannot be given. So never issue DC. And then the question of disease comes in the, if anybody feels, remember only one line. If whatever certificate one writes, whenever one writes a certificate, just remember one line. If this certificate goes in any litigations, and if any court of law asks you to come, put the summons to you and visitor give the statement, whether one will be able to justify your certificate, then only give. Keep this in the back of the mind. If you are able to justify your certificate, then only give. Otherwise, never ever give any certificate. Most of the people tend to have in good faith. Because I feel at present, this is the era of consumerism. We should have a professional attitude. Whatever is this, we should never, we think is in good faith, but sometimes it's not in good faith. So it will not be done. Yes. So if you are confident, so that again that line I am telling, if you have seen that case for last 14 days and knowing that this case properly, the diagnosis, depending on that, one can give the cause of death. But still, if you are surely safe and if you are able to justify your cause of death certificate, then only give. Because we do not know, though you are knowing it is a chronic cause, but what made the death? Because you are seeing the dead patient. So whether few moments before, 1 hour before, was there any suspected foul play? Same thing happened in the Mumbai, one of the suburbs, where the DC was given and then the complaint was made, and it was the case of the suicide, this poisoning done. And that doctor who gave the certificate was behind the jail. So that one should always remember.
Sir, one more question.
Hello.
The patient is brought dead, and you have assessed the clinically the patient is dead. No CPR, but then how long you should wait before declaring that?
That I was coming to only. So CPR ka bata hai, CPR, if one gives CPR, then it becomes admission. So then you have to make all the papers properly. And then everything has to be written, and then everything follows that. What CPR has given, everything. So it becomes all the admission type of paper. And in emergency, in OPD basis, at least on the right on any paper or the letterhead. That is that. But what you said, Ram Gopal, after some hours, there is some movements. Probably that happens only in neonates and not in the older things. Sir is there and Amdekar sir is there. I don't know. Sir, तुम्ही मला ह्यांनी सुरुवातला नाही पण तुम्हाला नमस्कार करतोय आणि आमच्या बलदेवा सरना नमस्कार बाकी सर्वांची माहितीची आहेत पण आय रिअली फील मला मी पहिल्यांदा सरांसमोर बोलतोय इथे तर सादर चरण स्पर्श सर आणि सर तुम्हाला So only neonates sometimes are there. That is, I don't know what is the terminology for that movements occur after some time. So that is only the thing where other in most of the cases never happens. Madam, तुम्हाला काय?
हां, मी फक्त एक थोडा ॲड करायला मी समीरला सांगितलं होतं पहिले पण एकदा की फर्स्ट पोस्ट होती आमची आणि त्यावेळेला एक पेशंट होता RH इनकम्फर्टेबिलिटीच्या होता आणि मी नाणावटीमध्ये फर्स्ट पोस्ट करत होते आणि त्यावेळेला हे डेटच्यासाठी तुम्ही ECG करा किंवा काही हात नको लावा हे सगळं मनात येणारच नाही तसं होतं कारण आपण काहीतरी शिकलेलो असतो ते सगळं तिथे आपण दाखवतो आणि नॉलेज करून ह्युमॅनिटी फर्स्ट येतो जसं सानेनी सांगितलं होतं तसं तर त्यांनी 3 दिवस एक्सचेंज केलं होतं आय बिलीव्ह बिन ऑलरेडी 20पर्यंत 18 to 20 राहत होता आता ते पेशंट माझ्या को हाऊसमेननी राऊंड घेऊन सांगितलं की ते डेड आहे डेथ सर्टिफिकेट लिहून गेलं आणि मला सांगितलं की तू आता सरांना बोलवून फक्त साईन घेऊन टाक आणि नंतर त्यांना पाठवून दे असं करून आता क्लिनिकली आपण बघतोय तर आपल्याला हात लावून चालतच नाही आता सगळं डिजिटलाइज झालं आहे म्हणून आपण काही वेळेला काही गोष्ट मिस करून जातो तर त्यावेळेला मी पहिला हे पेशंटापासून राऊंड घेतला आणि तो पेशंट हात लावला की थोडासा गरम वाटला मी म्हटलं आत्ताच कदाचित डेथ झालं असेल आणि त्यावेळेला मी CPR केलं आणि माझा स्टेथो कदाचित चांगला असेल किंवा काही माझ्या लक असेल, देवाला प्रार्थना करून त्यावेळेला केलं आणि तो पेशंट वॉज रिवाइव्ड. तर हां, अशा कंडिशनमध्ये डेड पेशंट असेल किंवा हे, आपण डॉक्टर आहोत, आपली ड्युटी पहिली हे आहे असं माझं म्हणणं आहे. आणि ते पेशंट सर्वाईव्ह होऊन मला माहीत पण नाही पडणार. संध्याकाळी मी एकदा गेले, 10 वर्ष झाले त्याला, आणि ते पेशंट माझ्या समोर आला इव्हनिंग राऊंडला वगैरे, तर म्हणे आपण ओळखलं काय? मी म्हटलं नाही असं. तर असे केसेस रेअर असतात, पण ते म्हणे तुम्ही 10 वर्ष आधी असं केला होता आणि हे माझी मुलगी आहे. दॅट वॉज अ फर्स्ट क्लास पेशंट. सो त्यांनी जर्मनी जाऊन सगळं फार ट्रीटमेंट वगैरे सगळं केलं. पण दिस इज अवर रेवॉर्ड. सो हे सगळं आपण जाणून, हे लिगल आस्पेक्टमध्ये आपल्याला फसवून करणारे जे असतात ना, त्याच्या प्रोटेक्ट करायच्या तुम्ही कोशिश करा. ते नर्स असतात त्यावेळेला पण.
मॅडम,
मला सांगणं आहे.
मॅडम, मी अंडरस्टँड व्हॉट यू वॉन्ट टू से, बट मला 2-3 गोष्टी सांगतो. देन आय विल आज डॉक्टर परमानंद वन थिंग. 10 वर्षापूर्वी आमचा नेरळ अजूनही खेडागाव आहे. ते एका फिजिशियननी, नवीन फिजिशियन आले ते, टेक इट व्हेरी लाईटली, टेक इट व्हेरी लाईटली. तो पेशंट मला येऊन काय सांगतो, अरे सर, ते मेलेल्या माणसाचं कधी ECG काढतात का? म्हणजे दॅट वॉज द ॲटिट्यूड ऑफ दॅट पेशंट पीपल दॅट टाईम. बट आता नाव द थिंग्स हॅव चेंज. द 2 questions what are arising, what you have asked, whether after arrival of the dead patient one should do CPR or not, I will ask Dr. Parmanand. Number 2, whether we should do ECG or not. And third, how much time we should wait if we are not confident clinically.
Well, flat line, na? So should I do CPR or no? How many of us having a ECG in your hospital or a clinic? What the question is? Whatever, clinic, na? Clinic. Chokani sir is here. What are the cause of pulseless activity? Sir?
Attend monitors. I think
Asystole is one of the cause. Systole is one of the cause. Yeah. So only thing is, it's a first thing is like in the pulse. It's like when your patient come pulseless, there are 4 situations: PAE, straight line, asystole, ventricular fibrillation without a pulse, ventricular tachycardia without a pulse. How you diagnose VF or VT without a pulse, without an ECG? So how you diagnose dead? So how you diagnose dead in your clinic? Then what is the justification of not giving CPR at the clinic? So I'll give you example. One patient, which is Praveen is here. One patient was come to casualty, had an electric shock. He came arrested in a situation casualty, right? You have to imagine an electric shock, and that patient came to casualty, must be 30-40 minutes, 25-30 minutes. We did the ECG, it was VF. Given the CPR, and patient went home. And he is neurologically also, I think it was normal. So it was a CPR done after 30 minutes. So patient had so how you diagnose dead? Second, I will give an example how long you should do a CPR. It was my patient. I was doing a CPR with one patient, which was actually the resident called me. The patient went into arrest. I'm like, okay, she could not intubate. She put an LMA and continued CPR. So by the time I came from home, I saw the patient, like in 25-30 minutes was over. So how long to continue? So I was also wait for, like, and I spoke to the relatives. I went inside and continued CPR for 10-20 minutes more. I was going to declare dead. And before declaring dead, I got the patient's relative, come inside. I will, like, and it's sab kuch kar rahe, we are planning to declare dead now. While declaring dead, I saw some electric activity. The ECG was going on. It was around 45 minutes of CPR was on. I said, just casually, पहा तुम्ही सगळं काय करतोय, थोडी ऍक्टिव्हिटी दिसते, पण आपण पुन्हा मी बोलतो थोड्या वेळात. and I took the patient out and came back, matlab nikal gaya patient. They will stop CPR and see that ECG has come up. Patient had come up, the heart has come up, and it was 45 minutes post CPR. And the patient went home. Mentally also followed up later on, and it was not that severely handicapped. So it was normal. So it should, before declaring dead, I feel ECG is must. How long? It depends upon which type of patient you are doing a CPR. If you feel it's the terminally ill patient, or like the outcome is not going to be good, anyway you are going to do a CPR, just on the paper you do it, but write on paper that you have done a CPR. If you feel that patient medically he was not having any chronic illness at that time and an acute illness, give CPR as far as there is no clear-cut guidelines that 10 minutes CPR is enough or 45 minutes of CPR is enough. It is that you have tried, you can write down on the paper that you have tried 35-40 minutes, but there is at least minimum time it's around 10 to 20 minutes.
55 minutes is what Pal said.
Yes, sir. It's nothing. There is no guidelines. Okay, sir? Is it 25 minutes?
Pal says that 25 minutes of resuscitation, then it can be reasonable to stop resuscitation. That's what I, at least when I was very faster at.
Time. There is no time duration which has been spoken. It depends upon the type of patient.
Sir, in a clinic setting, so this is in a casualty setting, for example, but in a clinic setting where all of us do not have an ECG or cardiac monitor, so you basically start CPR, especially in an acute case, and then transfer while you are trying to stabilize?
Accompany patient to that hospital.
Transfer with accompanying the patient to the hospital.
The patient can blame that the patient can blame which you had come to your hospital, the patient was alive, you are not done CPR, and that's the reason the patient has gone to other hospital, he was dead.
No, so you transfer accompanying the patient while you record. No, one last question, sir. So you're continuing the CPR, you are taking the patient to the hospital. What happens if the patient actually succumbs while you are transferring?
Fine, it's your responsibility. Then question comes to your certificate. Is that patient been treated by you in the past? If yes, you expect the death to occur, you can give the certificate. If you expect that patient, and it's not treated by you, or he's been treated by someone else, you know that colleague, and if he's ready to give, fine. If not, do a PM. Don't give certificate. Just send for postmortem, because you don't know the cause of it.
You're not.
Second.
1 minute. 1 minute.
We have there is a time limit.
but-
I request Amdekar sir to sum up for 15 minutes.
So, 1 second. Parmanand.
I
Yeah,
think
good.
we can, because it's a never ending story, we can have one full decision on that.
Yeah.
Sir, please. Mike.
So basically, I am asking you, do you recommend that we have an ECG? Having just an ECG in the OPD is not going to help. We will have to even have an AED, because that electric shock patient you would have shocked basically. You would have given a DC shock in a VTAC or a VFib. How else would have revived that patient? So is it a recommendation to have all that in a clinic? That's what or a small nursing home. AED technically, basically we should be having it that also, right?
Technically, now also the AEDs are recommended in the malls, airports.
Yes, that's
and
what
other
I
things.
know that.
You should take it also.
So I think we should have it in the clinic. That's what I feel.
Now, only thing we are all in the medical mode. You please get into legal mode as well.
I think
जेव्हापर्यंत कुला टेस्ट लागत नाही ना तोपर्यंत आपण नाही मेडिकल शिरत.
I think I've enjoyed the whole day. It so happened about 2 months ago, suddenly 6 people descended on my home, and Ram Gopal and Grivita were part of that, and they fooled me. And they said that you should come right from 9 o'clock till 6 o'clock. I did not realize that they were trying to put my brain stress test. And at the end they said that you must tell us at the end whether you digested anything, absorbed anything, retained anything, remember anything, and whether you can talk something. Now, that was too much of it. I said, I can sit here. I was physically alert, mentally alert also. Okay, it's too late now, but I just want to tell you what really impressed me of each of the topic that we went through. The first topic was on infection, and I learned that though viral infections are common, the complications of viral infections may not be so rare. And therefore, we just don't leave them as viral. Most of them get well, but some of them get into big trouble. So we have to be very alert that so-called simple viral infections could be troublesome, and they could be right from neonate to any age, and anybody could complicate. So we will have to be very, very vigilant about just saying it's a viral infection. That was the message of the first thing. The second was the recurrent one. And we discussed the urticaria, the headache, and the vomiting. And again, the point that Sudhir had made, fever-induced recurrent urticaria. Okay, can you imagine any fever, whatever the reason, can just induce urticaria again and again, and not only necessarily an infection doing that. We, of course, learned about headache, about the tension headache, the sinusitis headache, migraine headache, and so on, and so also vomiting. And we learned that vomiting can come from any part of our system, and we need to recognize what kind of system that is causing it. And that was a second session of chronic thing. The third session was very interesting, and something that we hardly talked, something hardly we knew, and we realized how important it is. I'm sure all of us are really sleep date. Not me, I sleep enough. But many of you who are busy have a deficient sleep for no reason. And I think we learn how sleep can cause a lot of trouble. But of course, pathologically, there could be many reasons why you don't sleep. You are stressed and you don't sleep. And you have a circadian rhythm problem that you don't sleep. And of course, you have an obstructive sleep apnea. And Indu and Prakash did a wonderful job of telling us what sleep means. And I think I must say that that was really an eye-opening, that you don't have to think when you are alert, you also think about sleep. So that was a very good message. Then after lunch, we got on to office problems, and several things were very well discussed, very well debated, and we had a lot of different things. We learned constipation is an emergency. Don't neglect it. That was the message. Then, of course, we went through many other things like syncope, and everybody who just falls down may not be syncope. He fell down because he is always busy falling down, and he had a vision problem. Many things. We learned a lot about syncope in that discussion. And same way they took about to speech delay. And quite a few of us haven't spoke a word also. I was wondering what is the diagnosis of their speech delay. Very few people talked. And then, of course, we had a precocious puberty as well being discussed. So that was a very, very good common office type practice, but many times we ignore them and we have not addressed them. But the last two sessions were excellent. Okay, we had never discussed those things. The last but one session had on a mental health. And I think they gave a lot of importance to how the mental problems can really cause that. And mental includes not just a cognition, but social, philosophical, psychological, so many parts of that mental thing. But I think what possibly was not mentioned at all is that we as pediatricians should also think what are the mental hidden problems of the mother who brings her child. And I think even if a 2 days fever, the mother brings the child, mother has a lot of hidden mental symptoms. Like she has an anxiety, she has an uncertainty. She is asking you whether it's a COVID, and she has heard some people get into ICU, some die, some never recover. She has that anxiety, uncertainty. She's frustrated that fever is not getting well. Finally, she has a self-blame. She has a self-pity की माझ्याच मुलाला काय झालं, बाकीचे सगळे तर खेळतायत. Now, these hidden symptoms need to be addressed by all of us. She does not report them to you. And how do you do that? by counseling. And I think every session talked about counseling. Every session also talked about history is important. Okay. Then, of course, we built up on a lot of investigations, etc. But that session on mental health was excellent, and how people really can fool us. And it was said that 30% of our problems could be arising out of mind. What does that mean? We pediatricians have learned everything about body, but we have not learned anything about mind. And the human being has 40% mind that decides what you suffer from, but most important is mind is the only faculty that decides how you heal from a disease. If you have a strong mind and a strong will, you will improve. And if that is not there, the best of the doctor, best of the diagnosis, best of the treatment is useless. And I think how mind is important, and therefore a mind of a patient is important for us to get a best outcome. And how do you treat the mind? By talking to him. Don't forget that patients don't care how much you know, but they want to know how much you care. Now, how do you give care? So you give care by two things. What patients need, and you give that, that is care. What do the patients need? Patients need time, and patients need communication and counseling. They want to talk to you. They want you to listen to you. And I realize that when you ask a patient when he walks in, "Kai hota hai kai?" Okay, and you are patiently listening. A patient listening shows the mother and the parents that you are empathetic. You are listening, not only you are hearing. Many foreign literature has shown that every doctor listens only for 3-4 minutes and stops them from talking. I have understood what is. Come on, let's examine. Patient listening is the first step of every physician that shows empathy. Then you start taking history. When you start taking history, it sets up a tone for communication. You ask a question, the parents answer, you ask another question, a communication is set up. Then you start physical examination, and that physical touch shows the emotional bonding between the doctor and the patient. And no virtual platform can do that. And when you counsel, the patients know that you are compassionate. So imagine an empathy, a communication, emotional bonding, and counseling. It sets up a tone for a half recovery straight off, even before you start your prescription. And I think that mental thing was very, very important. But the last session was most interesting. And we could see the interest generated. Almost everybody talked because we did not know what to do. But I'm sure I realized that the best way to do is how not to get into legal trouble. And for that, you don't need a lot of legal knowledge. You need just a common sense and dedication and commitment. And what does that mean? You communicate, you counsel, you write down documentation. Gangulia said that, all that. Unless we document, and when you document, somebody reads, then if you have not explained, he would ask you questions. So communication, counseling, and documentation are the only 3 ways of avoiding any legal problems. Whatever you do, and demonstrate honesty, demonstrate your commitment, demonstrate that you are responsible, accountable. And I can tell you that one of the very honest, competent physicians in this city, the mother came and told me that her child has fever for 4 days, and she asked me whether it is a multiple myeloma. I said, even I have to scratch my head. I have not seen a multiple myeloma in a child. I asked her, why are you saying that? She said, I had a similar kind of fever, and I went to the so-called best competent doctor, but he missed the diagnosis. Finally, somebody got the diagnosis. And she mentioned, I'm going to take him to the court. I was concerned because I know that person, competent, really absolutely committed, and he could have missed the diagnosis. I felt bad. Why is she taking token? But I did not want to say anything lest it would appear that I was kind of trying to side him. I kept quiet. 3 months later, she came with her child for some other reason, and I was itching to ask her, "Kai झालं काय त्याचं?" But I said, no, let me not ask her. But she came out on her own. You know what she said? She said, "Doctor, you remember last time I had told you I will go and take him to the court? So I decided to go and confront with him." So she went and said that, "Doctor, look at this report. Okay, you missed it." The doctor looked at it. He just bowed his down. He hit his hand over the desk and he said, "Madam, I missed it." That's all he said. Okay. She just kept quiet. She came out. She told me she had tears in her eyes. That this man is so honest. He did not defend his mistake. He just said that, "Madam, I missed it." I realized honesty mostly pays. Okay. So I will just end up by saying that every session was interesting. These people have done a wonderful job. I did not know that you are putting me into a little trouble and trying to test me, one, whether I can stay for 9 hours here. Okay. Second, whether I understand anything. And thank you very much.